Doctors, we are live.
A very good morning to one and all. I would like to welcome all delegates warmly to the third day of this academic extravaganza, Appec 21. I'm sure that all you had enjoyed the storming session with us over the weekend, and we sincerely hope you enjoy the day ahead. So let us now proceed with today's first session, which will be chaired by Dr. Hemlata Kamath. I welcome Dr. Professor Hemlata Kamath, who is professor in Pramukh Swami Medical College, Gujarat, and her area of interest is difficult airway, medical education, pediatric anesthesia, and cardiopulmonary resuscitation. Welcome, ma'am. Over to you, ma'am.
Yeah. Thank you, Dr. Shivpriya, for that introduction. A very good morning to all the faculties and dear students. I'm indeed privileged to be a part of this PG meet, which has been very meticulously planned by the organizers, and I wish to congratulate them on my behalf. And it is indeed not just a very good experience for the postgraduates appearing for the exams, but a very enriching experience to the faculties as well. Since I've been attending some of the sessions in the last 2 days, I'm finding it very interesting as a faculty also. So my heartiest congratulations to the organizers and thanks for giving me the opportunity to be a part of it. Today's session, the first lecture for today is by Dr. Dhirja Sharma. She will be talking on the topic audit in anesthesia. Now this topic is very important from the point of view of the postgraduates as well, because many of the Indian hospitals are now going for accreditation of hospitals, and quality control is a very important part of it. Hence, I wish to tell the residents that though this seems to be a very theoretical topic from exam point of view, it is very important for them to be involved in the quality control processes, which they soon will have to do as being a part of the hospital practice protocols. And anesthesia audits, though not very commonplace in India, in many of the hospitals, are gaining popularity because of these accreditation processes, which is going to be a sort of compulsory in the coming years. So I wish to learn more from Madam also, and I welcome you, Madam, to start the topic. Dr. Dhirja Sharma, Madam,
Yes,
she's a...
Please start the video.
Good morning, everybody. Today, I will be talking about clinical audit in anesthesia. Anesthesia is the first medical specialty to champion the cause of patient safety by specially focusing on it. Anesthesiologists have been at the forefront of medical record keeping and also improving clinical care through this review. So much so that in 1950s, the mortality due to anesthesia used to be somewhere in the range of 1 to 2 per 10,000, and now it is less than 1 per million. All thanks to our diligent improvement in clinical care by reviewing what we had been doing. This, in essence, is clinical audit. As budding anesthesiologist, you must understand the importance of clinical audit in anesthesia and also learn how to do a clinical audit yourself to improve your own clinical practice as well as patient care. So at the end of today's session, I expect that all of us would know that what is clinical audit, what are the components of a clinical audit, how to conduct clinical audit, and all of you should be able to give examples of clinical audit in anesthesia. I hope that when this class finishes, you may be having 10 or more examples of clinical audit that you would like to conduct in your own department, hospital, or area of clinical practice. What exactly is clinical audit? So the first definition which was used in NHS said that the clinical audit is a systematic critical analysis of quality of healthcare, including the procedures used for diagnosis, treatment and care, the use of resources and the resulting outcome and quality of life for patients. It embraces the work of all healthcare professionals. The National Institute of Clinical Excellence gives a definition which is now the most widely accepted definition of clinical audit. So a clinical audit is actually a quality improvement process. Please note it's a quality improvement process that seeks to improve patient care and outcomes through systemic review of care against explicit criteria and the implementation of change. So in this definition, aspects of structure, process, and outcome of care are selected and systematically evaluated against explicit criteria. Where indicated, changes are implemented at an individual team or service level, and further monitoring is used to confirm improvement in healthcare delivery. What are the types of clinical audit which can be done? Basically, there are 4 types. Standard-based audits. This is an audit done against specific standards, and we see if those standards are met. For example, the ASA standards. The easiest example we can take is the ESA grading. So we can do an audit to see that the patient have been classified in the pre-anesthetic checkup as per the ASA grading or not. The second type of clinical audit are adverse or critical incident related audit. So this audit is done when an adverse or a critical incident occurs. For this, screening and monitoring of such events is a must. And in subsequent slides, I will be talking about the practice in our hospital regarding this. The third audit is peer review, where the quality of care is checked by the peers. It is often multidisciplinary and may occur after a mortality or a grave event. The fourth type is patient survey. Basically, in this, the patient view of quality of service is seen. So the typical example may be the patient satisfaction with anesthesia services, the patient satisfaction with OP services, patient satisfaction with pain clinic services, etc. What is actually the steps of process of clinical audit? The first step is to identify the problem or the issue that we want to do an audit for. After that, we set the criteria and standards for the audit, following which we observe the practice and collect the data in the area where we are auditing. After which we compare the performance of that area with the standard that we have chosen for auditing. And last of all, we implement the changes which we have found out after doing the audit. These are the 5 main steps of process of clinical audit. What are the prerequisites for an audit? Good record keeping system is the first prerequisite. Fair and impartial professional is an important part of a good audit. If there is bias in the auditor, then the audit would not throw up the true picture. Therefore, it is very important that whoever goes for the audit goes with a fair and impartial professional mind, should not have their own views. The audit should be done against the specific set standard criteria, not as per the ideas, personal ideas of the auditor. The data should be anonymized. We should not be able to trace it back to a clinician or to a particular patient. The initiative for clinical audit should come from within the team. Till the time the team doesn't own the process of audit, the outcome of audit will be poor. Because even though the audit findings may suggest some suggestions, till the team is not part of it, they may not implement those suggestions. So it's very important that the initiative for clinical audit should come from within. The purpose should be clear and simple, and intention should be to effect change and nothing else. What is the difference between clinical audit and research? Research is something which all of you must have done as part of your studentship. But the clinical audit is the final stage. It can be the final stage of a good clinical research program. Research can identify areas for audit, and the audit assists with dissemination of evidence-based practice. That is where with audit we can actually see that the good practice has been implemented or not, or which are the areas in which there is lack enough for implementing the good practices, which may be a result of clinical research which has been done. Now let's consider what can be audited. So quality of healthcare provided can be audited by examining any of the following healthcare delivery components: structure of healthcare delivery, process of healthcare delivery, and outcome of healthcare delivery can be audited. What do we mean by structure of healthcare delivery? In this, we can look at the resources required, the number of staff and skill mix, organizational arrangements, physical shape, the infrastructure, provision of equipment. A typical example for such an audit can be number of emergency laparotomies which are attended by consultant. This refers to the resources required. We can also do an audit of what are the level of staff nurses training, what is the level of resident training which is available at night for doing cesarean. We can pick up and do an audit on how many emergency OTs are available round the clock 24 hours. We can do an audit and look at what is the availability of basic monitoring anesthesia equipment in different operation theaters. So these are the different examples for doing structure of healthcare delivery audit. The process of healthcare delivery audit is the commonest clinical audit. Most of the clinical audits which are carried out fall into the process category. They can be audits which are done for actions and decisions taken by practitioners. For example, if there is a particular fasting duration which is being told for the patient, we can audit against this standard. For example, in pediatric patient, whether it's 4 hours, 6 hours, 8 hours, 2 hours, depending upon the age of the patient, and against a particular guideline, we can audit the clinical practice in a particular department. Then we can audit the process of communication. We can audit the consent taken, whether the consents are informed consents, whether they have been given by the along with the patient by the consultant, etc. Third can be assessment, in which all the different audits we can do for pre-anesthetic assessment, assessment of blood loss, etc., etc. Education is an important audit. We can audit, for example, in a patient who's a case of COAD undergoing laparotomy. We can audit if those patients have been told pre-operatively for post-operative lung maneuver exercises. Investigations, very easy. We can audit, for example, if how many diabetic patients have a pre-operative morning sugars and electrolytes and urine examination. Just an example. Documentation is an audit which is very popular in anesthesia, in which we can see if all the patient charts have complete intraoperative documentation, if all the charts have complete, say, pulse oximetry documentation, any kind of documentation. Then therapeutic interventions are also some of the clinical audit which can be done. So these process audits are the one which have the maximum number of clinical audits occurring in anesthesia. Finally, we come to the outcome of healthcare delivery audits, in which basically we can audit for measure of physical and behavioral response. For example, how many patients have post-operative nausea and vomiting in a particular clinical unit, or after a particular type of anesthesia, or after a particular type of surgery. Then reported health status. So we can do an audit on pain care and pain relief in a patient in post-operative period. We could audit the ambulation and the duration after which the patient could be ambulated. We could audit the patient, say for laparoscopic cholecystectomy, how fast or how um, um, fast they could take orally after the surgery. So post-operative period of nil per oral can be audited. Then level of knowledge can be audited for the patient as well as for the caregivers, and patient satisfaction forms an important outcome audit criteria. Along with patient satisfaction, now there is increased focus on patient related outcome measures. So the patient tells, suppose we are doing, we have given a patient a block. So the patient can report that how fast he was able to go back to normal activity, say after a hernia surgery, because of the type of pain, a multimodal pain analgesia, which was provided to the patient. So these are different examples of outcome related clinical audits and anesthesia, which can be done. How do we do an audit? So basically, first of all, we have to define what is the aim. Why are we doing the audit? Once we know why we are doing the audit, then we will define what is the objective. When we do this audit, what do we think we will achieve? And to achieve that, what is the standard statement? What is exactly that will we need to audit? So let's take it up in a little more detail. AIM should define what is the topic of audit and where improvement is desired. It should further be qualified by objectives and standards. So as an illustration and an example, I'm going to pick up this as an aim to optimize clinical condition of patient before routine surgery. And then for rest of the PPG, rest of the class, I will be building upon this aim only. So let's see what are the objectives we want to optimize clinical condition of patient before routine surgery. So the objective would be to ensure that patients have PAC before scheduled surgery. That is our objective of this audit. And then to have achieved that objective, what is the standard statement? So for the standard statement, there are two parts of the standard statement. First should talk about the criterion, and second should talk about the target that we want to audit against. The criteria again has two parts: the statement which is being measured and the yardstick. Yardstick is what is being measured. So when we are doing an audit to improve the or to optimize the patient before a scheduled surgery, and we want to achieve the objective to ensure that patient have PAC before scheduled surgery, then the standard statement should be that 95% of patient will have outpatient based PAC before scheduled surgery. This is the standard statement for the audit. We are going to audit the department and the clinical care of department against this statement. Statement of what is being measured is patient will have OP based PAC. So what are we going to measure in the department clinical care? We will measure how many patients have OP based PAC. And who will be these patients? What is the yardstick? These will be the patients who have scheduled surgery. So obviously we are excluding emergency surgery patients. And what is the target that we are looking for? We are saying that 90%, 95% patients should have OP based PAC. So this is how we will write objectives and standards of a clinical audit. How to develop good standards? We should refer to the guidelines and protocols. The standard should be measurable. They should be set before the audit is commenced, and the target should be set at realistic level for defined patient group and local circumstances. The sample size and data collection is typically what we do even for other research products. So the sample size will depend upon size of population, degree of accuracy required, degree of confidence required, The data collection can be quantitative and qualitative. It can be either prospective or retrospective, depending upon the type of clinical audit that we have picked up. And there should be great clarity before we commence on audit on who will collect the data. That responsibility should be well defined. So, making and sustaining improvements. The audit report after it finished should be well written. The opportunity for improvement should be listed clearly. The organization-wide changes should be started. The change should be measured to improve and it should be sustained. So there should be periodic measurement of improvements that had been suggested as part of the audit. This is very important because at the beginning of the lecture, I had talked about how continual improvement is now the main part of NICE definition of clinical audit. So there should be earlier when we had started doing clinical audit, people used to do just one transactional audit. It used to be a one-time audit and just see how where we are and that's it. But now no clinical audit is complete without doing a sustained improvement as a result of that clinical audit. This is a very important aspect to remember. A small comment on clinical pathways. What are clinical pathways? These are multidisciplinary management tools based on evidence-based practice for a specific group of patients with a predictable clinical course in which different tasks or interventions by the professionals involved in patient care are defined, optimized, and sequenced either by the hour. So, for example, in an emergency department, or by the day, for example, in acute care, or visit, say, for example, in home care. So, typically, this encompasses the patient's total journey from admission to discharge and even beyond, say, at home. So, the outcomes are tied to specific intervention. A very good example of a clinical pathway is the clinical care pathway for knee arthroplasty. So this would involve the orthopedics department, the anesthesia department, the physiotherapy department, and the physician. So to have a patient coming out with the most optimal clinical care, all these four departments and many more in smaller parts would need to intervene at specific points with specific actions to give the patient the best result. So in a way, it is an amalgamation of small clinical care interventions, clinic result of clinic audit that we can make a good clinical pathway. So this is the example of a trigger tool that we use in our hospitals. After each surgery, the anesthesiologist who's carried out the procedure ticks on this anesthesia trigger list. So you can see that there are some triggers which are interoperative and there are some triggers which are there in the post-operative period. And if any of the triggers comes out positive, then that acts as a start point for clinical audit. For example, there is a conversion from epidural to GA in a patient. So that's one consideration. That's one trigger. If suppose in that unit there have been 5 to 6 such cases by the spinal and epidural got regional anesthesia got converted into GA, then we need to do a clinical audit of that particular specific area and that particular specific intervention to see against a standard what are the points where improvement can be done. Similarly, in the post-operative area, if suppose the patient has unscheduled admission to the surgical ICU, or the patient has intubation or reintubation post-operative period, those are very specific triggers for clinical audit. So this is, like I had told you much earlier in the slide, that when we are doing incident-based audits, we need to have a continual surveillance. So this is a trigger list which is maintained for each and every patient, each and every episode of anesthesia. And then it is reviewed to look for triggers of anesthesia which are positive, and clinical audits from that are then carried out, and the improvement whichever whatever are suggested as a result of those audit are then used to improve the clinical care of the department. So these are some of the useful resources you can refer to for studying further on clinical audit in anesthesia. All the best to all of you. And my last message is do or do not, but there is no try.
Thank you, madam. That was a wonderful topic, well covered, I would say, because you had covered right from the definition of clinical audit to what are the types and how do we go about doing the audit in the 5 steps, identifying the problem and selecting the topic, looking at the criterions which has to be met, and then collecting the data and then bringing about the change, which is the most important step of an audit to improve in the clinical outcomes. And I particularly liked the slide where you mentioned the trigger tools, where in a department you can identify on what topic you can do an audit. So I think it's a very good idea to incorporate that trigger tool in the anesthesia records, where each anesthetist from the department can take the sort of identified problem and undertake an audit on it to improve the outcomes in that department. And I think as the medical postgraduates are exposed to research, it is equally important for them to know about audits, because these are the primary source for the research topics which are going to be more relevant for their research, which they undertake. So I think all the medical students, the postgraduates especially, should be encouraged to undertake a clinical audit in the departments, and the faculty should promote that, because in the Western world, it's sort of a mandatory thing for the students, even the undergraduates, to undertake clinical audits, which prepare them for research later on. So I think this was a very important topic from that point of view for the students. And I wish the students do take interest in the clinical audits and bring about effectiveness in their practices in terms of quality improvement and even better patient satisfaction, which is gaining so much of importance these days. So I thank you, madam, for a wonderful talk, explicitly given, very well explained. And I don't know if there are any questions in the chat box. Dr. Shivpriya?
Uh, till now, there are no questions, ma'am. Thank you so much, Dr. Dheerja, for wonderful talk. I would like to brief, like first 2 days, we will be having extempo quiz at the tea time. Responses to be typed in the chat box, and the first 2 correct answers will receive gift vouchers. And I'll just like to brief that queries entered in the chat box related to that session will also be addressed by the respective faculty. So if anybody has any questions, they can type in the chat box.
There are no questions, Dr. Chipriya. We can go ahead.
Okay.
So I just before you go ahead, I'd like to thank Dr. Hemlata ma'am. Thank you so much for your kind words. And I'll just like to add that audit should be something that we should all start. So it can start, it can be done at each departmental level, and it can be in fact initiated from it. The quality, as we say, is top driven. So it can be initiated from the bosses like you from the department. Thank you so much. And thank you, Shipra. And thank you, Dr. Kakkar also. Thank you so much.
Thank you, madam. Can we go ahead with the next talk?
Yes, ma'am.
Okay, our next speaker for today is Dr. Vivek Gupta. He's a consultant cardiac anesthesia and intensive care specialist. He's affiliated with Hero DMC Heart Institute, Ludhiana. His areas of interest are ECMO, renal transplant therapies in ICU, hemodynamic monitoring, and transesophageal echocardiography, as well as quality in ICU. I welcome you, sir. He is going to talk on valvular heart diseases in anesthesia practice.
Good morning, everybody. First of all, I'm thankful to Dr. Akhilesh for giving this opportunity to me to discuss an important topic of valvular heart disease. What are the anesthetic concerns on this forum? So, if we talk about the valvular heart disease, first of all, we need to understand the heart has four valves, and all four valves share the common characteristic that there is always a one-way flow. The blood is flowing forward. And if there is an obstruction, then we call it as a stenotic lesion. And when there is a backward flow, when the valve is leaking, then we call it as a regurgitant flow. So if we talk any of these uh, valvular heart disease, this is basically an abnormality on the ventricular loading. This can be either a volume overload or it can be a pressure overload. This all depends which valve is involved and what kind of a lesion is this. So ultimately what happens when a patient develops a valvular heart disease, ultimately it leads to a hemodynamic burden on the left ventricle or right ventricle. In the initial phases, a patient tolerates it well or compensates it well by these overloads, by gradual dilatations of the chambers, or increasing the pressure of the chambers. But once these compensatory mechanisms start failing, then a patient will develop a myocardial dysfunction, or they will develop a congestive heart failure. There will be precipitation of arrhythmias, or there can be sudden death. So when we, as an anesthesiologist, when we try to manage these patients, the principle of management actually moves around certain parameters. What is the heart rate and what the heart rate should be in this particular valvular lesion? Or what is the rhythm? Can we maintain the normal sinus rhythm in this patient? Or can we avoid change in the rhythm? What is the preload? What is the afterload? How is the myocardial protectivity and how our drugs, our surgical stress, our procedure is going to affect it? What's the systemic blood pressure? And what is the systemic and pulmonary vascular resistance? These are not just the numbers. This we, as an anesthesiologist, we need to understand. Because if we just try to follow the numbers or treat the numbers, probably we will not be able to achieve an appropriate anesthetic management. So a thorough preoperative evaluation and the trend is probably more important as compared to the individual number. So what we are going to discuss here, we'll be talking about the different valvular lesion, stenotic and regurgitation. We'll talk that what are the presentation of these patients, how we can encounter, what is the pathophysiology, what exactly happens when these kind of lesions are present, and how it is important for us as an anesthesiologist that during anesthesia management, during induction or maintenance of anesthesia in the post-operative period, how these lesions are going to affect our management. And I'll be talking about a bit about the prosthetic valve also, how to manage these patients when they are coming for the non-cardiac surgery. Just to remind you about these NYHA functional classification, we all know class 1, no limitation of the physical activity, and patient will not have any fatigue or palpitation or dyspnea. And class 4, gradually it is worsening, and in class 4, a person is unable to carry out any physical activity without discomfort. And even he can have a symptoms at the rest as well. So how we assess the physical finding? What are the things we need to assess in these patients? So the most important, a clinical examination, we see the pulmonary rails, crepitations. If you look at the JVP, you'll find that it's a raised. In the long-standing cases, you will see the hepatosplenomegaly, or you will see the hepatojugular reflex is positive, or in the dependent part, patient will have edema. If it's a bedridden patient, it's a sacral edema, or it's a moving patient, then patient can have a feeder edema. And you have to assess these patients to find that which valvular lesion actually this patient is having predominant. So you will look for the murmur characteristic. What type of murmur is this? Whether it's in the systole or it's in the diastole, which area, which will tell us that whether it's a mitral valve involvement or it's a tricuspid involvement or it's the aortic involvement, and what is the grade and what's the intensity. Along with that, it is very important to look for any neurological deficit, because these patients most of the time may have atrial fibrillation and can develop the thromboembolic events. The investigation, in general, we can talk, but it should be tailored according to the patient and what procedure we are actually performing. So ECG, which is the baseline, one must have ECG, because that will give you an idea what is the rate, what is the rhythm, whether it's a sinus rhythm, there is atrial fibrillation, flutter, or some other ventricular topics are there. So it will give you a good idea about the rhythm. You can identify is there is a signs of coronary ischemia, there is ST depression, if it is there, in which area, so that you can see that it's the anterior wall, lateral wall, or inferior wall. And if there is any ventricular hypertrophy with the left or right ventricular hypertrophy. The X-ray test will give you a good idea about the cardiac size by looking at the CT ratio. You can see the presence of pulmonary venous congestion by looking at the Coley V lines, and in general, you are by assessing the chest X. Echocardiography, again, it's must. It will give you the chamber dimensions and the valve areas. It will give you, tell you about the transvalvular gradients, what is the regurgitation fraction, what exactly is the ejection fraction, and is there any regional wall motion abnormality suggestive of any ischemia or underlying infarction. And if patient is having a prosthetic valve, then it will give you an idea, is there any paraprosthetic leak, or there is some vegetation on this showing that infective endocarditis, and what is the transvalvular gradient. Cardiac catheterization is not required routinely, but in some patient, if they are having a coexisting coronary artery disease, or you are suspecting that coronary artery disease, then definitely they must undergo cardiac catheterization. This will give you an idea that what is the severity of the stenosis or regurgitation. It can tell you about the intracardiac shunts, and if there is a clinical and echo discrepancy, which can be identified in the cardiac catheterization. Besides this, most of these patients are the diuretics, ACE inhibitors. So electrolyte, potassium levels are must. Renal function you should assess, because disease itself can cause a low cardiac output state, and patient can have a compromised renal function. Coagulation abnormality, because most of these patients on the anticoagulants. And ABG, if patient is having a significant pulmonary symptoms, then the preoperatively we must have a baseline blood gases. If we talk in terms of prophylaxis, infective endocarditis prophylaxis, then the class has been defined by AHA, the high risk and high risk to moderate risk and low risk. So if the high risk, if the patient is having a prosthetic valve, or there's a history of infective endocarditis, or they have this complex cyanotic congenital heart disease, or there is a surgical correction of the systemic or pulmonary shunts, or there is a valve repair history, our patients are having a mitral valve prolapse with the regurgitation, and we are seeing the thickened leaflet on echocardiography, then these are the high-risk patients who should be having an infective endocarditis prophylaxis. The low-risk category, where there is a isolated ASDs or a small ASD, VSD, and PTA, which has been corrected surgically or percutaneously, are patients having MVP, but there is no thickened mitral valve leaflet, or the murmur is physiological, In those conditions, the prophylaxis is not recommended. So we take valvular lesion one by one. First of all, I'll address aortic stenosis. Aortic stenosis usually, if we look at with the increasing age and older age populations are coming for the procedures, this is basically because of degeneration and calcification of the aortic leaflet, and this leads to subsequent stenosis. Our patient is having a congenitally bicuspid aortic valve rather than tricuspid aortic valve, and they are more prone to develop aortic stenosis. If you go by age-wise, the elderly population will have a degeneration and calcification. The young adult to middle age, there can be a calcification or fibrosis of congenitally bicuspid aortic valve. At some time, along with the mitral valve, there can be a rheumatic aortic stenosis as well. And if it's a infant, children, or adolescent, they will have the more of the congenital aortic stenosis because of subvalvular membrane or supravalvular membrane. So if you look at the pathophysiology, we know that it's a normal aortic valve area is 2.5 to 3.5. And when the transvalvular gradient moves beyond 50, or there's the aortic valve area goes less than 0.8 centimeter square, we call it as severe aortic stenosis. So basically, when there is a obstruction to the ejection of blood into aorta because of decrease in the aortic valve area, it means the left ventricle has to put more effort to eject blood to the aorta. And this is what the aortic stenosis is. Most of the time, aortic stenosis is associated with some degree of aortic regurgitation as well. So if you look at this, there is a narrowing of the aortic valve. This will lead to a two things. One, there is a left ventricular hypertrophy because the ventricle has to work more, and there is a compression of the coronary artery. Once there is a left ventricular hypertrophy, the coronaries will start getting compromised, which will decrease the oxygen supply, and patient will develop a myocardial ischemia without having the coronary artery disease. So they will have the complaint of chest pain. Again, this left ventricular hypertrophy will increase the myocardial oxygen requirement as well. So the supply and demand balance will disrupt, and this will lead to chest pain. Again, there is a decreased cardiac output, and there is an incomplete emptying of the left atrium because there is a regurgitation in the left ventricle, so it is always filled. So there will be a pulmonary congestion, and there may be right-sided heart failure. So how these patient presents? Mild to moderate cases, usually they are asymptomatic, and when we do a preoperative evaluation, it is an incidental finding when you are auscultating these patients. So this is very, very important because even with the moderate disease, patient may remain asymptomatic. Usually, when the preload reserves are exhausted, then these patients develop angina, syncopal attack, and they can have the exertional dyspnea. And as the patient develops symptoms, their chances of survival gradually reduces to 5 year, 3 year, and 2 years. They can have the sudden death, and there can be an episodes of acute pulmonary edema to these patients. If you look at the physical findings, the slow rising carotid pulse and the pulse pressure will be narrow. Because of the LV pressure overload, there can be a heaving at speed, and when we auscultate the aortic area, we can have the ejection systolic murmur, and when the patient is developing a pulmonary venous congestion or pulmonary edema, we can find the creps at the basis. If you look at the ECG, you will find in the long-standing cases left ventricular hypertrophy. In the chest X-ray, you will find ascending aortic dilatation, and the echocardiography and Doppler will give an idea about the aortic valve area and about the severity of the aortic stenosis by looking at the transvalvular pressure gradient, myocardial thickening, valvular thickening, calcification, how the leaflets are mobile, whether it's a bicuspid or tricuspid valve, and how much is the systolic or diastolic dysfunction. So if you look at the severity, from mild, moderate, severe, and critical, the mild aortic stenosis will have the mean pressure gradient less than 25, and when the valve area is more than 1.5. When the further valve area decreases to 1 to 1.5, the pressure gradient increases from 25 to 40, it's the moderate. When pressure gradient is around 50 and valve area is 0.7 to 1, it is the severe aortic stenosis. And the critical stenosis where the valve area is less than 0.7 and mean pressure gradient goes beyond 50. So what option we have? Asymptomatic patients, they are usually on the medical management. If the patient is symptomatic, then these patients may require aortic valve replacement. At some time, along with that, they develop a coronary artery disease and the dual procedure, both aortic valve replacement along with the CVG may be required. If it's an adolescent or young adult with a congenital, there can be a percutaneous aortic balloon valvulotomy can be tried. Nowadays, for the older age population where the aortic valve replacement is not possible, then TAVI is a good option, though it's a very costly procedure. How we plan anesthesia or what is the basic principle? We need to understand that aortic stenosis is a fixed cardiac output state where the LV is hypertrophied and it's a very sensitive to ischemia. So any drop in the blood pressure or any loss of normal sinus rhythm will decrease the cardiac output and destabilize your patient. So what is important for us whenever we are managing in the perioperative period, try to maintain the normal sinus rhythm and avoid any kind of bradycardia. Bradycardia is absolutely not tolerated. To some extent, tachycardia is accepted, but again, if a significant tachycardia is there, then possibly the myocardial oxygen demand will go up and patient will destabilize. So avoid any hypotension and optimize intravascular fluid volume so that you are maintaining a good venous return with the left ventricular filling. So what is important? There should be a good preload, there should be a normal sinus rhythm, and hypotension should be avoided. Always try to maintain the normal sinus rhythm. So adequate preload, and if there is any hypotension in the intraoperative period, phenylephrine is a very good choice. It's a direct acting alpha agonist which improves the blood pressure by increasing the systemic vascular resistance, because you can understand very well it's a fixed flow state when there is a severe aortic stenosis. So any drug which is increasing the contractility will not help because the valve is fixed. So we need to improve the blood pressure by increasing the systemic vascular resistance, and this is what exactly the phenylephrine does. Any arrhythmia, because if patient is not having a normal sinus rhythm, what will happen? Suppose there is atrial fibrillation. So immediately the atrial kick will be lost and cardiac output will decrease by 15 to 20%. So any arrhythmia should be treated aggressively. Vasopressor is a good option, though adequate preload in the pre-operative before induction of anesthesia is very, very important. Inotropes are indicated only when you see that there is a signs of myocardial ischemia, there is ST depression and there is a myocardial ischemia in spite of adequate fluid resuscitation as well as using the alpha agonist. Vasodilators are strictly avoided in these patients. So whenever we are planning for anesthesia, the preferred one is the general anesthesia, and we use etomidate, opioid, midazolam, ketamine. We all know that should be avoided because it will cause tachycardia and will require the increase the oxygen demand. Hyperpentone, it reduces the preload, so one should be very careful while using the hyperpentone in these patients. Propofol again decreases cardiac output and can cause hypotension. For maintaining anesthesia, it's a combination of nitrous oxide and volatile anesthetics and opioids. Fentanyl or sufentanil can be used for maintenance of anesthesia, and neuromuscular blocking drugs with a minimum hemodynamic effect. Means we can use a rocuronium in these patients, which has the minimum hemodynamic alteration. Coming on the aortic regurgitation, again, it can be a congenital or it can be acquired. Usually associated with other rheumatic disease, rheumatic valve involvement. The congenital can be because of bicuspid valve. Acquired can be because of trauma, aortic dilatation because of Marfan syndrome or a dissection of aneurysm, syphilis, or ankylosing spondylitis. So what exactly happens in the aortic regurgitation? Basically, there is a decrease in cardiac output because once the LV is ejecting blood in the aorta, a part of blood is ejected back into the left ventricle during the diastole. So there is a both volume and pressure overload on the left ventricle. So how much will be the regurgitant volume? It will depend upon the several factors. It depends on the time for the regurgitant flow to occur, which is determined by the heart rate, pressure gradient across the aortic valve, because if pressure is high, the regurgitant fraction will be more, and it will depend on the systemic vascular resistance. So if we want to decrease the aortic regurgitation magnitude, or we want to reduce the aortic regurgitation fraction, there should be slight tachycardia and there should be slight peripheral vasodilatation, so that it will improve the forward flow and the tachycardia will not allow emptying of the blood back to the left ventricle. So ultimately, when this happens, the left ventricle compensates by developing a hypertrophy and enlarging so that it can accommodate the larger volume. And because there is an increased oxygen requirement and there is a decrease in the aortic diastolic pressure, so that leads to a reduction in the coronary blood flow. So angina pectoris can happen in these patients without coronary artery disease. So how these patients present? Usually mild to moderate aortic regurgitation, they are asymptomatic, or they complain of some palpitation. Severe aortic regurgitation patients, they complain of breathlessness and angina. You all remember the signs of aortic, these pulses in the aortic regurgitation. They are the collapsing pulse. We can have a dancing carotids, femoral bruise, and capillary pulsation on the bed, bounding peripheral pulses. When we auscultate, we get a diastolic, early diastolic murmur, and we can have the Austin Flint murmur as well. The other sign that there is a displaced apex beat because of the volume overload and the dilatation, chamber dilatation, or we can have a fourth heart sound and crepitation when patient is developing a failure. When we assess the severity, we compare the regurgitant jet width as a percentage of LVOT width. So left ventricular output tract width with the regurgitant jet width. If it is 25 to 46%, it is a mild. 47 to 64% is moderate, and if it is a more than 65%, it is a severe category aortic regurgitation. Similarly, we can have the regurgitant jet area as compared to the LVOT area, and if it is ranging from 4 to 24, it's a mild. 25 to 59 is a moderate, and if it's above 60, it is a severe aortic regurgitation. Asymptomatic patient normally require medical therapy by reducing the afterload medications using the vasodilators, nephadipine, ACE inhibitors, or hydrogen. Surgical correction is required in those patients where aortic valve repair or replacement can be done. Or if a patient has developed aortic dissection, then probably root replacement is required in these patients. So what we as an anesthetist, we should remember, avoid bradycardia in these patients. So try to maintain fit tachycardia with maintaining normal sinus rhythm, adequate reloading in these patients, and minimize any myocardial depression, and a high to normal systemic vascular resistance, because if you are keeping a too high systemic vascular resistance, then the regurgitation fraction will go up. If the patient is stable, for anesthesia induction, we can use intermediate or sodium thiopentone. High-dose narcotics with the benzodiazepines can also be an alternative. But if a patient is critically ill and having an acute AR, which is not yet compensated well, then these patients may require inotropic and vasodilatory support even before the induction of anesthesia. For maintaining, if there is a severe LV dysfunction, we can use the volatile anesthetic agent with or without opioids. And we should remember that the combination of high-dose narcotics can cause bradycardia and can have the myocardial depression. So we can use the pyroluria as a muscle relaxant, which will help in increasing the heart rate. And if there is any bradycardia or there is a hemodynamic instability, then that should be aggressively treated with using atropine. Ephedrine is not a good choice in these patients because it increases the afterload and can decrease the forward flow so that the regurgitation fraction will increase. If there is no severe hypotension, then possibly it does not require a treatment with the vasopressors. And these patients tolerate a regional technique well. If justified, we can use the regional techniques in these patients. Coming on the another very important lesion, mitral stenosis. It is almost always in our countries is a rheumatic in origin. However, in the elderly, we can, due to the heavy calcification, we can have a mitral stenosis. Rarely it can happen because of congenital or because of rheumatoid arthritis or mucopolysaccharidosis, or sometimes the prosthetic valve which has stenosis, which has there's a transmural gradient has increased and they have developed a mitral stenosis. So basically, if you say primarily it affects the females, there may be a diffuse thickening of the leaflet and subvalvular apparatus, and ultimately there is a fusion of the commissures and the calcification of the annulus as well as the leaflet. This process occurs very slowly, and for next 20-30 years, patient may be asymptomatic after the rheumatic fever. Over a period of time, what happens? The mitral valve becomes stenotic. In the initial phases, the LA pressure gradually increases, which leads to increase in the pulmonary vascular resistance. Patient develops a pulmonary hypertension, or gradually the right ventricular hypertrophy, a tricuspid regurgitation, and right heart failure can develop. But if at any point of time, a patient suddenly develops atrial fibrillation due to the LA dilatation, there can be a precipitation of pulmonary edema. So the mitral valve normally is a bigger one, 4 to 6 centimeters square. And when we talk about the mitral stenosis, it is basically a mechanical obstruction to the left ventricular filling. And ultimately, gradually keep increasing, and the mitral valve orifices keep the size of the mitral valve orifices decreases. The valvular obstruction ultimately leads to an increase in the left atrial volume as well as the pressure. So LA starts dilating. With a mild mitral stenosis, usually the left ventricular filling and stroke volume is well maintained at the rest position, but at the cost of increasing the LA pressure. And usually these patients do not become symptomatic until the mitral valve area has come down to 1.5 centimeters. Gradually, the LA keep increasing, LA pressure keep increasing, and there is an increase in the pulmonary venous pressure. And ultimately, this leads to a transudation of fluid in the pulmonary interstitial compartment, which decreases the pulmonary compliance, and there is an increased work of breathing, and ultimately patient present with a dyspnea. So what are the various clinical features? Patient is breathless and having cough because of pulmonary congestion. Patient shows complaints of fatigue because they have the low cardiac output state. Edema develops once the right heart failure is there, then patient will develop edema in the dependent part and ascites. Because of atrial fibrillation, they will keep complaining of palpitation. And once the pulmonary congestion is increasing, patient can present with the hemopsis. And because of pulmonary hypertension, they can have the chest pain. And if because of atrial fibrillation and they have the left atrial appendage clot, there may be a thromboembolic event, and that can lead to a stroke or ischemia in the left. These patients, if you look at these patients, they can have the mitral phases, means there is a flushing on the cheeks because of severe mitral stenosis. You can get the irregular pulse. That's because of atrial fibrillation. Patient can have the right ventricular heave and loud P2. While auscultating, we can get the opening snap and mid-diastolic murmur with perisystolic accentuation. And when you auscultate these patients, they can have the bilateral capitations and they can have effusion on extra chest. So ECG will show a tall peak P wave, but that's a P mitral, and in lead 2, upright in V1, we can have the right axis deviation and right ventricular hypertrophy if there is a severe pulmonary arterial hypertension. X-ray will show a straightening of the left heart border. You can have the curly B lines on the X-ray chest and posterior displacement of the esophagus if there is an enlarged left atrium. The echocardiography will help in assessing the anatomy of the mitral valve with the degree of how much is the leaflet is thickened, how much is the calcification, what is the mobility, and how much is the subvalvular apparatus, what is the status of the subvalvular apparatus. The severity can be assessed by calculating the mitral valve area and looking at the transvalvular gradient, and we can assess the cardiac chambers, pulmonary hypertension, and function of the left and right ventricles, and any other valvular disease. Left atrial appendage should be seen for any thrombus because that can be a source for thromboembolic event in these patients. The severity, mild, moderate, and severe. If the PA pressure is above 50, it is a severe one, and valve area is going less than 1, it is a severe mitral stenosis. The minor symptoms, we do the medical management using the diuretics, which decreases the pulmonary congestion, beta blocker and digoxins and calcium channel blocker just to control the ventricular rate to in the atrial fibrillation, anticoagulants where there is a risk of thromboembolic event, and if the patient is having infective endocarditis, antibiotic prophylaxis indicated. Surgically, if there are severe symptoms and patient has developed symptomatic even after the medical management, there can be a balloon valvuloplasty, mitral valvulotomy, or mitral valve replacement is required. What is required from our side when we are managing these patients with a mitral stenosis for non-cardiac surgery? Basically, we need to maintain the adequate diastolic filling time. So, avoid any tachycardia and treat any arrhythmia aggressively in the perioperative period. Though we need to optimize the preload, but one should be very, very sure that we are not overloading these patients that will lead to pulmonary vascular congestion and precipitate the pulmonary edema and compromise the gas exchange in these patients. Any factors, hypercarbia, hypoxia, metabolic acidosis should be avoided because that will lead to a pulmonary vasoconstriction and will compromise the right ventricular function. Coronary perfusion pressure has to be maintained, so myocardial contractility should be maintained throughout the period. If patient is having a sinus rhythm, then try to maintain the sinus rhythm, and afterload should be also be maintained to maintain the hemodynamics. So during pre-operative period, it is important that we avoid any anxiety which can lead to a tachycardia. So a low dose of opioids or benzodiazepines as a pre-medication, but one should remember that we have to avoid over-sedation. Otherwise, there can be a hypoventilation and patient can taste carbon dioxide and hypercapnia may be there. Hypercapnia may be there. Drugs which are used for the heart rate control should be continued till the date of surgery. One has to be careful for any hypokalemia that should be managed preoperatively because these patients are on diuretics. Anticoagulation management we'll be discussing very shortly, but should be continued for minor surgery. For major surgery or for the regional techniques, we need to discontinue anticoagulants, and then appropriate anticoagulant management is needed in these patients using heparin. Ketamine should be avoided because it increases the heart rate. Intubation and muscle relaxation with using the rocuronium or vicuronium because they are cardiostable drugs. Avoid any drug which causes histamine release, avoiding the muscle relaxant which can cause the histamine release. Short-acting beta blocker can be used for the rate control. Anesthesia should be maintained with the nitrous oxide and low concentration of volatile anesthetics along with the opioids. The nitrous oxide can cause increase the pulmonary hypertension. So in cases where there is a severe pulmonary hypertension, nitrous oxide should be avoided. Reversal, again, while using reversing these patients with a neurovascular blockade, one should avoid drugs which are causing tachycardia. So anticholinergics, while using, one should be very, very careful. And titration of intraoperative fluid is very important in this patient. One should avoid any kind of a fluid overload in these patients. Monitoring for a routine patients, there is no problem. A routine monitoring for a asymptomatic patient, routine monitoring is fine. But if a patient is having a symptomatic mitral stenosis and undergoing major surgery, then you need to have an invasive artery pressure monitoring, central venous pressure monitoring. If you have a facility of transesophageal echocardiography, that is very important for perioperative management. PA catheters should be avoided because it's of no benefit. In fact, if the patient is having a severe pulmonary hypertension, inflating the balloon can lead to a PA rupture while wedging these. Blood gases are important in the perioperative period to manage the ventilatory parameters. Post-operatively, there is a risk of pulmonary edema and RV failure. So avoid pain, hypoventilation, any respiratory acidosis or hypoxemia. Continue invasive monitoring in the post-operative period, and appropriate pain relief is important using the opioids intravenously or some neuroaxial technique. These patients, sometimes they have the pulmonary congestion, and so they may require ventilatory support for some time if they have an increased work of breathing. Coming on the mitral regurgitation, it can be of rheumatic origin. There can be because of mitral valve prolapse, or there may be some coronary artery disease or dilated cardiomyopathy where there can be dilatation of LV and the mitral valve ring, or because of rheumatic heart disease, there may be a rupture, valve cus damage or body rupture, or even with the myocardial infarction, there can be ischemia infarction of the papillary muscle, and there may be a papillary muscle rupture, and there can be a acute mitral regurgitation. So there can be acute or chronic mitral regurgitation. Acute mitral regurgitation, they are not well tolerated. They happen suddenly because of body rupture in patients of the acute coronary event or myocardial infarction, and they suddenly develop the pulmonary edema because LA does not tolerate that much of volume. So if we talk about the pathophysiology, the basic hemodynamic derangement is basically decrease in the forward flow from the left ventricle, stroke volume and cardiac volume. So every time when LV is contracting, a small amount of stroke volume is coming back to the left atrium, and there is a volume overload of the left atrium, and ultimately there can be a pulmonary congestion. Patient with a regurgitant fraction, if it is a more than 0.6, they are considered as a severe mitral regurgitation. The fraction of left ventricular stroke volume and regurgitate into the left atrium, it will depends on several factors that will depend on the size of the mitral valve. What is the size of the mitral valve? What is the heart rate? Because that determines the duration of ventricular ejection. If the patient is slight tachycardic, ejection, this regurgitant fraction will be less, and the pressure gradient across the mitral valve. So again, it depends on the compliance and impedance of the left ventricular ejection into the aorta as well. So any pharmacological intervention which increases or decreases the systemic vesicle resistance will have the significant impact on the fraction of mitral regurgitation. How these patient presents? These patients will be dyspneic because of pulmonary venous congestion. They complain the fatigue because of low cardiac output, palpitation because of atrial fibrillation, and they can have edema and ascites. When we examine them, they have the irregular pulse because of atrial fibrillation. They can have the pansystolic murmur and Appec, and they can have the signs of pulmonary venous congestion, means bilateral basal crepitations, they can have effusion, and pulmonary hypertension and right heart failure. ECG shows the left atrial hypertrophy with the left ventricular hypertrophy. The chest X-ray will show enlarged LA at LV. There will be signs of pulmonary venous congestion and Crowley-B lines. Echo will show a dilated LA at LV, and there you can identify the structural abnormality of the mitral valve. And with the help of Doppler, we can quantify the extent of regurgitation. Cardiac catheterization usually not required, but if you are suspecting some coronary artery disease, then definitely yes, and that will give us a guide about the mitral regurgitation, pulmonary hypertension, and coronary artery disease. The severity can be assessed with the regurgitant volume, fraction, and looking at the regurgitant orifice area. If the volume is 30 to 40, it's mild, and above 60, it is severe. If the regurgitant fraction is 10 to 30, it is a mild, and up to 50, it is moderate, and above 55 is severe. If the regurgitant orifice area is less than 0.2, it is the mild, and if it is more than 0.4, it is the severe mitral regurgitation. So the medical management is with the using diuretics, vasodilator, digoxin for atrial fibrillation, anticoagulant if a patient is having atrial fibrillation, and patient may need a infected hepatitis prophylaxis. Surgically, either valvuloplasty using the rings or mitral valve replacement. So what is our goal in anesthetic management? The first thing is we need to maintain the forward systemic flow and we should try to reduce the regurgitant fraction. So try to keep the heart rate towards the high normal around 100 beats per minute. Any bradycardia needs to be avoided. We should try to maintain the sinus rhythm and slightly increases preload. If you maintain a higher preload, it will increase the regurgitant fraction. And if you keep the low preload, it will decrease the cardiac output. So an optimal fluid balance is very, very important in these patients. Uh, so after load, that needs to be reduced. A bit low after load will improve the forward cardiac output. So you should avoid any sudden increase in the systemic vascular resistance and try to maintain the contractility, because if there is any myocardial depression, it will decrease the left ventricular ejection. So when we are inducing these patients, IV induction agent, dose should be adjusted to prevent any increase in the SVR and any decrease in the heart rate. Pancuronium, which increases the heart rate modestly, can be used in these patients. Maintenance with a volatile anesthetic agent, but remember, if the myocardium is severely compromised, opioid-based anesthetics are preferred. Ventilation should be adjusted so that acid base and respiratory parameters are fine. And what is important here, the pattern of ventilation is very important. You should give adequate, sufficient time to the expiration to maintain the sufficient venous return. Otherwise, it will decrease the cardiac output if the venous return is decreased. Mitral valve prolapse, again, by definition, it's a prolapse of one or both mitral leaflet in the left atrium during systole with or without mitral regurgitation. So it is one of the most common form of valvular heart disease, common in young women. It may be anatomical or functional. Functional, when we say, when they say it looks normal, everything looks fine, it is just a mild bowing. But it's anatomical when there is a rupture, redundant or thickened leaflet, or especially in the connective tissue disease or in the elderly male. The patient presents with anxiety, palpitation, dyspnea, fatigue, atypical chest pain, and they show some cardiac dysarrhythmia as well. Older people with an anatomical mitral valve prolapse can have the mild to moderate congestive heart failure. That is seen by exercise intolerance, or they complain orthopnea if you take a proper history from them, or dyspnea on exertion. So these patients are prone for developing a cerebral events, embolic events, infective endocarditis, or they develop the severe MR during surgery, or there can be arrhythmia and sudden death. So if there is a functional disease, there's no problem. But if they are with a significant mitral regurgitation, beta blockers should be used to control the dysrhythmia, and that should be continued throughout the perioperative period. And anticoagulants are important in these patients. So what we need to avoid any increased sympathetic activity or sudden drop in the systemic vascular resistance, and avoid any hypovolemia in these patients. Most of these mitral valve prolapse patients, they have the normal LV function. They tolerate both general and regional anesthesia. Normally, volatile anesthetic agents are beneficial because they depress the myocardium and decreases the chances of regurgitant fraction. Regional anesthesia, they maintain the adequate intravascular volume to prevent any fall in the systemic vascular resistance. So intravenous induction agent avoids significant and prolonged drop in the systemic vascular resistance. So intermediate is a good choice of induction as an induction agent. Ketamine should be best avoided. Maintenance of anesthesia using the isoflurane or desflurane, muscle relaxant using the vecuronium or pancuronium, and appropriate fluid balance, and if needed, alpha agonist as a phenylephrine is acceptable to maintain the hemodynamics in these patients. Invasive monitoring is required only in the patient who have a significant mitral valve prolapse or having the LV dysfunction. Complication, always keep in mind, they can have the ventricular dysrhythmias during the procedure, so treat it aggressively using the beta blocker or lidocaine. Right-sided lesion, tricuspid stenosis, which is rare and usually associated with the mitral stenosis. There's a back pressure in the right atrium, so the patient will present with venous congestion, hepatic enlargement, and ascites. The medical management requires salt restriction, digitalization, and use of diuretics. They may require valvuloplasty or valve replacement. As an anesthetist for the non-cardiac surgery, if the patient are presenting with a tricuspid stenosis, our goal should be maintaining the preload and controlling the heart rate. Tricuspid regurgitation, usually it is a function, and it is caused by the annular dilatation secondary to the RV enlargement because of pulmonary hypertension. Other causes may be infective endocarditis, trauma, or abstain anomaly. It is well tolerated in most of the patients until they have the severe pulmonary hypertension. In moderate to severe tricuspid regurgitation, they may require tricuspid annuloplasty. We should keep in mind that nitrous oxide can increase the tricuspid regurgitation by increasing the pulmonary hypertension. These patients may require dobutamine, isoproterenol to dilate the pulmonary vasculature to reduce the fraction of tricuspid regurgitation. Just some words about the prosthetic valve. You know that the prosthetic valves are bioprosthetic and mechanical. The bioprosthetic one, they have the low thrombogenic potential, do not require systemic anticoagulation, though aspirin is recommended when a patient is having a bioprosthetic valve. Mechanical valve, they are long lasting, but they require lifelong warfarin therapy. So whenever you are coming across with a patient who is having a prosthetic valve and coming for the surgery, non-cardiac surgery, a thorough history and examination is important. You should know that what type of valve has been inserted and on what anticoagulation patient is. You auscultate. If it's a mechanical valve, you will find a high-pitched, crisp opening and closing sound. Bioprosthetic valve, usually they do not have any special characteristic. If you find any new onset murmur or change in the quality of the murmur, you should suspect a valve endocarditis or there is some problem with the valve. So anticoagulation management, it is important if there is a low risk of thrombosis, means if the patient has undergone aortic valve replacement where we require just targeting 1.5 to 2 of the INR, the warfarin may be stopped and we can bring down the INR to 1.5, and after surgery we can always restart it after 24 hours. But if there is a high risk of thrombosis, means if the mitral valve patient is with a mitral valve replacement, or even with the aortic valve, our patient is having any other risk factor like infective endocarditis, in those we need to stop warfarin 48 to 72 hours prior. We should start unfractionated heparin once the INR falls below 2, and this should be stopped 4 to 6 hours prior to surgery. And after surgery, once the we have the low risk of bleeding, the warfarin can be restarted and heparin can be continued till the time INR has reached to the therapeutic level what we are targeting with the warfarin. So to conclude, a thorough evaluation of the valvular lesion is very, very important because with the increasing elderly population, we may be caught with surprise on operation table if we do not do a thorough assessment of these patients. So always auscultate your patient well. If you have a suspicion, always evaluate them thoroughly so that you can find out the severity of cardiac disease, what is the degree of impaired myocardial contractility because of the valvular lesion, or if it is leading to some other major organ disease along with the valvular lesion. On what therapy a patient is and what is the impact. If a patient is on diuretics, you must know that what is potassium, patient is on ACE inhibitors, what is the renal function. This all you should have list of the current drug therapy. Prepare these patients well if there is no emergency. And your plan for anesthesia should be as per the pathophysiology of that particular valvular lesion. Invasive monitoring is required in moderate to severe cases, and one should be very, very careful for managing post-operative with these patients, adequate fluid balance, hemodynamic optimization, and adequate pain relief in the post-operative period. Thank you very much. If you have any question, I'll be happy to answer.
Thank you, sir. That was a very well explained topic, especially the commonly faced valvular heart lesions. And you have very you have explained very well the pathophysiology, which is so important to understand to handle any such cases during elective as well as emergency situations. And I think the understanding of pathophysiology is the mainstay of these valvular heart lesions in order to achieve your hemodynamic goals during your anesthetic management and entire perioperative period per se. Very well described, sir, all the common lesions. And when you touched on the prosthetic valves and the need for giving the anticoagulants and titrating them during the perioperative period, I think there are a few questions in the, I think you already answered one of them regarding the thrombo history taking in the perioperative. One question was how to rule out the thromboembolic events in mitral stenosis while taking the history.
Yes, ma'am. Good morning,
You
ma'am.
have already answered it, yeah.
Yeah, but possibly the participant have not seen. This is the message I have got.
Yeah.
I'll just speak once again.
Yeah.
While taking the history, one should ask, do you have any weakness of any limb or one side? Or you have undergone any surgery? You had some blockage in your vessel? Because most of the time, doctor tell them that you have a blockage in the vessel. Or you had any blackout in the past? Any history of blackout? Or you have fallen because of this just dizziness. So these history will give us a good idea that probably they had some thromboembolic event.
Yes, and there's one more question. In patients with aortic stenosis with left ventricular dysfunction, hypovolemic patient for emergency surgeries, what is the choice between whether we should go for an opioid only induction with fentanyl or etomidate?
I'll prefer etomidate in these patients. Side by side, I'll go for the preload optimization along with the etomidate.
Okay. I think that answers the questions. No more questions I can see in the chat box. Oh, one more is there. Should warfarin be discontinued 5 days prior to surgery?
Yes, warfarin, it depends on what surgery we are planning. And warfarin, depending on the surgery, how much bleeding we are expecting, then it should be switched over to the, we have to bring it down INR to around 1.5 to 2. And we should start with the heparin infusion. And that should be discontinued 4 to 6 hours prior to surgery. And once the surgery is over, then we can, once we assess the bleeding and there's no major bleeding, then we can restart the heparin. And from next day onwards, we can switch over again to the heparin.
Yeah, thank you, sir. Thank you for explaining everything in so much detail, especially the pathophysiology, which is the mainstay of this valvular heart lesions. And I think if there are no questions, further questions, we can go to the next topic.
Thank you, ma'am.
Thank you, sir.
Thank you, ma'am. Thanks a lot.
Our next speaker is Dr. Sanjula Virmani. She is a director professor, J.B. Pant Institute of Postgraduate Medical Education and Research. Her area of interest is cardiac anesthesia. And today her topic is congenital heart diseases, concerns in anesthesia practice. Over to you, madam.
Good morning, everybody. In a patient with congenital heart disease presenting for non-cardiac surgery, the anesthetic implications they are based on three things. One, the nature of congenital heart disease. Secondly, the degree of cardiopulmonary impairment, and most importantly, the type of surgical procedure. So if the surgery is elective or it is less urgent and the cardiac disease is severe enough to require a surgical correction, for example, if a patient is presenting for elective hernia repair and has severe pulmonary stenosis, perform the pulmonary valvotomy first before taking up the patient for the elective surgery. If, on the other hand, if the cardiac surgery or the intervention procedure is not indicated, for example, if the pulmonary stenosis is not very severe, the patient can be optimized with medical management before cardiac surgery is undertaken with risk stratification. Now, if the surgery is of emergent nature, for example, if the patient of tetralogy is coming to you for drainage of an abscess, then the surgery should be undertaken with high or intermediate risk. But even if it is an emergency surgery, it does give us a couple of hours in order to optimize the medical condition. For example, we can correct the acidosis, we can correct the electrolytes, and we can even perform a phlebotomy in order to improve the microcirculation. The anesthetic implications can be best understood if you have a very clear knowledge about the pathophysiology of congenital heart disease, and most importantly of the shunt lesions, left to right shunts and right to left shunt, because shunt lesions are the most commonly encountered congenital heart diseases. We have already seen that the fetal circulation is a parallel circulation in which the oxygenated blood flows from the placenta via the ductus venosus into the inferior vena cava into the right atrium. From there it gets deflected by the crista dividens into the left atrium and then is ejected into the left ventricle, and from there it comes into the aorta. Now the desaturated blood from the SVC flows into the RA, from there it goes into the RV and the PA, but because of the very high PVR, little blood enters the PA, most of it gets shunted through the ductus into the descending aorta. Now after birth, there occurs an increase in the SPR, there occurs a decrease in PVR because of lung expansion, change in arterial oxygen tension, and because of the action of certain vasoactive mediators. In the absence of congenital heart disease, a transitional period of fetal parallel circulation is transformed into the normal series circulation. The pulmonary artery pressure equals the systemic pressure immediately before birth. Immediately after birth, as ductus closes and the lungs begin breathing air, the PA pressure decreases rapidly to half of the systemic levels. Thereafter, there occurs a gradual decrease over weeks to reach the adult levels, with the result that normal PA hemodynamics is achieved. And the normal mean pulmonary artery pressure is less than 25 millimeters of mercury at rest, and if it occurs it increases to more than 25 millimeters of mercury at rest or more than 30 millimeters with exercise, it is known as pulmonary artery hypertension. At birth, both the RV and the LV are approximately equal in size and wall thickness. The increase in LV pressure leads to thickening of the ventricular wall over the first 2 years of life. This diagram illustrates the normal pressure and the saturation in various cardiac chambers. The blood on the right side is desaturated and reaches the left side after oxygenation in the lungs. The PFO and the ductus, they close, which maintains the normal physiology. Now, intracardiac shunts are the most common cardiac lesions which are seen in congenital heart disease. So the congenital heart disease is broadly classified into acyanotic and cyanotic congenital heart disease, with or without the presence of a communication or shunt between the chambers which are normally separate. In cyanotic heart disease, the blood flow across the shunt is from right to left and may be bidirectional, as seen in tetralogy, TGA, tricuspid atresia, and whereas in the left to right shunt, such as in cases of VSD, AST, PDA, the shunt is from left to right. In patients with congenital PS, AS, coarctation of aorta, no shunting is present. So shunting means there's normal systemic and pulmonary circulations are separate, and a simple shunt is said to exist if a direct communication exists between various chambers or between chambers and vessels. A complex shunt is said to exist when the associated with simple shunt is associated with an obstructive lesion. We'll first see the pathophysiology of left to right shunts in patients who have ASD, VSD, PDA, because these are most commonly seen congenital heart diseases which come for non-cardiac surgery. So this figure shows some of the commonly occurring left to right shunting of blood at various levels. And in patients who have left to right shunting of blood, there is seen a step up in saturation from SVC to PA. Now, left to right shunting of blood causes increase in the pulmonary blood flow, leading to an increase in the precapillary vascular obstructive changes, increase in resistance to blood flow, leading to pulmonary artery hypertension. Now, if this condition remains uncorrected, the pulmonary artery hypertension becomes unresponsive to pulmonary vasodilators. Ultimately, the pulmonary vascular resistance becomes so high that the shunt reverses and becomes right to left, a clinical setting which is known as Eisenmenger's syndrome. Now, clinically, on auscultation, patient with VSD will have a harsh, long systolic crescendo-decrescendo murmur, best heard along the left sternal border. P2 may be palpable and loud with narrow split. In ASD, the patient will have a wide, split and fixed second sound with soft ejection systolic murmur. And in PDA, there will be a machinery continuous murmur will be heard. A 12-lead ECG is recommended, and it may reveal right bundle branch block, right axis deviation as a consequence of atrial and ventricular enlargement. X-ray chest will relieve features of increased pulmonary circulation, chamber enlargement, which is specific to the type of lesion. For example, this is an X-ray of a 31-year-old woman with ostium secundum ASD. Pulmonary hypercirculation can be seen. There is increase in size of RA, RV, main pulmonary artery. And this is a patient of VSD. Here you can see that there is pulmonary overcirculation. There is an enlarged LA, and there is but normal or the caliber of aortic arch. In PDA, there is a pulmonary overcirculation, enlarged LA, and prominent aortic arch. If Eisenmenger develops, then there will be relative pruning of the peripheral vessels. This is an echocardiography picture of a patient with VSD. Here you can see that this is a aortic valve in longitudinal axis of the aortic valve at 120 degrees. This is the aortic valve. This is a subaortic VSD with left to right shunting of blood across it. Let us move on to the right to left shunt, which have decreased pulmonary blood flow. This slide shows the commonly encountered cyanotic heart diseases. Most commonly seen is tetralogy, tricuspid atresia, Epstein's anomaly, TGA. These are less commonly encountered diseases. Now, to understand the pathophysiology of a cyanotic heart disease, we have to understand the shunting. We've already seen that a complex shunt is one in which a simple shunt is associated with an obstructive lesion. This is the obstructive lesion which is present at the right ventricular outflow tract. This will lead to an increase in the right ventricular pressure, and this will cause a shunt to increase from right to left. If the RVOT obstruction is dynamic, as occurs in case of tetralogy, which may occur because it might increase because of sympathetic overactivity, the right to left shunting of blood increases. And this is the reason for the hypercyanotic spell, which is seen in tetralogy of Fallot. This is one of the most common cyanotic lesions. There occurs a VSD. Then there is an RVOT obstruction like pulmonary stenosis, which may be valvular or infundibular, overriding of the aorta, and right ventricular hypertrophy. Now, due to predominant right to left shunting, there is desaturation of blood, and since the obstruction is dynamic, this shunt fraction can change. This is the net result. This is a picture of echocardiography picture of a patient with tetralogy. And this is the longitudinal axis of the aorta at around 120 degrees. Here you can see that there is a mosaic pattern here which shows that there is pulmonary stenosis. That is right ventricular outflow tract obstruction. There's a small VSD here. There's overriding of the aorta and right ventricular hypertrophy. Now the net result of right to left shunting of blood is there results hypoxia, congestive cardiac failure, and coagulation abnormalities. Hypoxia is the root cause of all the problems. It leads to polycythemia, increase in blood volume, vasodilatation, alveolar hyperventilation, and chronic respiratory alkalosis. All these adaptive mechanisms lead to coagulation abnormalities, increase in vascular resistance, and they impair the global ventricular function. Chronic hypoxia causes polycythemia. which leads to peripheral sludging of blood. And this causes an increase in the intravascular stasis and thrombosis, followed by a state of hyperfibrinolysis due to decreased clotting factors and decrease in the number of functional platelets. The vitamin K dependent coagulation factors also decrease, such as factor 2, 5, 7, and 9. This occurs because of hepatic dysfunction secondary to cardiac failure. Now, the coagulation abnormalities can be corrected by replacement of coagulation factors, correction of anemia, phlebotomy in order to improve the microcirculation, and also we can add administration of vitamin K. Now let us come to the anesthetic management of congenital heart disease. We will first see the anesthetic management of patients who have left to right shunt, followed by patients in whom there is right to left shunt. A preoperative assessment and pre-medication will be similar in both types of shunt cases. A good pre-operative assessment is essential in order to determine the physiological status of the patient. This should include recording of height, weight, and a thorough physical examination, and all current medication that the patient is receiving. Blood investigations such as hemoglobin, coagulation profile, renal function test, liver function test, blood grouping should be done. A physical examination should include blood pressure in all extremities, baseline oxygen saturation in all limbs, and the effect on oxygen saturation due to exercise. Edema, cyanosis, murmur, crackles, all should be taken note of. Investigations such as X-ray chest, recent echocardiography, MRI reports should be reviewed. And if the patient is receiving any pulmonary artery hypertension reducing drugs, they should be continued perioperatively. Pre-medication, a good pre-medication is very important. It reduces anxiety. It makes parental separation easy, especially in case of children. It also reduces the catecholamine release, and it helps in smooth induction. It also reduces the chances of hypercyanotic spells in patients who have tetralogy. Hypoventilation, hypercarbia should be avoided. Pulse oximetry should be monitored after pre-medication. The choice of drugs includes midazolam 0.5 mg per kg orally or 0.05 to 0.2 mg per kg intravenously. Triclofos can be given orally in a dose of 50 to 70 mg per kg body weight. Ketamine 1 to 2 mg per kg IV or 5 mg per kg orally if there is no IV access. In managing patients of left to right shunt lesions, we know that the patients are prone to develop URI, and this should be treated adequately before surgery. That means the patient should be maximally decongested before taking up the patient for any kind of surgery. The preoperative fasting time should be minimized and adequate hydration should be ensured. In small children, there are psychosocial considerations and they should be discussed with the parents. The risk of paradoxical hair embolism should not be forgotten. Care should be taken to de-air the lines properly. Now, endocarditis prophylaxis should be undertaken as per the institutional protocols. Most patients with left to right shunt tolerate surgery and anesthesia well, unless pulmonary artery hypertension is present. The anesthetic goal is directed towards decreasing the shunt flow, maintaining the cardiovascular respiratory stability, and providing adequate tissue perfusion and oxygenation. And while following all these goals, we have to minimize the left to right shunting, and this to minimize the left to right shunting, we have to decrease the SVR, maintain adequate preload, avoid any increase in pulmonary artery pressures such as hypoxia, hypercarbia, acidosis, and if there is presence of pulmonary artery hypertension, pulmonary vasodilators can be used. In the wake of pulmonary artery hypertension, a good level of sedation and analgesia is necessary. We have to avoid hypercarbia, hypothermia, acidosis, use pulmonary vasodilators like nitroglycerin, nitroprusside, prostaglandin, sildenafil. Nitrous oxide should be avoided, and we should consider elective postoperative ventilation. A few words about Eisenmenger syndrome. We've already seen that in the pathophysiology of left to right shunt, how shunt reversal can occur due to suprasystemic pulmonary artery pressure and long-standing pulmonary artery hypertension. This is generally seen with ventricular level shunts, and the patient may present with central cyanosis, dyspnea, fatigue, hemoptysis, syncope, right-sided heart failure. And pulmonary vasodilators should be used in symptomatic patients. Now, fixed pulmonary vascular resistance, it precludes rapid adaptation to perioperative hemodynamic changes, and changes in SVR are mirrored by changes in the intracardiac shunting. So any decrease in SVR will be accompanied by any increase in right to left shunting and decrease in the systemic saturation. Now, general anesthesia is generally used because of the hemodynamic maneuverability is better with general anesthesia, and it should be the preferred technique. However, regional anesthesia too has been used successfully, but the local anesthetic should be delivered slowly in incremental doses with close monitoring of the blood pressure and saturation. Currently, the pulmonary vasodilators which have been approved belong to 4 classes: phosphodiesterase 5 inhibitors such as sildenafil, endothelin, receptor antagonists like bosentan, prostacyclin like iloprost, and all these can be used for in the presence of pulmonary artery hypertension. Surgery should not be performed if the PA systolic pressure is more than 2/3 of the systemic, or if the pulmonary vascular resistance is more than 2/3 of the systemic, or there is a net right to left shunt in the wake of lesions which are predominantly with left to right shunting of blood. Now let us come to the anesthetic goals that are seen in patients with left to right shunt lesions. The patient should be pain-free and asleep. There should be maintenance of hemodynamics, and we have to minimize the right to left shunting by avoiding any sudden decrease in SVR or increase in PVR, avoiding any adrenergic surges, and if it does occur, then we can use beta blockers like esmolol. All intravenous agents can be safely used. Morphine, fentanyl, midazolam, because all of these will cause decrease in SVR. So it is not the type of the drug, it is the rate and the dose which is administered which is more important than the drug itself. They should be given in small incremental doses with careful monitoring of the blood pressure and the saturation. Inhalational induction can also be used. Sevoflurane, halothane can be used, but it may prolong because of the right to left shunting, but this is rarely a problem clinically. The need for invasive monitoring depends upon the nature of surgery and the underlying cardiac lesion. There should be no central lines in patients who have already got a cavopulmonary connection such as Fontaine or Glen. Arterial pressure on the contralateral side should be used in patients who have a BT shunt existing, and we should be aware that capnography will underread the PaCO2 in the presence of right to left shunt. T can be used in order to aid in the hemodynamic management. In the presence of a hypercyanotic spell, if it occurs intraoperatively, this can occur because of the presence of dynamic RVOT obstruction, and this may increase due to any decrease in SVR or because of decrease in the systemic arterial pressure. So if this does occur, then we have to give beta blockers like metoprolol, esmolol, and we can also give a small dose of noradrenaline in order to increase the SVR. So this to end all the details that we have studied till now. This is a cardiac grid which you can find in any of the standard textbooks, and it summarizes the pathophysiologic goals, which is choice of anesthetic drugs that can be used to achieve the goals that we have just covered. So pregnancy in heart disease is a separate lecture because of the implications. In the presence of congenital heart disease, the patients are counseled against becoming pregnant because there is a high chance of complications with abortion rates of around 43%, PPH 50%, arrhythmias 29%, and heart failure can occur, especially between 23 to 30 weeks and at the time of delivery. So delivery has been safely conducted using neuraxial catheters, but because of easy maneuverability of hemodynamics, general anesthesia is preferred. Thank you.
Thank you, madam. That was a very comprehensive description of all the congenital heart diseases coming for anesthesia. And though it is a complex topic to be covered in a short time, you have done quite a justice to it, I must say. And
Dr. Hemlata, ma'am?
yeah. Hello? Hello?
Yes, ma'am.
Am I audible?
Now you are audible, ma'am.
Okay. Thank you, Dr. Virmani, madam, for a very comprehensive talk on the subject, which is quite vast to be covered in a matter of 45 minutes or so. You have covered very aptly all the regions and given a brief overview of the pathophysiology as well as the considerations during anesthesia. And I think the students have got a grip of it, especially the last table that you showed gives a summary of all the lesions with the pathophysiology so that we can attain the hemodynamic goals during the perioperative period and have a safe conduct. There are no questions in the question box, chat box yet.
One question is there, ma'am.
One question is there. That was for the previous session, right?
Yeah, that's for the previous patient.
Yeah,
Bridging therapy, somebody is asking about the bridging therapy for stopping warfarin.
Yeah.
Thank you, Hemlata ma'am. Thanks a lot for the encouraging words. And I prepared the lecture keeping in mind that it is targeted towards the PGs and what they would, the kind of problems they would encounter while conducting such a patient. Because we are not going in for a cardiac surgery. We're going in for the surgery may be, the surgery may be an emergency, it may be a semi-emergency. So depending upon the situation, as I said right in the beginning of my talk, that it depends upon three things. One is the type of surgery. Secondly, the degree of pulmonary impairment that the patient has, depending upon the pathophysiology, and the type, whether it is an emergency surgery or whether it is like you're taking elective surgery, and how much time you have in order to optimize the patient. So keeping that in mind, I kept it very short and simple, so that it's not very confusing.
One more thing, just madam, I want to ask you, because these patients commonly we encounter in the MRI, especially
exactly.
So would you give a brief listing on how to conduct these cases? Because those are very challenging, according to me, for the postgraduates.
So if the a patient of left to right shunt or right to left shunt, any patient with congenital heart disease comes for MRI, we generally get it done under ketamine. Ketamine anesthesia can be used because it is very difficult to take an IV access also for such small babies if they're coming for MRI. And you can just give ketamine 2 to 10 milligram intramuscularly. You can have monitor the saturation, and you'll have a calm child for MRI. You can keep the patient calm for at least 20-25 minutes. That is going to take.
Ketamine is a drug of choice.
Ketamine is the drug of choice.
My question was particularly in the oxygenation. Like they get scared looking at the SpO2 levels in these babies when they are taken for MRI.
It is very important that the saturation should be monitored at all levels. So and ketamine is very helpful. It keeps the patient calm. You do not need to worry too much about the spontaneous respiration is getting affected, and the child can be kept calm, and MRI can be conducted. So that is why I said ketamine should be given. But at the same time, you have to keep things ready in case of an emergency. Like one should always be ready with the intubation, with drugs which are necessary for resuscitation. These things have to be kept in mind, and plus pulse oximetry is very important.
So pulse oximetry reading, that is what scares the postgraduates. That was my question, because here how much oxygenation to be achieved? So usually when the baseline levels to be maintained, or should we go for more oxygenation levels, because these patients already are hypoxic. So that was the question.
So it all depends upon the degree of desaturation that the patient presents with. So the baseline is very important. And plus, if you avoid giving any kind of adrenergic surge, if the patient is calm, there is less chance that the patient will have a hypercyanotic spell. Basically, we have to avoid the hypercyanotic spell, which will give rise to more and more desaturation. So that has to be avoided. Keep the child a little warm. Allow the parent or somebody to be inside the suit if possible, because dissociation from the parents also causes them to become hyperactive. And that can again induce, because it gives an adrenergic surge, so it will give rise to increase in your obstruction, the degree of obstruction, because it is dynamic, and it will lead to desaturation. So all that can be avoided by taking care. And plus a pre-operative assessment is very important. The degree of the degree of desaturation, the degree of polycythemia that the patient has.
Yes.
That means the
So
hematocrit is
baseline-
also, yeah.
The baseline values
Baselines
are very important.
very
So they
important,
should
yeah.
look at the baseline rather than achieving for 100%
Yes.
SpO2 or something.
No, we
Yeah.
don't need that much.
Yeah,
They are
yeah.
used to desaturation.
Yes.
So they will maintain very well. Only thing is we have to avoid hypercyanotic spell in such patients.
Yes.
Further deterioration has to be avoided.
Thanks
That
a
is
lot,
why,
madam.
yeah, most welcome, ma'am.
Yeah.
And
that was
I
nice
hope,
lecture.
yeah, thank you so much.
Yeah.
Thank you so much, Dr. Sanjula ma'am, for such a wonderful presentation.
Thank
I'm
you.
sure delegates have benefited from this very well explained lecture.
Thank you so
Before
much.
going for a tea break, I want to display two MCQ questions. So answers you have to type in the chat box, and early two responders will get the prize. The time starts now.
Please share the screen, Dr. Shivpriya.
I'm already sharing.
It's not visible. Not visible.
TS. Yeah.
Just make it full screen, please. Yeah, good. Please show the slide again. Yes. So delegates, please type your answer in your chat box so that we can choose the fastest and the correctest one. So while the delegates are doing the quiz of these two questions, I would like to tell you in this time that the winners of all the quiz questions for yesterday. So Dr. Surbhi Sharma from Civil Hospital Jalandhar, she and Dr. Sarita from Paras Hospital. Surbhi and Dr. Sarita have won the quiz set 1. Dr. Sheetal from Maulana Azad Medical College and Dr. Lopamudra Panda from Odisha. They have won the second set of quiz questions. The third set of quiz questions was won by Dr. Hina Agarwal from UCMS GTB Hospital and Dr. Srikanth from RML Hospital. So congratulations to all the 6 winners. You will be shortly receiving the Domino's voucher on your phone. And regarding the Google form quiz, which was given in the end of the session, there are 2 winners and they will be receiving a refund of 2,000 rupees. So we need to ask them for their bank details, account numbers to be mailed to us. The first winner is Dr. Marina Thomas. She's from Lady Harding Medical College. And the second winner is Dr. Sarita. She is a DNB student from Paras Hospital. Congratulations, Dr. Marina and Dr. Sarita.
Oh, thank you so much, Dr. Hemlata ma'am. Thank you for your time.
Yeah, I'm also very thankful to you all to give me this opportunity. And it was a really nice experience. And thanks a lot to the whole team of organizers at RML Hospital, especially Dr. Abhishek. Thanks a lot.
Thank you, ma'am.
Sorry,
Thank you, ma'am.
Akhilesh, not Abhishek.
Yes.
Thank you.
Thank you, ma'am. Now we will have a short tea break and we will be back and resume our session at 10:30 sharp. Welcome back, delegates. Let us now proceed with our next live interactive session of case discussion. Shobit, can you show the CV slide? So our next case discussion, for that our external faculties, I would like to welcome Dr. Asha Tyagi. She is Director Professor in UCMS and GTB Hospital, and her area of interest is obstetric anesthesia and critical care. Internal faculty will be from RML Hospital. Next slide, please. Internal faculty will be Dr. Devang Bharti. He is Assistant Professor in ABVIMS and Dr. RML Hospital. His area of interest is difficult airway, obstetric anesthesia, and palliative care. The case will be presented by our third year PG resident, Dr. Srikanth. Over to you, Dr. Srikanth.
Shall I start, ma'am?
Dr. Shivpriya, please mute yourself and mute your laptop also.
Am I audible, Dr. Srikanth?
Yes, ma'am. Good
Right.
morning.
Morning. Let's start with your case presentation, please.
Yes, ma'am. Good morning to one and all present here. Myself, Srikanth, and I am presenting a case of 52-year-old male, Mr. Raman, who is a resident of Karnal from Haryana, presented with complaints of lower back pain for 6 months. History of presenting illness. Patient developed pain in lower back region 6 months. Nature, radiating to the back of the right thigh till right foot, aggravated with walking, relieved temporarily by lying down and taking medication. There was no diurnal variation. There was no history of tingling sensation, numbness, or weakness of legs. No history of weight loss and fever. No history of bladder incontinence. No history of other joint pain and morning stiffness. History of trauma. Past history. The patient gave a history of chest pain 9 months back, which was severe and sudden in onset, radiating to the left shoulder, arm, and neck, which lasted for 1 hour. It was crushing in nature, associated with nausea and vomiting. It increased on exertion and relieved slightly on rest. It does not change with posture. It was not associated with food intake, and pain is not aggravated while taking deep breaths. He was immediately taken to hospital, and after receiving medication, the pain decreased in intensity. He was conscious and well-oriented throughout the events. He underwent some procedure done through his groin area and was informed that the stent was placed. He was discharged after 1 day with medications prescribed. After that, there were no complaints of gabrat, chest pain, swelling in legs, breathlessness on exertion, or breathlessness while lying down, or air hunger at night causing sudden awakening. There was no history of diabetes or hypertension. Sir? Video sound, sir.
Sorry, any problems, Dr. Srikanth?
No, ma'am.
Okay.
So no history of diabetes or hypertension, no history of tuberculosis, jaundice.
I can't hear you, Dr. Srikanth.
Ma'am, so no history of diabetes, hypertension, no history of tuberculosis, no history of jaundice, seizure, asthma, or no history of known allergy or no history of surgery. Treatment history, patient is on some medication and he is not certain about what medication he is taking.
Right. Anything else?
Personal history.
Personal history. I think we could stop here and see the relevance of what you're trying to tell us. So you said whoever is the organizer, there I can hear a lot of voices, please. There's too much disturbance.
Please give us 1 second, ma'am.
Okay.
Yes, ma'am.
Yeah, that's much better, Dr. Srikanth. Okay. So we are going to simulate this case discussion much like an exam. That's the whole point of this assembly, I was made to believe. So usually in the exam, once you've presented your history midway through it, anywhere through it, or at the end of it, we would like you to rationalize what you've done. So
Yes,
Dr.
ma'am.
Srikanth, based on this back pain that you say your patient is having, which is radiating and which you said is not associated with any bladder bowel incontinence, what is the likely cause of this backache?
Ma'am, there might be any compression because of vertebral disc prolapse, or maybe some vertebrae compression, or maybe fusion of vertebrae.
Okay. Why did you take a history of trauma and weight loss and tuberculosis? What's the relevance?
Weight loss and fever, I asked for tuberculosis, ma'am. Either POTS pain also patient might present with lower back pain.
Okay.
In trauma may be a significant factor, ma'am. If patient had recent...
Usually POTS pain is commonest in which area? Is it lower backache?
Ma'am, yes, ma'am, lower backache also patient might present, ma'am.
Commonest site? In India, what have you witnessed? Most of the POTS pain is in which area when they come for surgical explorations to you?
Lower thoracic, ma'am.
Thoracic is more common, right? Lumbosacral is usually not that common. Okay, so let's assume based on your history that this is the pain because of a disc prolapse.
Yes, ma'am.
What's the likely surgery your patient will need?
Ma'am, laminectomy.
Okay, maybe single or multiple level laminectomy. Let's assume that this is going to be a multiple level laminectomy.
Okay, ma'am.
Now, you described a chest pain in your patient. You described its characteristics. And you said that there was no correlation with food intake. Why did you take that history?
Ma'am, gastric esophageal reflux, when those patient presenting also they also will give a history of chest pain kind of thing, ma'am.
Okay. Why did you look for a variation with respiration?
Ma'am, pleuritic pain, when patient takes deep inspiration, patient might have pain because of that. So he might also give chest pain.
Okay. And why with posture? Postural variation would have signified what?
Ma'am, pericarditis, ma'am. Patient with pericarditis, some involving pericardium. So patient leans forward, he might feel pain.
Okay. So since he had an absence of all of this, you are trying to convince me that this chest pain is cardiac in origin. Accepted, yes, right? Based on rest of the history of his whatever procedure and saying a stent that he had, most probably he suffered from what? This chest pain was because of?
Myocardial infarction.
So let's assume, so we are saying he had an MI, which is one of the ACS syndromes 9 months back, and presently he's stented. Okay. What kind of stents are usually being used in clinical practice?
Drug-eluting stents are used nowadays.
How many generations are you aware of?
2 generations, ma'am.
Okay. There are 4 generations now. Usually we are using which generation?
Ma'am, 2nd generation.
Okay. What do you mean by a drug-eluting stent?
Ma'am, the stent is coated with drug, ma'am. So it basically, when previously we used to put bare metal stent, it caused intimal hyperplasia. So there will be problem later on. So what they did to avoid that intimal hyperplasia, they coated with some drugs.
What does this drug do?
It prevents multiplication, prevents this hyperplasia of that area, ma'am.
How? So they are anti-proliferative agents, which stop these cells in which particular cell division phase? I'm sorry, I'm stumping Dr. Srikanth. The students were supposed to know the questions. I gave him a fair deal, but there are certain questions I did not tell because then it looks too rehearsed, and the way Viva proceeds, we couldn't have kind of shown the students, okay? So it is not always what you know. So which phase of mitosis is usually inhibited by which agent? Fine. What is the problem with putting in stents? Why did we progress to DES from bare metal stents?
Ma'am, I'm not able to.
Can you hear me? Why? What is the problem with putting in stents?
The restenosis, late thrombosis problems are there, ma'am.
Right. So restenosis is the problem. And what are the drugs these patients receive because they have a risk of restenosis and MI?
Ma'am, they might receive antiplatelet drugs to prevent that.
Okay. Single, double, triple?
Double. Usually dual antiplatelet drugs they will be
So
on.
dual antiplatelet, which two classes are typically chosen?
Thrombolytics.
Am I the only one who can't hear Dr. Shrika? Okay. So it's a thienopyridine derivative along with aspirin. That is what your patient is likely to be getting. Why did you take a history of breathlessness on lying down? What did you want to rule out?
Ma'am, I wanted to rule out orthopnea, ma'am. Any left ventricular failure patient. I wanted to rule out orthopnea, ma'am.
Why does it occur?
Ma'am, when patient lies down, there will be volume shift from interstitial to the vascular compartment. So patient will not be able to cope up with that volume. So there will be pulmonary congestion. Back pressure will be there in heart, which is transmitted to lungs as pulmonary congestion. So there will be stimulation of J receptors, and patient might feel he will feel dyspneic, ma'am. So
right. So there's a redistribution of blood flow. Any other reason of orthopnea besides the redistribution? One more reason. Why typically on lying down?
Compliance of the lungs also will reduce.
The FRC decreases. So it's a dual-edged sword for the patient. Both things are harmful. You also asked for air hunger. What did you want to rule out?
I want to rule out paroxysmal nocturnal dyspnea.
Okay. What's the difference in physiology of PND versus orthopnea? In PND, that means your patient has managed to sleep. He's lying down, he has managed to sleep, and then he's getting up from sleep. Why?
Ma'am, that will be in early stages, ma'am. PND. Patient will be able to lie down and sleep for at least 2 to 5 hours. After that, patient will feel, during sleep, there will be decreased sympathetic innervations to the ventricles, ma'am. So patient will feel, he will again get the same mechanism. So there will be pulmonary congestion. So same will happen. The patient will feel dyspneic.
Right,
So in order to...
So it is the sympathetic stimulus, which is an additional thing for PND, and it's in the earlier stages. That you're correct. Go on with rest of your history, please. Finish it off.
Yes, ma'am.
You would tell the personal history you were starting. You said no diabetes, no hypertension, no tuberculosis, jaundice.
Yes, ma'am. Personal history. He's a shopkeeper by occupation. He's a non-vegetarian by diet. He's a smoker for past 20 years. Who smokes half pack per day for the past 20 years and stopped before 9 months. Non-alcoholic. Bowel and bladder habits are normal. Normal sleep-wake cycle. Socioeconomic status. He belongs to a lower middle class. Family history. He was married for 20 years and has 2 children. He lives in a nuclear family. His father was hypertensive and died due to some heart-related ailments 5 years back. General physical examination. After getting consent from the patient was examined. Patient was conscious, oriented to time, place, and person. Patient has normal faces and he was moderate.
Wait, we will stop before you start the examination. Based on this history, whatever relevant positive and negative history you have, what is your clinical diagnosis at this moment? What are your differentials?
Ma'am, he's based on my history, patient is a known case of ischemic heart disease. Most probably post PTCA before 9 months. Currently, he is asymptomatic without any features of heart failure. He's come for some spine surgery.
Okay, fair enough. So
most probably laminectomy.
Okay. Based on this history, what is your relevant positive or negative examination that you want to tell me?
First, general examination, I will see the build of the patient, ma'am. Next, I will see pallor. Next, I will see any edema, or then next I will go for pulse rate of the patient. Pulse rate, and I'll rate rhythm, volume, character.
So how? What was this in your particular patient? Tell us the findings also.
My patient, yes, ma'am. My patient had a pulse rate of 68 beats per minute, ma'am. It was regular in rhythm. It was good in volume. It was normal character. No radial or radiofemoral delay. All peripheral pulses were felt and there was no arterial wall abnormality.
Okay. Did he have edema or pallor?
No, ma'am.
Okay. Anything else of significance?
Ma'am, blood pressure, ma'am.
How much was it?
Ma'am, it was 130 by 80 millimeters of mercury measured in the right arm and sitting position. Next, I would ask for a jugular venous pressure, ma'am. I will see for the patient's JVP, ma'am.
Okay.
Next, any engorged veins in neck.
Okay, JVP, engorged veins. So what is the significance of looking for pallor in ischemic heart disease patient?
Ma'am, if patient is anemic, there will be decreased, so that is also one of the cause for decreased oxygen supply, ma'am. So anemia, hemoglobin plays a vital role in that.
Okay, so could be a contributing factor towards ischemia. Good. Yes, how did you measure the blood pressure? What technique?
Ma'am, non-invasive method of blood pressure, ma'am. By oscillometric and by oscillometric and auscultatory method I measure.
Okay, so for your oscillometric method, what apparatus did you use? You measured it where?
I measured in my PAC clinic, ma'am.
Okay, so how does oscillometric method work?
It works based on the oscillometric pressures of the blood vessel wall. When it oscillates, the cuff pressure decreases, ma'am. So at that time, it measures, ma'am. It measures mean arterial pressure mostly.
So oscillations are in the wall, and they are caused because of the turbulence that you set up in the blood flow, correct?
Yes, ma'am.
What are the other methods of BP measurement that you know, non-invasive methods?
Palpatory method.
Good.
Arterial tonometric method. Pressure pulse transit time method. Plethysmographic pulse transit time method.
Good.
Then electronic palpation method.
Is any of the non-invasive methods a continuous method? Because all of these are intermittent otherwise, right? We never get a real-time trace with non-invasive. Is there any experimental or proposed method for continuous?
Ma'am, I don't know.
Okay.
For invasive blood pressure monitoring, it is a continuous method. Non-invasive.
Agreed. Agreed. Okay. So your patient has a normal blood pressure. His heart rate is around 68 per minute, right? Yes. Do you think this could be because of, do you expect it to be 68, or do you think this is because of some intervention which has been done?
After stenting, patient will be on beta blockers also. There is high chance this patient will be on beta blockers. So I expect this.
Right. Why are beta blockers given to these patients?
Tachycardia is bad for these patients, ma'am. It will increase oxygen supply. It will increase oxygen demand, ma'am. So I don't want my patient to be tachypneic. So they will be on beta blockers.
Right. So beta blockers result in what long term? They decrease the cardiac morbidity in patients and mortality. That's why he's going to be on beta blocker. Okay. So he has no edema, he has no pallor, heart rate is nicely controlled, blood pressure is normal, JVP is not engorged, you are saying. Okay. So anything else relevant in the history, in the examination? Go on with your examination.
Ma'am, airway examination. Bilateral nerves were equally patent. There was no deviated nasal septum. His oral hygiene was good. The interincisor gap was 5 centimeter. There was no loose artificial or buck teeth. He belongs to modified Mallampati grade 1. Upper lip bite test was grade 1. Neck movements were normal. The stenomental distance was 13 centimeters. Thyromental distance was 7 centimeters. Hyomental distance was 6 centimeters. Neck circumference was 36 centimeters at the level of thyroid cartilage. Spine examination.
Wait, so by all this airway examination, what are you trying to conclude? That he has an?
He does not have a difficult airway.
Okay, so no anticipated difficult airway. Okay. Who modified the Mallampati classification? You said this is modified. Young and?
Samson.
Okay, good. Go on. So airway is also normal. Now, next.
Spine examination.
Any abnormality?
Ma'am, he has a tenderness over L5 region, ma'am. Straight leg rising test was positive on the right side at 45 degrees.
Okay.
And on left side at 80 degrees.
Okay.
Motor and sensory systems were normal, ma'am. There was no bowel or bladder.
Fine. You said that. You said that. Anything else of relevance in examination?
Cardiovascular examination.
Tell us.
On inspection, the chest wall was bilaterally symmetrical in shape. Apical impulse was visible on left fifth intercostal space, 1 centimeter lateral to the mid-clavicular line. The trachea appeared to be in midline. There was no precordial bulge or no other pulsation. Palpation, the inspectory findings were confirmed. Apex beat felt at the left fifth intercostal space, 1.2 centimeters lateral to the mid-clavicular line. There was no palpebral thrill, parasternal heave, or any other pulsation. On percussion, the cardiac borders were found to be normal. On auscultation, the heart rate was found to be 68 beats per minute and was regular in rhythm. S1, S2 appeared normal. No click, rub, or murmur was here.
Okay. So based on entire history examination, what's your diagnosis now?
Ma'am, he's a 52-year-old male patient who is a known case of ischemic heart disease who came for post-PTCA 9 months back, who is currently asymptomatic without any features of heart failure who came for spine surgery, probably L4 at L4, L5 region, maybe disc prolapse. He came for laminectomy at L4, L5 region.
Fine. So now the situation I'm going to give you is that this patient with IHD is now being scheduled for a multiple level laminectomy. It has been 9 months. He has got, let's say, a drug-eluting stent in situ. What do you think are the likely medications he's going to be receiving? First thing.
Since he's on drug-eluting stent, he will be receiving dual antiplatelet therapy, ma'am, most probably.
Good. Okay.
He will be receiving beta blockers. He will be on statins, ma'am.
Okay.
And he might be on ACE-ARB inhibitors.
Okay. So we will assume that your patient is on all of these medications. Now, how do you want to proceed for this laminectomy? You get a requisition in the PSC. So what is the first thing that you would like to confirm or kind of rediscuss with your surgeon and your cardiologist?
First, I would like to know what kind of stent he's been drug-eluting stent on what generation, first generation or second generation?
Okay, second generation.
Okay, ma'am. Then next I will ask whether this, I'll ask about what drugs he is taking currently, on how much stents he has been placed, either 2 stents or 1 stent, at where he has been placed at bifurcation, what is the length of the stent, he has any comorbidities.
Okay.
Then next I would like to ask to the surgeon, it is an semi-urgent surgery or elective surgery.
Okay. So why are you trying to ask, you said, for the length of the stent, the number of stents, whether it is at a bifurcation, and for certain comorbidities? Why do you want to ask for all this? These are risk factors for what?
Stent thrombosis, ma'am.
Okay, so high risk for stent thrombosis. Okay. And why do you want to talk to your surgeon, whether he can postpone or not?
Ma'am, for if he is on first generation to till 12 months, I would try to postpone him, since it is not an emergency surgery. So it is an scheduled elective surgery. So that will be based on the risk benefit ratio. I would like to.
Right. So the first thing you're trying to do is talk to the surgeon and the cardiologist, and we want to establish that, let's say it's a second generation stent. So we can take him up after how many months?
6 months.
So 6 months is over. We can take him up. And let's say the cardiologist says that there is no increased risk of thrombosis, which means the stent was not more than 6 centimeters in length. It is not less than 3 millimeters in diameter. They are not multiple. They are not at bifurcations. Okay. And there are no comorbidities. And he's a non-diabetic and his renal function is also normal. So now would you like to go ahead with the surgery?
Yes, ma'am.
Okay. So, and the surgeon says that he would like to operate if possible because it might result in neurological damage. So we are deciding to go ahead with this surgery at 9 months. Okay. At the end of this session, if anybody wants to have a discussion regarding this timing of the non-cardiac surgery, Dr. Shrikant will take your questions. Now, how will you proceed? What would you like to do?
Ma'am, I would like to order some investigations in this patient. First, I would like to order complete blood count, which includes hemoglobin, total leukocyte count, and platelet count. Next, I would order a kidney function test. Next, I would like to order serum electrolytes. Next, I would like to order liver function test.
Okay.
Next, I would like to have a blood sugar, ma'am. Next, I would like to have chest X-ray.
Okay.
And a 12-lead ECG.
Okay. Now, just justify, why do you want kidney functions done in this patient?
Ma'am, I need first thing, I wanted to rule out RCRA criteria, ma'am. So one of the criteria is creatinine. So whether I wanted to know his normal creatinine or it's elevated or something. Next thing, perioperative AKI. Since he is a high-risk patient for perioperative AKI, so I wanted to know creatinine.
Okay, what is RCRI? What do you mean by that?
Ma'am, revised cardiac risk index.
Okay, what all does it include?
It includes a history of ischemic heart disease, history of stroke, history of heart failure, or his under the nature of the surgery. Either he is a diabetic on insulin or is creatinine more than 2.
Okay, more than equal to 2 mg/%. So in your patient, out of these 6 criteria, what is his score, RCRI?
1, ma'am.
1.
History of ischemic heart disease.
So does that mean he's a low risk or a high risk of cardiac morbidity, mortality?
He's a low risk, ma'am. Based on RCRI criteria, he's on low risk.
Right. So this is a low risk patient. And the surgery is a low or a non-low risk surgery? Multiple laminectomies, prone position.
Ma'am, high risk surgery.
High risk surgery.
High risk surgery, ma'am.
Okay. So we have tried to establish that your patient has a low risk of cardiac morbidity, mortality, you are saying, and he has a high risk surgery. And anything you'd like to tell us about his functional capacity?
Yes, ma'am.
Functional capacity is good or is it poor?
He's good, ma'am. He's good, ma'am. It's good in this patient.
Acha. How did you establish that?
Ma'am, I asked his history, ma'am, whether he is able to walk, he does his household works, what he is doing. So he said he is a shopkeeper by occupation and he does his own work, even in shop and in home also.
Okay. So
he's able to walk, everything.
How do you grade a non-poor functional capacity? He should be able to do all of these. What is the cutoff for a low functional capacity?
I'm able to climb stairs or not.
How many flights?
One flight of stairs.
Okay. And that would mean that he has a good functional capacity, or does that just mean that he does not have a poor functional capacity?
It means he does not have poor functional capacity.
So why did you say that he has a good functional capacity?
Ma'am, he was doing rest of the works. He was able to do some amount of exercises.
Did he say that? He has a back pain. You said it is radiating. He has to lie down and sit intermittently. So do you think his functional capacity is non-poor, unknown, or is it indeterminate?
Unknown because of back pain.
Unknown. So, okay. Why are we stressing so much on it? You are saying it's an unknown functional capacity and it is a low risk of MACE and it's a high risk surgery, right? So now coming back to your investigations, you also said you want a blood sugar done. Why?
Ma'am, I wanted to rule out, ma'am, whether he might be not knowing that he is diabetic or not also.
Good.
So baseline blood sugar I need.
Okay.
It will be a risk factor for me.
Right. So again, it's a part of RCRI. So
Yes,
RCRI, which you are using for risk stratification, what are the advantages of this score?
Ma'am, it is easier. It is validated.
Good.
Does not require any calculations. Web calculations.
Yeah, right. It's just one simple score for each. Yes, so your patient has an RCRI of 1. You also said you want to get a chest X-ray done. What will chest X-ray show you in patient of IHD?
If he's on failure, maybe features of left failure or cardiomegaly, I can see cardiothoracic ratio.
Okay, okay. Why do you want a 12-lead ECG? Is it justified as per guidelines to get a 12-lead ECG?
Yes, ma'am. It's justified.
Why?
It's one case of ischemic heart disease, ma'am. So I would like to ask for, and he's a high-risk surgery also.
Yes, so non-low risk surgery and known CAD. Fine, so you'll get an ECG. But he says he has an ECG of 4 months back. Will you still want a new one?
Ma'am, 1 to 3 months I will accept if that after that ECG or anything patient is not on a, he didn't get any new symptoms. 1 to 3 months I can accept, ma'am.
Correct. Any other cardiological investigation? What is your opinion on trying to get a resting echocardiography for this patient?
Ma'am, if post stenting echo is available, then I will go with it, ma'am. If not,
okay, so let's say he has.
If not, then I will ask, ma'am.
Okay, justify this, please. Why don't you want? Let's say his last echo is available is 3 months back. So why don't you want a new one? What do your guidelines say?
Ma'am, guideline says if he's either he's dyspnea of unknown origin, or there is a dyspnea with heart failure, or even he is a documented left ventricular assessment dysfunction, and he has not done an echo within 1 year, then I will ask for an echo.
So he doesn't fit into any criteria. Good. If you do have the echo report with you, what all would you like to see in the echo in a patient of IHD? What is it you're going to look for?
I look for ejection fraction, ma'am. Ejection fraction. Any regional wall motion?
Should be more than how much?
55%. 60.
Less than how much would you classify as a high risk?
25%, ma'am. Less than.
25? Or
30.
is it 40% as a cutoff value? Less than 40% is not a normal risk, right? Less than 30% is a definite high risk.
Yes, ma'am.
Okay. Anything else? RWMAs.
Regional wall motion abnormalities.
Anything else?
Is valve area.
Valve area is normal. He doesn't have a rheumatic lesion. So systolic dysfunction.
Systolic and diastolic dysfunction.
Yes, diastolic dysfunction. How do you see that on an echo? What will you look for?
It will be written in grades. Grade 1 systolic dysfunction, grade 2.
Or, so diastolic dysfunction is how many grades? 3 grades. How is it classified? How is it diagnosed? You will see an EA ratio, right? Which is an early to late diastolic pressure gradient ratios. So EA ratio, if it is 2 or more, it is a severe class 3 diastolic dysfunction, which is almost a diastolic failure. Fine. So echo. Do you want to get a stress echocardiography or an exercise tolerance test done for him, or TMT?
Ma'am, if possible, I can get, ma'am. Since he is an elevated risk patient and his unknown meds is there, unknown functional capacity, so I can go, ma'am.
Right. So as per AHA guidelines, you are entitled to get a stress echo provided it is a non-low risk.
Elevated risk surgery and unknown origin of meds, unknown functional capacity.
Yes. What is meds?
Metabolic equivalent scoring.
How is it defined? How is one med defined?
Amount of oxygen consumed at rest by a 70 kg man at 40 years of age.
Perfect. Okay. So now let's say in your particular patient, you have a last echo, you've gotten an ECG done, and there is no abnormality detected. His ejection fraction was 45%. Okay. And there doesn't appear to be any RWMAs at the moment. So will you accept this patient?
I'll accept this patient.
Okay. So preoperatively, what will be your pre-op orders?
Milperolar for 8 hours for solid and 2 hours for clear liquids. And I'll obtain a written informed consent, ma'am. And if patient is on dual antiplatelet, so I would like to stop clopidogrel in this patient for 7 days. And rest other medication, I would like to continue, ma'am.
Okay. Which means what all are you going to continue?
Ma'am, aspirin, beta blockers, statins. The patient is on beta blockers, statins, AC and ARB inhibitors, I would like to continue.
Okay. So all 4 you would like to continue?
Yes, ma'am.
Okay. What can be the side effect of statin therapy in your patient?
Ma'am, muscle pain, polymyopathy, patient might be having pricking and pin sensation in feet and lower limbs. So I would like, if patient is on there, I would like to document in my PSC sheet.
Okay. Any other disadvantage or side effect of statin therapy?
Constipation, diarrhea.
Okay. Any on liver and kidneys usually spared?
Yeah, ma'am. If hepatotoxicity might be there, ma'am.
Okay.
Patient.
Fine.
Hepatotoxicity, statins.
Okay. Anything else in the pre-op orders? Drugs you've decided? Informed consent, NPO?
Ma'am, blood group and cross matching, ma'am.
Perfect. Anything else?
Then, ma'am, anxiolytics. I would like to give preparation tablet alprazolam 0.25 mg on the night before surgery and on the morning of surgery also, ma'am.
Okay. And of course, he's complaining of backache. So anything else?
Rest and tablets and peace and some pain.
Yes. So his painkillers have to continue because pain in a case of IHT, you just don't want to accept at any cost. So you've prepared. Now patient has been shifted to the OT. How will you proceed?
Ma'am, on the morning of the surgery, as soon as patient comes, I would like to assess the patient and I would like to know whether he has followed my pre-op orders or not. If it is there, then I would like to ask for any fresh complaints.
No fresh complaints.
Then I would like to prepare my OT, ma'am. I will check my machine resuscitation bag, drugs, suction and cardiac emergency drugs. After that, then I will wheel in my patient to the OT, ma'am. Then I will obtain a baseline readings of non-invasive blood pressure, pulse ox, and an ECG. Then I will take 2 wide bore cannulas in patient, ma'am.
So what monitorings are you planning? You said pulse ox, BP, ECG.
ECG.
What else?
Temperature monitoring.
Okay. Any other monitoring?
Blood sugar.
Anything else? What are the minimum mandatory monitorings that you need to do for all patients under anesthesia?
Pulse oximetry, non-invasive blood pressure, ECG, temperature monitoring, ETCO2.
So ETCO2 also.
Okay.
Supposing, forget about what is correct and what you need. If you are in a situation where you have a choice to pick up only pulse oximetry or end-tidal CO2 to monitor any patient, it should never happen, right? But supposing it's a rural setup and you have a choice to choose only one, which one will you pick up and why? Any patient undergoing anesthesia.
Ma'am, pulse oximetry. And
okay.
If it is regional, though, I need pulse oximetry only, so I'll pick up
I never said regional or GA. I'm just saying that out of these two, which one will have a better predictive value for more number of things? What can you use them for in drop? So pulse oximetry tells you about, what all can it tell you?
Pulse waveform, heart rate, saturation of the patient.
Okay.
Whether it is regular or not.
Fine. So heart rate, rhythm, and hemoglobin saturation, right? These three things. What are the uses of end-tidal CO2 that you are aware of?
Ma'am, to know about whether end-tidal carbon dioxide, we can know for intubation whether patient is on whether intubated or esophageal intubation, to rule out that we can use.
Okay. One. So correct intubation. What else?
Even post CPR patient, for how much effective the CPR is, that also you can use end-tidal CO2, ma'am.
Why do you use it after CPR? Why not use a pulse ox again?
Peripheral, it will not be that much. Peripheral circulation will not be that much in post CPR patient.
So that means your pulse ox.
Low cardiac output states.
So low cardiac output, your pulse ox is not very reliable.
Accurate.
First thing. Whereas end-tidal continues to be, ETCO2 continues to be. Any other use of end-tidal CO2 you've encountered besides intubation and perfusion, right? So yes, ETCO2 tells you about perfusion. What happens if there is a massive embolism, air embolism to your ETCO2?
It will drop, ma'am. ETCO2 will drop.
Why does it drop?
Zero. There is no perfusion.
Right. So it's a very good indicator of perfusion, and intubation also. Any other use of ETCO2? What happens to ETCO2 in a patient with bronchospasm?
Sparfin appearance will be there.
Okay, so the waveform kind graphics also tell you so much. They tell you about a spasm. They can tell you about if your system gets pink.
Yes, ma'am. kinking also it can tell you. If it gets dislodged also it can tell us. If it is endobronchial intubation also it can tell us.
Wonderful. And does it tell you when to give your NDMR?
Yes, ma'am. There will be Kurare Nach. It can tell that also, ma'am.
Okay, you know that also. And what happens if there's a leak in your system? Does your end-tidal change its waveform pattern?
Yes, ma'am. Waveform change its pattern. It will be down, ma'am. So
okay.
it will not.
Okay. And are these changes immediate, or does it also take time, like a pulse oximetry, which takes time for saturation to drop? And once it drops, it's precipitous, of course. Are ETCO2 changes also lagging behind, or are they more instantaneous?
I think 6 seconds lag is there, ma'am, from side ETCO2.
Just that much, right? It is not that unlike the S-shaped curve of oxyhemoglobin dissociation, so it's going to take time. Aisa to nahi hai? Not like that. So pulse oximetry also has this disadvantage that physiologically your saturation takes time to start dropping while you're at the flat portion, isn't it?
Yes, ma'am.
So for perfusion, can you use both these, pulse oximetry and ETCO2?
Ma'am, I'm not getting, ma'am.
As a test of perfusion, can you use both?
Yes, ma'am, I can use, ma'am.
Okay. As a test of ventilation, which is more reliable?
ETCO2 is more reliable.
So then why don't you want to choose ETCO2 instead of pulse oximetry? Think about it. Okay. This was just to break the monotony. This is an opinion-based question, and let's get back to your case, Shrikant. So you had forgotten end-tidal CO2. That is why I was trying to emphasize its utility. Okay. So you need a pulse ox minimum mandatory monitoring. Besides the minimum mandatory, any other monitoring? You said pulse ox, BP, ECG, temperature, ETCO2. Anything else?
Urine output
cardiac patient. Very good. Anything else?
Invasive arterial BP, I would like to secure in this patient.
Okay, you want invasive. Anything else?
Blood sugar monitoring.
Fine, good. Anything else you want to monitor intra-op?
Blood loss, ma'am.
Very nice. Okay. Anything else? Good. So let's talk a little about your invasive BP monitoring. In your physical examination, anything you like to do in patients of IHT because you're going to do an invasive outline?
Modified Allen's test I would like to do before.
How's that done?
First, I'll ask the patient to sit comfortably. Then I'll get the patient's hand. Then I'll ask him to clench his feet, ma'am. Then I'll upload his radial and ulnar artery. Then I'll open the ulnar artery. And I will see for color, ma'am. If it comes within normally it should be less than 5 seconds. 5 to 10 seconds is also accepted. More than 10 seconds, there is no collateral. So I would not like to.
Okay. Does modified Allen's have a good sensitivity or specificity or predictive value to portend or say that this patient is going to get gangrene or thrombosis?
No, ma'am. Does not say anything about clinical outcome. Does not give any ideas.
Okay. And what is sensitivity in anesthesia? How is it defined?
True positive. True positive.
Good, good. And if you are going to put in an invasive arterial cannula, you've put them in, you're familiar with the technique?
Yes, ma'am.
What gauge of arterial cannula do you want?
20 gauge.
Okay. Supposing you're getting a waveform and now your damping becomes very high. What will be the effect of this damping on your systolic and diastolic blood pressure?
If it is over damped, it will decrease, ma'am. If it is under damped, it will increase.
Good. Both pressures will decrease, or will one decrease and one increase?
Both will decrease, ma'am. Mean arterial pressure will be same, ma'am, but I don't know about individual.
If both are decreasing, how can mean arterial be same?
Yes, ma'am.
Because the systolic decreases and the diastolic goes up, right? Their high frequency and low frequency components are different. Okay. And when would you like to put this invasive arterial line?
I would like to take before induction, ma'am.
Why?
The local anesthesia.
I agree. Why?
Ma'am, because during induction hypotension and during laryngoscopy hypertension. So I wanted to see what changes patient is suffering. So I don't want this to happen. So I would take before induction.
Agreed. Okay. And what are the techniques for blood loss monitoring that you are aware of?
Ma'am, visual assessment technique.
Okay.
Gravitometric, calorimetric, and radioiodine technique. One is there, ma'am. And
what is the gravimetric method? Do you use that normally?
Ma'am, we actually take the weight of empty gauze soaks. After that, how much it is soaked, we'll wait and we'll take. But it has certain disadvantages, so we don't use.
Yes, these are all subjective. Fine. So after establishing all these monitorings, is there any other monitor which, if your institution had the facility for, it's not routinely used, then it can be recommended for a certain subset?
Ma'am?
Yes? I can't hear you.
Monitor. Ma'am, I'm questioning ma'am once again, ma'am. Please,
okay.
I could not hear.
Any specific specialized monitoring which is not routinely recommended for IHT patients but can be used in those who are hemodynamically unstable IHTs?
And esophageal echocardiography. If experts are available, and then I can go with esophageal echocardiography.
Okay, only in those who are hemodynamically unstable. Otherwise, no. Fine, I agree. So now with all this monitoring, you have decided to carry on with your anesthetic technique. What's your technique of choice?
My technique of choice will be general anesthesia with endotracheal intubation and controlled ventilation.
Wonderful. How will you proceed?
I will pre-medicate with induction midas 1 mg and fentanyl 120 mics. I would like to induce with the injection ethomidate. And after checking ventilation, I would like to go with the injection vecuronium 6 mg. And I'd like to ventilate with the 50% of oxygen, air, and sevoflurane. Then after 3 minutes, I would before 90 seconds prior to intubation, I would like to give lignocaine 90 mg. Then I would like to do a gentle laryngoscopy and secure an airway and connect it to the ventilator and control ventilation.
Okay, okay. So why have you chosen fentanyl in this patient?
Opioids, so I
what
know pain to blunt the response also and pain also.
Okay. Any side effect with etomidate that you're aware of?
Myoclonus, ma'am.
Anything else?
Adenocortical suppression, nausea, vomiting, pain on injection.
Okay. Why have you chosen etomidate then?
It's a cardiostable drug, so I choose etomidate.
Okay, good. Any induction agent which is not cardiostable according to you? IV induction agent?
In this patient, I would like to avoid ketamine.
Okay. And what about propofol?
Propofol causes hypotension, and
why does it cause hypotension?
There are 3 causes, ma'am. One is it directly acts on heart, it decreases the heart rate. One is systemic vasodilatation is also there for propofol. So,
does it cause myocardial depression? Propofol?
Yes, ma'am.
It does? Does thiopentone cause it? Yes. Okay. And you decided to choose vecuronium as the non-depolarizing muscle relaxant. Why?
I'm not able to hear.
Okay. Why have you chosen vecuronium?
Ma'am, it does not have any cardiac action, so there are no vagolytic action. So I preferred vecuronium.
Okay. And why did you choose air? Why have you decided to not use nitrous oxide?
Pulmonary vascular resistance, and I feel air for my patient is more comfortable than nitrous in heart disease patients.
Why?
So I choose nitrous.
Why?
Nitrous causes pulmonary vascular, it increases pulmonary vascular resistance, which will be bad for these patients.
Okay. Any other disadvantages of nitrous oxide which you're aware of?
Nitrous oxide causes megaloblastic, it may cause anemia patients, then it may cause post-operative nausea, vomiting, nitrous with, then there is third gas.
Yes.
Diffusion hypoxia when patient comes out.
Okay.
And air in cases of emboli, so it will enlarge air and then
okay. So fine. Yes, there are advantages of air. Good, you've pointed them out correctly. What will you take care of when you are using air as compared to nitrous oxide? How will you have to modify your anesthesia?
I would like to increase the sevoflurane concentration when I'm using air.
And increase sevoflurane and maybe a higher dose of
higher dose
analgesic
of
also?
analgesics. Yes, ma'am.
Yes, so your fentanyl also. Why did you choose sevoflurane?
It's cardio stable, ma'am. So I choose to sevoflurane
Is
compared to
there,
others.
okay, is there really any difference in terms of ischemic heart disease, which agents you pick up or which anesthetic technique you choose? Does the outcome differ?
Ma'am, once again, ma'am, question.
Is the connection not okay? I can hear you clearly. If you are going,
Now
is there,
it's fine, ma'am.
okay,
Now it's fine.
is there any difference in terms of the anesthetic agents or techniques as far as outcome in IHD patient is concerned?
Ma'am, there is no advantage over regional or general in ischemic heart disease patients. Ma'am.
Okay, as long as which particular goal you are maintaining.
I would like to maintain oxygen supply and demand in this patient as a primary goal.
And
Next,
how
I
will
would
you
like
do
normothermia.
that?
I will avoid tachycardia and extremes of BP, both hypotension and hypertension. I would like to avoid in these patients.
Good.
Then I would like to maintain normothermia, ma'am.
Very good. Why? Why normothermia in IHD and not otherwise?
I mean, every patient I would like to maintain
Yes.
normothermia.
So why particularly in IHD?
I mean, it will increase oxygen demand and also it increases the afterload. So I don't want this to happen in my patient.
Okay. Is it an accepted recommendation? Is it a good grade of evidence for normothermia in IHD?
Yes, ma'am. There is a good evidence.
Yes. It's a class?
2B.
So normothermia definitely. Why do you want to use lignocaine? You also said lignocaine 90 milligrams.
I wanted to blunt the laryngoscopic response.
Okay.
So I wanted to, before 90 seconds prior to, I wanted lignocaine.
Okay. Any other agents for intubation response blunting you can use?
Beta blockers. First, I would like to increase the depth of anesthesia.
Adequate depth.
Then I'd like adequate depth. Then opioids also I can use, fentanyl. I can use beta blockers, esmolol, short acting. So.
Okay. So all these can be used to inhibit the intubation response. Okay. You have chosen to use lignocaine. Now you've induced. Okay. How will you know that your depth of anesthesia was adequate for intubation? What will you look at?
Minimum alveolar concentration.
How's it defined?
MAC and it is the minimum amount of inhalation agent required to prevent purposeful movement to a surgical stimulus. 50% of adult at 1 atmospheric pressure in 37 degrees Celsius temperature.
Okay, fine. Why are you trying to define the pressure and temperature when you're talking about MAC? What will change if the temperature and if STP is not held? Do you ever define atmospheric pressure and temperature when you talk about dose of fentanyl, dose of propofol?
No.
So why? Think.
Boiling point.
Yes, so that changes, then the vapor pressure changes, right? And if that changes, then the potency changes. So that is why it is important when you define these.
Okay, ma'am.
I just want to say this here that this was not a planned viva. So we're going, Shrikant is having to think, and he has to manage a lot of things, right? Not just IHD focused, because this is how your exam vivas actually go. Just because you have a case of IHD doesn't mean it will be only ischemic heart disease, right? Tangential, everything, it's a horizontal and in-depth knowledge, which is always going to be tested in your vivas. So you've induced your patient and it is uneventful so long. You've intubated also successfully. What position do you think it is going to be for a laminectomy usually?
It's probably prone position, ma'am.
Prone position. So you just after putting your patient prone, what are you going to look for? What do you expect that can happen and you don't want it to happen?
First, I look for airway.
Okay.
Whether it is secured, might be the tube might be displaced. So first, I will go with airway. Then breathing, I will auscultate all the areas.
Okay.
Next, circulation, I would like to see for whether my lines are perfect and other monitoring CCG circulation, then invasive arterial BP.
What do you expect with the BP to happen in prone positioning? Let's say your patient was very dehydrated and he's on beta blockers also. He's not able to compensate very well. So what do you expect? The BP can rise or fall, or it will remain same?
It will rise, ma'am. So
If your depth is not adequate, yes, it rises. Otherwise, certain class of drugs, which antihypertensives, which can produce a postural drop.
Yes, ma'am. ACE-ARB inhibitors.
Okay.
Postural.
Fine. Not postural, but yes. So now let's say your patient seems to have developed some kind of a hypotension. What is the first thing you will do? Just after turning prone, how will you manage this hypotension?
Fluids. First, I will check whether he is adequately adequate hydration of the patient. So you gave him fluid. Yes, ma'am.
Okay. You gave a fluid challenge. There is no response. His BP doesn't pick up. What will you think of next? Is hypotension good for this patient?
Ma'am, no, ma'am. I'll think of inotropes then.
Excellent. Which one would you like to start?
Vasopressin.
Why vasopressin?
Ma'am, because this patient was an ACE-ARB inhibitor, so she will not respond to others. So I would like to start vasopressin.
Yes, it is possible. Why do patients who are on ACE inhibitors and ARBs, why do they not respond to anything else except vasopressin?
Because those act by RAS mechanism. So it blunts that. So they won't be responding.
Okay. So the RAS entire pathway is obtunded. So vasopressin acts separately through independent receptors. So yes, vasopressin. Any other use of vasopressin in anesthesia you've seen?
Shock patients you can use.
Good. Anything else? Does one particular specialty use it for anything?
Neurosurgeons.
Okay. Any other? That's desmopressin more, but okay. Heard of it being used for myomectomies? In myomectomy? Okay.
Myomectomy.
Fine. Do gastric surgeons or gastroenterologists use it for anything? Is there a role in portal hypertension? Right.
Yes, ma'am. Yes, ma'am. They use it.
Yes. So let's get back to ischemic heart disease now. You've induced, he had hypotension, he's responding now, and the surgeons have started with their surgery. It goes off uneventfully, but yes, he had that one episode of hypotension intraoperatively. Now, will you extubate your patient? No.
At the time of extubation, if he is fine, I'll extubate my patient.
Okay. Where will you like to observe him now? In the ward, ICU, post-op
High
ward?
definition unit. First, I will shift him, so I will observe him.
Why HDU?
Ma'am, these patients are more prone for cardiac events post-surgery also.
Very good. Which cardiac event mostly?
Major adverse cardiac events.
Okay.
Anything they will be prone for. Most probably myocardial ischemia, oxygen supply demand will be disrupted.
So ischemia or infarction. How is a perioperative MI different from a usual MI?
Perioperative MI is mostly because of oxygen supply and demand mismatch. Usual MI is because of plaque rupture, atherosclerotic changes. That will be most. There are two types.
So is there any difference in the presentation also then?
Ma'am, ST elevation, it will be a silent MI, kind of silent MI perioperatively.
Yes. And do they usually have STT changes, or even those are obtunded to some extent?
To some extent, it will be obtunded.
It's not as common, right?
Okay. Yes,
so you have him in the HDU. What will be your post-operative goals?
Same as intraoperative goals, ma'am. What I maintained intraoperative, I will maintain same for the post-operative also.
Which means, what will you do?
Ma'am, first oxygen supply and demand I will maintain. And I will maintain normothermia in this patient, even in post-option also. Analgesia of this patient.
What else?
IV fluids, head propped up,
Yes,
same
fluids, because hemodynamics you have to maintain. Okay. How do you plan to do the analgesia?
Multimodal analgesia, ma'am. I planned multimodal analgesia.
What will you use for multimodal?
Ma'am, paracetamol and opiates, I'll use opioid.
Okay. How will you use opioids? And which
infusion.
one?
I prefer fentanyl, so I'll go for infusion.
Okay. What's the dose for a fentanyl infusion for post-op analgesia?
0.5 to 2 mg per kg per minute.
Okay. And if you had, let's say, a usual infusion pump or anything, any other kind of infusion pump which you would like for post-op analgesia?
Patient controlled analgesia. If patient controlled PCA pumps.
Right, that would be preferable. Do you think there's any role of a regional anesthetic technique in this particular patient? Can you have used any block to decrease the pain?
Caudal. There are some studies for caudal
block also.
So
is there any role of epidural specifically in IHD patients?
Ma'am, not for this patient, ma'am. If abdominal aortic surgeries, there is definitely a role for abdominal aortic surgeries or hip surgeries. There is definitely a role for epidural, ma'am. But
yes,
not in.
They have been shown to decrease mortality and cardiac events in these patients. Agreed. Okay, so post-operatively, you've managed fine. And will you get ECGs or any biomarkers or troponin done for this patient in the post-op?
Ma'am, if he shows signs of MI, definitely I'll get a ECG and biomarkers. If not, if he is a high risk, preoperative high risk, and based on the tests which I have done, if he shows any signs of infarction and he is a high risk, then also I will do, ma'am. It comes under 2B category, so I can ask.
Okay, so any evidence of MACE and you will get done troponin and ECG, otherwise not routinely for post-op surveillance.
Yes, ma'am, not routinely.
So how do you stratify or how do you classify the risk or myocardial risk based on a stress test? Are you aware that there's a low, intermediate and high risk stratification in these patients? Okay, that's for some audience to answer, please. I want one of the students to answer. What will you look for in the results which are given to you of a stress test? How will you say that this was a high risk for MACE based on that testing that you do? Okay. So post-operatively also it is done. Now we have a few unanswered questions, Shrikant, during the course of your case. Supposing your patient was not on beta blockers preoperatively, right? Or let's say he had left it by himself, say 2 months back. Would you like to restart beta blockers? And if yes, why and how?
Ma'am, I would like to restart beta blockers, ma'am. If he has left also, I would like to restart beta blockers. I would like to start before 24 hours prior to surgery.
Preferably for how long before surgery?
As soon as he comes, so I will start.
Right, but preferably for how long do you want to give it before the surgery? Is there a recommended period? 1 month, 1 week, 2 days? When will you say that this is okay? Surgeon ko to case karna na bacha?
1 week, minimum 1 week. Minimum 1 week.
Yes,
he should be.
Yes. So for 2 to 7 days, you'd like to give it. And in the post-op and intra-op period, will you continue beta blockers?
Yes, ma'am. I will continue, ma'am.
Okay.
Cardiac outcome is good in patients who are receiving. So it has decreased cardiac mortality and morbidity. So I will continue.
Okay, but would you like to look for anything, or will you just write in the case sheet that, okay, continue beta blockers?
Hypotension, bradycardia.
Yes.
So if I would see hemodynamically also, then.
So beta blockers have to be titrated according to clinical condition. In the post-op, will you restart your dual antiplatelet therapy?
Preferably 24 to 48 hours, I will restart, ma'am. I'll ask surgery, or if surgery goes fine and there is no bleeding, and if they are okay, then I will definitely restart, ma'am.
Okay. And supposing you had done a surgery, exactly the same thing, but let's say that you had given a spinal block to this patient for something. Let's say surgery was different. Now in the post-op, will there be any specific instruction with regard to the DAPT, dual antiplatelet?
Yes, ma'am.
Hmm.
After 4 to based on what antiplatelet he is, so I will modify.
Clopidogrel and aspirin. When can you start them back?
24 hours after I will start.
Okay. So your spinal doesn't make any difference. It is more to do with surgical hemostasis in the post-op when it is antiplatelet therapy. Correct. Now, you said that you can take up the patient because it has been more than 6 months since your drug-eluting stent. Okay.
Yes, ma'am.
Are there some, how long is DAPT usually given to these patients?
1 year, ma'am.
1 year. Can there be
After
some
that,
candidates in whom it is given for extended periods beyond 1 year?
ma'am, if patient has big stent, long stents, if it is on bifurcation, patient known diabetic, if he has some renal dysfunctions, then we might give.
Right. So is there any score you are aware of which can be used to determine whether they need extended DAPT? Because supposing in PAC you get a patient, it has been 1.5 years, he's still on DAPT and he says his cardiologist told him to continue and not stop. What do you think is the reason? How has this decision been taken? What you said, these are risk factors. Is there any particular score which can be used?
I don't know, ma'am. Score.
Okay, okay. There's a DAPT score, right? So if your DAPT score is 2 or more, these may be candidates for extended therapy. And extended therapy, you as an anesthetist cannot stop. Who will take this decision to stop the antiplatelets, Shrikant? Will you write this on the PAC sheet?
Ma'am, if he's on clopidogrel, yes, ma'am, I can write.
Okay.
I will consult cardiologist also, but I will write, ma'am.
Yes, because you have to weigh the risk of the thrombosis or restenosis, which the cardiologist is best aware of, knowing which kind of stent, and as you've been saying correctly, the characteristics of the stent. Now, I'm giving you another scenario.
Yes,
This
ma'am.
patient only, he had developed hypotension intraoperatively, okay, and he did. You gave him fluids. He responded. What do you think was wrong? Was it the myocardial oxygen supply which was low or the demand which was high?
Hypotension, ma'am. So preload. Demand was high. Both also, ma'am. Hypotension, tachycardia, it increases both also, supply and demand both also.
Right. So tachycardia increases the demand. The supply had gone down, okay, because you'd used this. Now, supposing the same patient comes back to you at 4 months after an implant, after a stent, it's a drug-eluting stent, okay? He had a history of MI for which the primary angioplasty was done. Now he's on DAPT. Will you go ahead with and let's say he has a neurosurgical procedure which is planned. How will your decision for DAPT change? I'll repeat, take your time. 4
Yes,
months. So ideally, should the DAPT continue or should you stop?
It should be continued, ma'am.
Till 6 months?
Yes,
Preferably. Okay, so preferable to postpone the surgery to 6 months. Now the surgeon says he cannot postpone. He needs to operate right now. And it's a neurosurgery. So is the bleeding risk high or low?
It is very high, ma'am.
Bleeding risk is high. Is his thrombotic risk high or low? Let's say he had a primary angioplasty and he has 2 stents, or let's say he's a diabetic. So his thrombotic risk is also high.
Yes, ma'am, it's high.
So now a high bleeding risk, high thrombotic risk, and we are trying to schedule him for surgery. How do we manage his DAPT?
First, I'll assess risk of the surgery and thrombosis. So we assessed, ma'am. Next, I would like to change him to certain other antiplatelets, ma'am. From clopidogrel to some cangrelor.
Wonderful. What is this called? Why are you giving him cangrelor?
Bridging
Right.
therapy. So I can cut short.
Sorry.
I can cut short the period, ma'am. So
why cangrelor only?
Ma'am, I can go to FT fibatide, tirofiban.
No. Usually it's cangrelor. Why? This is bridging of antiplatelet therapy.
Platelets.
Not bridging of heparin. Please remember.
Yes,
this is not bridging of oral anticoagulants or warfarin. That is different. We are trying to talk about bridging of antiplatelet therapy in a high bleeding, high thrombotic risk where I cannot postpone the surgery. Cangrelor is used. Why? Because it is?
It is an antiplatelet, ma'am. Cangrelor.
Yes.
GP, 2B, 3A inhibitors, and it has a short acting. I need to stop only 60 to 90 minutes before the surgery.
Yes.
So that would be beneficial.
Yes, it has a very short half-life, 3 to 6 minutes kind of thing. Okay. And obviously it has to be given IV. So this is about bridging antiplatelet therapy. Can't I use low molecular weight heparin instead? Everybody uses LMWH for everything. Can I use?
I can't, in this patient, I can't use, ma'am. This is because of platelets. Low molecular weight is that is not an antiplatelet.
Absolutely. We need antiplatelet therapy when we are talking about stents or MIs. We are not talking about warfarin. We are not talking about heparins. Okay. Now, the other situations is that supposing this patient had comes to you at 4 months or 6 months or 9 months, and he's come with a stab abdomen. How will you deal with his dual antiplatelet therapy? He can wait, and he's a stable stab. He can wait maybe for 1 hour or 2 hours. What will you do?
Within the time available, I'll first try to optimize the patient, ma'am. Stab injury, so.
Optimized. Anything else?
I will arrange platelets for this patient.
Yes, you will arrange platelets. Supposing you had all available investigations with you, any platelet function tests which you can do?
Thromboelastography.
Okay. Would you like to do a platelet count?
Platelet count? No, platelet count has nothing to do with antiplatelets.
Yes. So you want to do a TG. Any other point of care platelet function tests you are aware of?
DTCT, thromboelastography, sonoclad, rotational thromboelastography, platelet aggregometry.
Yes. So short question, platelet function tests. Right. So I think more or less we have covered everything. Dr. Devang, would you like to tell me how to proceed now? Do you take over from here? Do we take questions? How would you like to do?
Thank you, ma'am.
Oh, Shrikant's in such a hurry to go. Viva finished, exam over.
He's happy that he's done fairly well.
Yes, he has. Okay, first, I'd like to point out what were the good things from as a student's side which he did. First, he did not lose his cool with tangential questions. He kept his presence of mind and he answered after thinking logically, quietly. It was not immediate that he needed to answer. He was willing to think about and then answer whatever he knew. He was also not, he didn't waste time on questions he did not know, which were very few, but he said that I don't know. And he said it in a humble manner so that he gained the next question. So do that. Third, there were certain things he knew and he wanted to utter those words in front of me, which is good because that way you can guide your Viva a little. Never fight with your examiner. Please don't be brisk, don't be rude. Okay. So be willing to say that I don't know. Be willing to say that, okay, there is a difference of practice. This is how we do it, but I'm aware, ma'am, that there is another way to do it too. So with that, I think I want Dr. Devang to kind of take over.
Can we take up questions? There are a few questions.
Sure. We can do that.
One of the delegates has asked why in bare metal stents anti-dual platelets is essential for 7 days, and in case of drug-eluting stents, it is 365 days.
Okay. First thing, after bare metal stents, it's preferably 1 month, not 7 days. And after drug-eluting stent, see, when drug-eluting stents started, it was probably we are going to give them for the whole life. Then it came down to 1 year over a certain decade. Now it is that 6 months we need to give. And there are certain studies underway, which maybe in a year or two, we will have fresh guidelines that they have started giving dual antiplatelet in DES. Don't quote this. This is not in guidelines. These are trials at the moment for just 1 month or 3 months after stents. And they are saying that after that, let's forego the aspirin and put them only on clopid. This also might change in this thing. Anyway, why the difference? Drug-eluting stent. See, these are metallic struts on the stent, which you put into the vessels, and you are hoping that with time, these stents will get endothelialized and they'll become a part of the vessel wall. Till they don't, there is a chance that these themselves become a nidus for a thrombus formation. So what we did with drug-eluting stents was that you coated them with certain drugs which inhibit the proliferation and the neo-intimal hyperplasia. So the stents do not get thrombosed and they do not stenose, and the arteries kept patent, and the pathology of CAD has not stopped, but you have circumvented that particular obstruction. If that patient doesn't take care and new plaques and thrombosis keep forming, that the stent is not going to change in any way. So that is why the duration of dual antiplatelet therapy is supposed to be much shorter with a bare metal stent, because it gets kind of taken up and it's done. Whatever has to happen happens within a month. Whereas with drug-eluting stents, because it's going to take time, stent rethrombosis ultimately will be lesser, but you need to inhibit this neo-intimal hyperplasia. So usually from lifetime to 1 year to 6 months, now to maybe 3 months, and it might come down more also. This is as per evidence which we have right now. Any other question?
Yes, ma'am. Another one is that students are saying that orthopedic surgeries are intermediate risk surgery. So this laminectomy is a high risk surgery. So they want a clarification on that.
Right. See, if you were to look at the ACC AHA 2014 guidelines, and you look at the guidelines before that, the prior guidelines, I think that was 2007 or something, used to divide surgery into a high, intermediate, and a low risk. Then it was seen that the outcome doesn't vary much. It is intermediate and high is kind of together, and low risk outcomes are similar. So the 2014 guidelines talk only about high risk or non-high risk surgeries. If you refer to the RCRI, yes, it talks about intrathoracic, intra-abdominal, and supra-inguinal vascular surgeries as high risk. And for low risk, it gives you the example of cataract and breast surgeries or endoscopies. It does not talk about any other surgery. And that is one of the disadvantages with RCRI. If you were to look up, the same guidelines also make you aware that there are other risk stratification tools of the National Surgical Quality Program Improvement of the American College of Surgeons. They are web-based calculations, but there you can put in different kinds of surgeries. So here you have to assess if you have a heart shell implantation, okay, in a prone position with blood loss of, let's say, 2 to 3 liters, how can you say it is not a non-low risk surgery? So all you have to see is low risk or non-low risk, and a spine surgery, multiple level laminectomy, prone position definitely is not a low risk surgery, okay? And wherever you have to err, please err on the side of safety for the patient.
So the last question is, when do we stop ACE inhibitors before surgery?
Okay. Now, as far as ACE inhibitor recommendation is concerned, your textbook has a different implication. I think starting from our times when we were told that we need to stop both, then came in a time where you withhold ARBs, but you continue ACE inhibitors. Coming on to the guidelines which make no mention about when to stop, but only that if you are continuing, there is a high incidence of refractory hypotension, which is going to happen. If you tell me that you're going to stop ARBs prior to surgery and continue ACE inhibitors, that's what your new standard textbook says, I don't think you will be penalized for that. In our institution, we like to stop both 24 hours prior.
That's all, ma'am. Thank you so much. It was a wonderful session, and I hope, I'm 100% sure that all the delegates must have gained.
I hope so. We tried to keep it as near to Viva exam as possible, while also telling you the things that you need to know. Okay, yes. And that Dr. Devang will sum up what all should be your focus areas.
So we now call up Dr. Devang to do the summation of the case.
Thank you, ma'am. Good morning, everyone. I guess we have already had a comprehensive discussion over the topic. I will just quickly summarize it. Ischemic heart disease or coronary artery disease is a condition characterized by inadequate supply of blood and oxygen to a portion of myocardium. It is essentially a mismatch between oxygen demand and supply at the level of myocardium, and it may manifest as stable angina, acute coronary syndrome, or sudden cardiac death. Acute coronary syndrome further includes unstable angina, ST elevation MI, and non-ST elevation MI. Myocardial ischemia is a common and feared cardiac complication of non-cardiac surgery with an inpatient mortality in the range of 5 to 17%. The incidence of perioperative MI or PMI is reported to be 1 to 17% in all types of surgery and is an independent risk factor for cardiovascular death. Patients experiencing an MI after non-cardiac surgery have an in-hospital mortality of 15 to 25%, with mortality being particularly high in the first 30 days. The exact mechanism of PMI remains uncertain and is a subject of debate and controversy. Acute plaque disruption and hemorrhage in the infarct-related coronary artery system is common in PMI, but the severity of the underlying coronary artery stenosis does not necessarily predict the infarct territory. On the other hand, the presence of subendocardial PMIs implicates myocardial oxygen supply-demand mismatch as the primary trigger. However, these two mechanisms may not be mutually exclusive, with both of them contributing to PMI. Factors causing myocardial oxygen supply-demand mismatch can be divided into factors which decrease oxygen supply and factors which increase oxygen demand. Factors which decrease oxygen supply are further classified into factors which decrease coronary blood flow, like tachycardia, hypotension, raised ventricular and diastolic pressure, hypocapnia, coronary artery spasm or blockage, factors which decrease oxygen content like anemia and hypoxemia, and factors which reduce the oxygen availability in the blood. These are essentially the factors which cause leftward shift of the oxygen hemoglobin dissociation curve. These are increase in blood pH, low 2,3 dpg content, and hypothermia. Factors which increase oxygen demand are tachycardia, increased ventricular wall tension, increased pre and afterload, and increased myocardial contractility. Various indices have been proposed for calculating the risk of perioperative major adverse cardiac events or MACE. Out of these, the most validated ones are American College of Surgeons NSQIP Surgical Risk Calculator, which is essentially a web-based calculator, and RCRI. In 1999, Lee et al. Revised the Goldman Cardiac Risk Index and put forward Lee's RCRI or Revised Cardiac Risk Index. It utilizes 6 independent predictors for calculating the cardiac risk. These predictors are high-risk type of surgery, which includes intraperitoneal, intrathoracic, and suprainguinal vascular surgery, history of ischemic heart disease, history of congestive cardiac failure, history of cerebrovascular disease, pre-operative treatment with insulin, and pre-operative creatinine of more than 2 milligrams per deciliter. The 2014 American College of Cardiology ACC and American Heart Association guidelines stratify the patients into 2 cardiovascular risk categories, elevated and low risk. Patients who are positive for 2 or more than 2 RCRI risk factors are categorized as elevated risk, and they have more than 1% chance of perioperative MACE. Patients who are positive for less than 2 RCRI risk factors are categorized as low risk, and they have less than 1% chance of perioperative MACE. Now let's discuss the various recommendations regarding perioperative medical therapy in these patients. Beta blockers reduce myocardial oxygen consumption, improve coronary blood flow, and improve supply-demand ratio. Despite all these theoretical benefits, various large multicentric trials like POISE have failed to show any benefit of beta blockers over perioperative mortality. ACC-AHA conducted a systematic review on the topic and recommend that beta blockers should be continued in patients who are already taking them. Beta blocker therapy may be initiated in patients with elevated cardiac risk, such as ischemia during preoperative stress testing, or in patients with 3 or more RCRI risk factors. And if beta blocker therapy is initiated, it should be started long enough in advance, preferably at least 1 week before surgery, and certainly not on the day of surgery. Alpha-2 agonists decrease sympathetic outflow and hence decrease heart rate and BP. But large multicentric POISE-2 trials did not show any statistically beneficial effect of clonidine. Based on these findings, ACC-AHA do not recommend alpha-2 agonists for prevention of cardiac events in patients undergoing non-cardiac surgery. Nitrates decrease left ventricular preload and afterload, improve coronary circulation, and prevent or reverse coronary spasm. However, a meta-analysis conducted by Zhao et al. Showed no benefit of prophylactic nitrates in perioperative period. Thus, the current guidelines do not recommend the use of prophylactic intravenous NTG to reduce myocardial ischemia in patients undergoing non-cardiac surgery. Although patients already on nitrates for anti-anginal therapy may continue using them during the perioperative period. Calcium channel blockers reduce myocardial oxygen demand and improve coronary blood flow. ACC-EHA make no recommendations regarding CCBs. However, European Society of Cardiology, ESC, recommends continued use of CCBs in patients already taking them for princemental angina, use of CCBs for heart rate controlling patients having contraindication to beta blocker use, although routine use of calcium channel blockers to reduce perioperative cardiovascular risk is not recommended. Statins lower lipids and stabilize coronary plaque. ACC-EHA recommend continuation of statin therapy in patients currently taking statins. Perioperative initiation of statins may be considered in patients undergoing elevated risk or vascular surgeries. In addition, ESC recommends, if indicated, statin therapy should be started at least 2 weeks prior to elective non-cardiac surgery. Aspirin inhibits platelet aggregation by blocking production of thromboxane A2. Both PEP and POISE-2 trials have failed to demonstrate protective effect for MACE or death in non-stented patients, either continuing or starting aspirin. On the other hand, various large meta-analyses establish that peri-procedural withdrawal of aspirin increases the risk of intraoperative bleeding complications. ACC-EHA recommend that initiation or continuation of aspirin is not beneficial in patients undergoing elective non-cardiac, non-carotid surgery who have not had previous coronary stenting, unless the risk of ischemic events outweighs the risk of surgical bleeding. There is continued controversy regarding withholding ACE inhibitors and ARBs 24 hours prior to the surgery. These agents may lead to prolonged intraoperative hypotension in patients being chronically treated with them. ACC-EHA recommend continuation of ACE inhibitors or ARBs perioperatively, unless the surgical process involves major fluid shifts or significant blood loss. If ACE inhibitors or ARBs are held before surgery, it is reasonable to restart them as soon as clinically feasible postoperatively. The goals of preoperative evaluation include to provide clinical risk profiling, to decide on further testing, to treat modifiable risk factors, and to plan the management of cardiac illness during perioperative period. History and physical examination should focus on current complaints, functional capacity, comorbid conditions, RCRI risk factors, and also on pre-existing ISD. ACC-EHA recommend the use of validated multivariate risk indices like Duke Activity Status Index for predicting the risk of perioperative MACE. Routine preoperative resting 12-lead ECG is not recommended in patients undergoing low-risk surgical procedures. Although preoperative resting 12-lead ECG may be considered for both high-risk or asymptomatic patients undergoing high-risk surgical procedures. Routine preoperative evaluation of LV function is not recommended. LV function assessment may be considered in patients with dyspnea of unknown origin, patients with heart failure dyspnea, patients with known LV dysfunction who have not been assessed in last year. Screening with non-invasive stress testing is not recommended for patients undergoing low-risk surgery. Screening with non-invasive stress test is again not recommended for patients having functional capacity more than equal to 4 METs who are undergoing high-risk surgery. That means preoperative stress testing may be undertaken for patients with unknown functional capacity or functional capacity less than 4 METs who are undergoing high-risk surgery, and that too only if it will change perioperative management. Here is a stepwise approach to preoperative cardiac testing in a patient posted for non-cardiac surgery. The first step is essentially defining whether surgery is an emergency procedure or an elective procedure. If the surgery is an emergency procedure, patient can be taken up for surgery only after clinical risk stratification, no further testing. If the surgery is not an emergency surgery, we need to determine whether patient is currently in ACS, acute coronary syndrome. If the patient is in ACS, he should be referred to a cardiologist for optimization. If patient is not in ACS, then his or her perioperative risk be calculated using RCRI risk factors. If the patient is categorized as a low risk patient, then no further testing is recommended and patient should be taken up for surgery. If the patient is categorized as an elevated risk, the patient's functional capacity should be calculated, should be assessed. If the functional capacity is greater than equal to 4 METs, no further testing is recommended and patient can be taken up for surgery. But if the functional capacity is less than 4 METs or is unknown, then it should be decided whether further testing would impact decision-making or perioperative care. If the answer is no, then no further testing, patient can be taken up for surgery. If the answer is yes, the patient should be subjected to preoperative stress testing.
Could I point out something here, Dr. Devang?
Yes, ma'am, please.
The previous slide, right. So I want you to look at that particular box here, which says that the estimated, it's after ACS. When ACS is not present, the first step says you need to estimate perioperative risk of MACE based on combined clinical and surgical risk. I just saw somebody had sent in this question also, that even if the patient's the patient characteristics is a low risk, but the surgery is not a low risk, then what's the combined risk? So we just want to emphasize here, which we made our case also to emphasize. Even if patient was asymptomatic for IHT, he did not have any elevated risk for MACE per se as per RCRI, and his surgical risk is not low risk, then he fits into further testing protocol, okay, as per this. Thank you, thank you.
Routine preoperative coronary angiography is not recommended. Revascularization before non-cardiac surgery is recommended only in circumstances in which revascularization is indicated into existing clinical practice guidelines. Coronary revascularization exclusively to reduce perioperative cardiac events is not recommended. Elective non-cardiac surgery should be delayed for 60 days following an episode of MI without coronary revascularization, 14 days following balloon angioplasty, 30 days following bare metal stent implantation, 6 months, preferably 12 months following first generation drug-eluting stent implantation, 3 months, preferably 6 months following second or third generation drug-eluting stent implantation. The goal of anesthetic management is to prevent myocardial ischemia by avoiding factors that increase myocardial oxygen demand or decrease myocardial oxygen supply. As pre-medication to decrease and reduce tachycardia and although the indiscriminate, especially in elderly, should be avoided. Excuse us for this disturbance. It's better now. Various multicentric trials, like Master, have failed to demonstrate any distinct advantage and neuraxial anesthesia techniques with respect to perioperative cardiac morbidity and mortality. Thus, the current ACC-AHA guidelines recommend that the choice of anesthesia technique be left to the discretion of anesthesia care team and should be determined by factors other than prevention of perioperative myocardial ischemia. Intraoperative monitoring includes use of ECG, invasive BP monitoring, ETCO2 monitoring, pulse oximetry, FiO2 monitoring, temperature and urine output monitoring. Pulmonary artery catheter use is not recommended, and routine use of transesophageal echocardiography is also not recommended. Although TE may be used in patients at high risk for developing myocardial ischemia who are undergoing major non-cardiac surgery. The intraoperative goal is to minimize both hypotension as well as sympathetic stimulation during induction and tracheal intubation. Induction agent should be administered slowly in small incremental doses. Etomidate is the induction agent of choice because of its better hemodynamic profile. Ketamine and pancuronium should be avoided as they may cause tachycardia. Laryngoscopy should be swift and gentle, lasting for less than 15 seconds. And agents like opioids, lidocaine, and beta blockers may be used to attenuate the stress response associated with laryngoscopy and tracheal intubation. Various meta-analyses have failed to demonstrate any difference in MI rates in patients receiving volatile anesthetics and those receiving TIVA. ACC-EHA recommend the use of either of these agents, with the choice being determined by factors other than prevention of perioperative MI. There was some controversy regarding the use of nitrous oxide in patients with IHT, but the ENIGMA-2 trial has established that its use is not associated with increased risk of cardiovascular morbidity or mortality. Hyperventilation and hypothermia may evoke coronary artery vasoconstriction and should be prevented. Good analgesia and adequate depth of anesthesia should be maintained at all times. Although neither ACC-AHA nor ESC offer any recommendations over the cutoff value for initiating blood transfusion, maintaining hemoglobin levels over 10 gram per deciliter is advisable. Assuming no intraoperative complications, patient may be awakened and trachea extubated following completion of the procedure. Low dose of medications like lidocaine or beta blockers may be administered before emergence to reduce sympathetic response associated with extubation. Post-operative period is crucial for these patients as most PMIs occur early after surgery and 90% occur within 7 days. Continuous ECG monitoring should continue in post-operative period, and serial 12-lead ECG and troponin measurements may be used for patients at high risk of developing ischemia. Supplemental oxygen should be provided, blood transfusion if indicated, analgesia in the form of IV PC and PCEA pumps, and normothermia should be maintained. Perioperative MI may be diagnosed firstly by keeping a high index of suspicion for at-risk patients, using clinical signs and symptoms like chest pain, using the ECG changes like ST segment and pathological Q waves, and measurement of biomarkers of cardiac injury like cardiac-specific troponin. Management of perioperative MI essentially includes the use of supplemental oxygen, opioids, nitrates, beta blockers, antiplatelet agents, heparin, and essentially PCI and CABG techniques. Thank you and good luck.
I think that sums up everything from our side. So.
Thank you, Dr. Devang, for summarizing, and thank you, ma'am, for such a detailed case discussion. I'm sure delegates have benefited from that. Now, let us move on to our next session, which will be chaired by Dr. Ramesh Kashyap. Shobit, please put the CV slide. Dr. Professor Ramesh Kashyap, he is consultant and head of cardiac anesthesia department in AB Wilms and Dr. RML Hospital. His work experience is in cardiac anesthesia. He started cardiac anesthesia in Dr. RML Hospital and now started DM in cardiac anesthesia. He has so many national and international publications to his credit. I welcome you, sir.
The speaker is Dr. Poonam Kapoor. She is professor of cardiac anesthesia, All India Institute of Medical Sciences. She has done a lot of work right from beginning, and she has many publications as a books and also in journal. She was a editor of Society of Cardiac Anesthesia and very good orator. We have so many experience with her, and she teaches so well, and all students will be benefited from her lecture. Now, Dr. Poonam Kapoor, please.
Thank you, Dr. Ramesh. I'm sorry, I'm from the hospital itself. I'm calling from my OT. I hope I'm audible. Am I audible?
Yes, very fine.
It's a pleasure and a very good congratulations to you, Dr. Ramesh, and to Dr. M.D. Kaur and the entire team of RML to do this grand PG assembly in COVID times amongst all the tumultuous happenings. It's a very great effort. I myself am a part. I was born in RML and brought up around RML, and for me, RML is home. And thank you for giving me a topic on CABG, because I personally feel this is the bread and butter of all cardiac anesthetists. So I've tried my best to do the thing, and I'm available for any questions at the end of the recording. Thank you so much. Thank you, Shivpriya, and thank you, Dr. Kaur and Dr. Ramesh.
Please carry on.
Thank you, ma'am.
Respected organizers, respected chairpersons, senior faculty members, and my dear students. A very good morning to all of you. At the outset, I would like to
The
thank
slide is wrong.
organizers.
Now, Mr. Shobit, this is pediatric regional anesthesia. My talk is CABG. This is Dr. Mehtani, Poonam Motiani, sorry. I'm Dr. Poonam Malhotra.
Dear doctors.
Can I play my...
Doctor, can you play from your side?
Yes, I can. I'll play from my end. Just give me 1 minute. It will take a minute. Hello everyone. Coronary artery bypass grafting.
Dr. Poonam, can you share screen?
I'm doing that. It's coming.
Please.
It's coming. Otherwise, I can speak live also. If it doesn't come, I'll speak live. I thought I saw it in the morning. It was not downloaded. So that's it. Is that
a very pertinent subject in 2021? Yes. Thank you to the organizers for giving me this topic. Why? Because so many people today are inflicted with atherosclerosis-ridden ischemic heart disease. From 18 to 85, 90 years of age, everyone suffers. And at AIMS, it's our endeavor to try to do on-pump as much as off-pump. And today in this outline, as I give you greetings from my alma mater, AIMS, I want to outline, we'll be doing the definition, review of coronary arteries, the indications, the contraindications, a detailed procedure overview from the anesthetist point of view as what you should look into, also the ventilatory management and the complications. The types of CABG are, as described, a non-pump CABG, an off-pump CABG, a mid-cap CABG, and a robotic CABG. Now, this procedure here on the right side in the running video outlines right from the incision that you make from the sternal notch to the zippy sternum, a big long incision in the classical unpumped CABG or an off-pump CABG. You are all the time using stabilizers or procedures to compress the heart. As you harvest the internal mammary artery and retract the pericardiums and harvest the mammary arteries, and then begin your distal and proximal anastomosis, it is imperative to know the contractility of the heart, the preload and the afterload of the heart. So monitoring is very, very important as we go on. But let's first go to the history of heart surgery. As early as 1930s, heart surgery, which seemed impossible, became possible with the Gibbons 1937 designing of the heart-lung machine. In 1955, Wienerberg and Wöhler implanted the internal mammary artery into the myocardium to treat cardiac ischemia and angina. And in 1960s and 70s, CPB and cardioplegic arrest were adopted, allowing coronary artery bypass grafting to emerge as a viable surgical treatment of ischemic heart disease with heart failure. If we see the conventional CABG, most common arteries which are bypassed are the left anterior descending artery, the right coronary artery, and the circumflex coronary artery. The saphenous vein is used for bypassing the right coronary artery and circumflex coronary artery. The internal mammary artery is generally used for bypassing the left anterior descending coronary artery with a patency of more than 90% over a period of 10 years. And if more veins are needed, then alternative sites such as the upper extremity veins can be taken, and the patency of other veins beyond the great saphenous vein is 47% after 4.5 years. So we should be preferring a larger vein like the great saphenous vein of the leg. Conventional CABG, the conduits are removed from the body of the patient. The median sternotomy done with an electric saw. Cold potassium cardioplegia is given. Cardiopulmonary bypass with cannulation of the ascending aorta, the femoral artery, right atrium is done, and the SVC in some cases, and heparin is administered to minimize the clotting at the rate of 4 milligram per kg body weight. The bypass of arteries is incision in the target artery. As you can see, a small incision is made in the LAD here, and you choose the site. The surgeon does that. The positive is of the CABG is there is a very big relief of the angina to the patient in 90% of them, and 80% of them remain angina-free after 5 years with a survival of 95% after 1 year, and the chances of restenosis are less. The negative is the patient is spending 2 to 3 days in the ICU, a total of 7 to 10 days in the hospital stay. 3 to 6 months it takes for a full recovery, and 5 to 10% may develop post-op complications. We'll discuss them. And long time on CPB causes a neurological sequelae of depression in the patient, post-operative bleeding, and of course hypotension with a feeling of numbness and chest pain on and off. So CABG we define as a surgical procedure to relieve angina and reduce the risk of death from coronary artery disease. Arteries or veins from elsewhere in the patient's body, the internal thoracic arteries, the radial arteries, and the saphenous, are implanted to the coronary arteries of the patient by using a bypass, atherosclerotic narrowing, and improving the blood supply to the coronary circulation, supplying the myocardium. This surgery is generally performed with the heart stopped. Now, what does a double, triple, or a quadruple or quintuple bypass refer to? They refer to the number of coronary arteries that are being bypassed during this procedure. In other words, you have a double bypass, which means 2 coronary arteries are bypassed. A triple bypass means 3. Generally, the LAD, the RCA, the left circumflex are this thing, bypass. The quadruple means the LAD, RCA, left circumflex, and also the diagonal of the LAD. Let's remember the diagonal has obtuse, marginal, OM1, OM2, and OM3, and also the diagonal branches of the LAD are there, and posterior descending is the branch of the RCA. Bypass of more than 4 coronary arteries is generally uncommon. The review of coronary arteries, if you do, you have the major from the left main coronary artery, you have the left coronary and the right coronary descending. The right coronary goes posteriorly into the posterior descending artery and the marginal artery, whereas the left coronary artery becomes the circumflex and the main, and this gives rise to, and the main LAD, and the LAD gives rise to the left marginal or the obtuse marginal artery, the diagonal arteries, and that's what you see in the anterior part of the entire LV is the LAD. So the purpose of CABG is to restore the blood flow to the heart, relieve the chest pain and ischemia, improve the patient's quality of life, enable the patient to resume a normal lifestyle, and lower the risk of a heart attack. The indications are patients with blockages in coronary arteries due to atherosclerosis, patients with angina, patients who cannot tolerate a PTCA and do not respond well to the drug therapy, acute myocardial infarction, and severe coronary artery disease. The contraindications are aneurysms, valvular diseases, congenital diseases, and diseases of the blood, such as hemolysis or sickle cell anemia. One would think twice. An endotracheal tube is inserted, secured, and mechanical ventilation is started. From the anesthesia side, general anesthesia is maintained generally by a continuous slow infusion of propofol. We generally don't use propofol except as an induction agent. We maintain on fentanyl midazolam. But this is briefly what is done in most centers. The chest is opened via medial sternotomy, and heart is examined by the surgeons involved, creating a 6 to 8 inch incision in the chest. The heart is cooled with ice salt water while a preservative solution is injected, which is the cardioplegia, into the heart artery. This process minimizes damage caused, and this is known as myocardial protection, which the cardioplegia, which contains enough of potassium, magnesium, and calcium to stop the heart, and provides a good amount of glutathione and other substances, important essential salts, which are physiological nature to the heart milieu. This cardioplegia on cardiopulmonary bypass is the standstill to the heart, and this is known as cardioplegia. The most commonly used grafts for the internal thoracic artery, the radial artery, the saphenous veins, and when the wanted vessels are harvested, the patient is given heparin to prevent the blood from clotting. So before the bypass surgery can take place, a cardiopulmonary bypass must be established. So plastic tubes called cannulae of different sizes are placed in the right atrium to channel out the venous blood of the patient's body for passage through membrane oxygenator, which is a part and parcel of the cardiopulmonary bypass heart-lung machine. Now, this machine, as shown in this picture, has to the far right a monitor which tells us about the SpO2 and the hematocrit. On the left side, there is a venous reservoir, which is a big hard shell reservoir, which has all the priming volume of the patient's blood, to which fluids, blood, etc. are added, along with heparin and other drugs, even the anesthesia drugs made before we go on bypass or during bypass and before we come off bypass. And you have the membrane oxygenator, which is the lung of the patient, the artificial lung of the patient, through which the deoxygenated venous blood comes from the patient, goes through the membrane oxygenator and goes back to the patient as an oxygenated blood into the arterial cannula. Now, this heart-lung machine has a heat exchanger so that the patient's blood can be cooled down to 18 degrees and again rewarmed to 37 degrees or 35 degrees as we normally do. It also has the membrane oxygenator, it has an arterial filter, it has the cardioplegia line with the cardioplegia small filter, and it of course has the centrifugal pump, which is the pump like the heart, analogous to the heart of the body and of the patient's body, through which gives you the driving pressure through which the RPMs of the roller pumps or the centrifugal pumps that you're using in the cardiopulmonary bypass machine runs. So that is the RPM of the pump, and that is the driving pressure. The driving pressure would vary according to the body weight as well as the speed of the kind of the manufacturer's details of the pump being used. You have different pumps, the Sorin, the Biomedicals, the Mecke. There are so many companies making different pumps, but one must be well versed as a perfusionist and an anesthetist. What is the size of your arterial tubings? What is the size of your venous channels? What is the size of the oxygenator, the company? And for how long can you keep this cardiopulmonary bypass machine in situ for the procedure to go on? Is it 7 hours, 10 hours, 21 hours? Every pump, every oxygenator has a duration of use in number of hours. So minimally invasive surgery, the second type of surgery after open heart lung surgery, it does not require a cardiopulmonary bypass. A smaller incision is given, not a 7-8 inches incision. It is emerging fast in the last 1990s. Since then it has emerged as a replacement for the conventional CABG. And since 1990s, you have the mid-cap minimally invasive coronary artery bypass, which has gained popularity. We'll talk about it, and it is normally done when you have direct grafting of the lima to the LAD. Now, the advantages of a conventional CABG or a mid-cap CABG are generally you don't require a sternotomy and a CPB. The number of hours it takes on a mid-cap are less. Recovery time is much, much faster. It's within 2 weeks, the patient is back to work. Effectiveness is 90% in both. The incision length is just about 10 centimeters, but it's 3 times, generally 30 centimeters in a CABG. Additionally, mid-cap reduces the need for blood transfusion because you're not going on bypass, you're not cooling the patient, hemodilution is less, hypothermia is less, the need to add blood is less. And it is less time under anesthesia. Patients are moved out of intensive care more quickly. There's less pain and discomfort, and the cost effectiveness is much, much more to the hospital, to the patient, and general stay is less in the ICU as well as in the wards. So this is a mid-cap procedure. You have a right thoracotomy incision, which is about 10 centimeters, and small incisions can be made if you're doing a video-assisted lima harvesting under a robot or using a VATS procedure. That's also come in a big way, and we can go on. But there are a lot of contraindications also where we should not use the off-pump CABG. There are some absolute ones, like if the patient is in shock, any kind of shock, especially cardiogenic shock, major ischemic arrhythmias, relative contraindications are if there are very small vessels which are to be, you have enough collaterals and the vessels are thin, small, intramyocardial target vessels, or you have calcified target vessels where you contemplate that the surgeon may have to do an end arterectomy to reach the native vessel where the anastomosis will be done, or the LV function is very poor, or the RV function is poor, and you have ejection fraction which is very low, or patients who have a deep pectus excavatum, there's a bony deformity and marked leftward displacement or rotation of the heart, and if the patients are undergoing a reoperation. So patients who have, this is as early as 2020, a very beautiful study done in the Journal of Biosciences, which came out in July last year, it said that acute renal dysfunction after coronary artery bypass grafting in patients with coronary disease, if you compare the on-pump and the off-pump, then on-pump coronary artery bypass surgery causes significant renal dysfunction in the immediate post-op period compared to off-pump coronary artery bypass surgery. This suggests that off-pump CABG offers superior renal protection and has significantly lower risk for renal dysfunction in patients undergoing coronary revascularization. This is the ROC curve that you see, and this is patients undergoing either an off-pump or an on-pump. Comparing the mortality in the patients, if you see a 5-year off-pump is 76.9% and an on-pump is 55.3%. A 1-year is 42 versus on-pump 29.7. And this is the freedom from readmissions that they have seen, and this readmission rate is much, much lower in off-pump versus off-pump. And in the same study, they've shown that the mortality at 5 years is associated with potential benefit from off-pump CABG are in acute coronary syndrome. If you related factors, then cardiogenic, this is the on-pump CABG, then early graft failure, emergency surgeries, maybe some redo surgeries, left ventricular dysfunction, intraoperative factors, difficult to approach coronary targets, high risk of complications using off-pump techniques like intramyocardial vessels or unstable hemodynamics, and poor quality coronary targets, that is diffuse calcification and small diameter. So when you have something like this coming up from the Journal of Cardiac Surgery, which says that off-pump would be in these circumstances, and a lot of controversies are for redo complex surgeries with a low ejection fraction. One is the dilemma there, but that is a surgeon and a cardiologist approach where peak may not be consulted, but one must know a redo and sometimes a double redo CABG coming to you for maybe 1 or 2 grafts. It benefit
Hello, there is no audio. Hello. Hello.
Shobhit, please see, audio is not there.
No audio, no video.
Dr. Poonam is not there in the platform.
I think it is a problem with Dr. Poonam's network, and that is why she has left the meeting also.
We have a recording.
And
Yes,
so we
doctor,
can
yes,
play
doctor.
her recording. Let us just try and play her recording.
I think if you have a recorded, please continue.
Yes, sir, we have a recording. We will just play it. Shobhit, please stop sharing your screen.
Doctor, there is no audio for this. I think you need to stop sharing and you need to enable sound.
Okay, Shobit, just play your recording.
Dr. Ramesh, I will play from 23 minutes again. Aap mat kariye, I will play. I think there was something happening at your end, but I will play again because this way double is coming.
Okay, ma'am. Okay, ma'am.
Thank you.
Okay, ma'am. Dr. Poonam, ma'am, can you start the video presentation, please?
Doctor, when you share the screen, you need to enable share sound.
Dr. Poonam, you are in touch.
Yes,
Dr. Poonam, can you play?
Ma'am, you have to enable the sound.
So actually, we cannot be fully dependent on the technology also.
We are trying again. We are trying once again.
Ma'am, if you want, then we can start the video which you have shared with us from here also. Because we have ensured the connectivity, so we can start from here also.
No, connectivity is all right at my end. Only thing is it's coming at my end, but it's not coming from your end. So slide number 31.
Yeah, please, from slide number 30.
31.
We'll play it.
Yeah.
This is 21. Slide number 21 is this. इस पे थी ना मैम. Okay, so we have to.
Connecting, it's important that everyone who's listening should know that people who are doing a CABG and giving anesthesia for it need to be very well versed with the kind of blocker that we are using, the depolarizing or the non-depolarizing. We generally prefer in today's day and age to use vecuronium and avoid pancuronium-induced tachycardia in these patients. We induce with rocuronium and maintain on vecuronium, or we can also maintain on rocuronium as such. Rocuronium or atracurium FPC has very good short half-life, easily titrable, and minimal renal dysfunction when we are using cis-atracurium. So those are important things. Are you connected? Then we can begin. Are you connected?
I'm just a minute. Ma'am, from here, I'm going to start.
Right. You can go full screen and start. You want me to do it live? I can do it live in case you're having problems. Are you okay? Should we try once?
I'm just seeing. हाँ वीडियो ये रहा. मैंने स्क्रीन शेयर किया हुआ है ना उसमें. Ma'am, can you stop sharing your screen, please?
Yes, yes. We have not shared.
Okay, ma'am. Okay, ma'am.
Yes. Slide number 31.
Yes, ma'am.
20 minutes, 23 minutes. Slightly more back. Slightly more back. More back. Yes. Slightly more. We can begin from here. We can begin from here. We have finished the anesthesia part. We can begin from here. So once you have maintained on non-depolarizing blockers like vecuronium, rocuronium, or cis-atracurium as the patient may be, and doing
Poonam ma'am, I think first we let this video run and then we can have a discussion with you.
Can I speak from this if you're unable to see?
Ma'am, we are able to see, ma'am.
So can I speak extempo from
Okay,
here?
ma'am.
Is that okay with you, Dr. Sarupriya, Dr. Ramesh,
Yes, ma'am.
Dr. Shivpriya?
Yeah, ma'am, you can start, ma'am. You can speak, ma'am.
So we are seeing how an incision is made and how we are seeing the heart being put onto slowed motion. We use intracoronary shunts. We put an LED over the native LED, that's a Lima graft. You can see the blue one here, which we put over an LED. And once we do on a, as you see in the video recording, on a beating heart that we do without giving cardioplegia, the comparisons done in this very recent study on the ventilatory management of off-pump versus on-pump using two modes of ventilation, the PRVC mode and the pressure controlled ventilation. Now, the authors in this study, which they did, I'll show you the ROC curves, they said that the PRVC mode has a distinct theoretical advantage over the pressure controlled ventilation, that it provides the target tidal volume at the minimum pressure and may improve advantageous and prove very good while ventilating these atelectic lungs, because you are inducing in off-pump CABG a reduced tidal volume. You come down on your tidal volume, the patient's body is shifted a bit towards the left to harvest the Lima, then you come back to the neutral position on the table, and with low tidal volume of about 3 to 4 ml per kg body weight, you start ventilating your patients on a ventilator when the harvesting is going on. So either you use a volume controlled or a pressure controlled or a PRVC mode, where the authors found that the PRVC mode is better in terms of a better oxygenation index. Why? Because the PaO2 upon the FiO2 and the mean airway pressure when multiplied was always found to be more than 1. So this was a very good study which studied the oxygenation, seeing the PaO2 and the FiO2 with different modes of ventilation while on off-pump CABG. And they said that the PRVC mode is much better than a pressure mode where the mean airway pressures may remain very high because you're giving low tidal volume and the minute ventilation therefore is less. Now, the authors therefore concluded that PRVC will be a more useful in certain group of patients to reduce the intrapulmonary shunt. The weaning is done in the pre-weaning and the weaning criteria. And when we see the pre-weaning, there is no acute ischemia, hemodynamically stable, the blood loss is less than 2 cc per minute per hour, the urine output is more than 1 cc per kg per hour, and it demonstrates signs of awakening from anesthesia with a core temperature more than 97 degrees centigrade, then the Fahrenheit, and patient is ready to be awakened. Now the patient is awake, is cooperative, follows your commands, is able to lift the head of the pillow, has a PaO2 more than 80 with an FiO2 more than 0.4, a PEEP more than 5 centimeters or less, and your tidal volume is coming down with spontaneous tidal volumes of the patient being more than 5 cc. You are assessing the patients with a CPAP of 5 centimeters water with a pressure support of 5 centimeters of water for up to 20 to 30 minutes. After an hour of CPAP, if the ABG maintained shows a pH of more than 7.35, a PCO2 of less than 45, a PO2 of more than 80, and an FiO2 of less than 40, then the patient is ready to be extubated with a tidal volume more than 5 cc per kg of the patient on its own. Now, as we go on to using this flash player that they are doing, we have extubated the patient, and the criteria that we've seen is that a patient's tidal volume is more than 12 ml per kg. After extubation, you will continue to oxygenate the patient with the aerosol mask of 40% oxygen at least. And after 4 hours, the patient can be placed on a 5 liters per minute humidified mask. And post-extubation, IPP should be stopped and can be given by a mask with not a nasal cannula at this stage. But remember, IPPB can be done with racemic epinephrine, which may reduce the glottic edema and the swelling which is caused by the tube in situ for nearly 7 to 8 hours. Now, patients who have a history of smoking may need an aerosol of a bronchodilator like albuterol or salbutamol. Other patients will receive normal saline with each treatment, and when patient is alert, then incentive spirometry can be used to make these atelectic lungs become inflated again. The patient uses his or her own breath in raising the balls that we see and blowing into the spirometer. Bleeding, heart attack, heart failures, recurrent arrhythmias due to hypo or hyperkalemia or calcemia, stroke, pleural effusions, renal failure, wound infections, mediastinitis, and mortality are all possible in the first 3 to 4 days. And therefore, when we start CABG, I think we missed out on the video. But what I would like to talk about today would be more detailed about the TE in off-pump CABG. Now, TE is a very, very good tool for seeing the LV function, the wall motion, the right heart function, and also the valves, all the major 4 valves, especially when we are doing an off-pump CABG, because in an on-pump CABG, we are on the bypass. So during bypass, the heart is at a standstill. But in a beating heart or for off-pump, when we need to rule out renal insufficiency, worsening heart rates, worsening regurgitations, reducing the CPB associated or the other morbidity, mortality, which the patient may go into sudden cardiac arrest. Then close cooperation between anesthetist, surgeon, and the standby perfusionist is important. Remember, off-pump also comes with its disadvantages. Severe LV dysfunction, redo surgeries, the grafts may not have a complete revascularization, so early closure of the valves of the grafts is possible. Hemodynamic changes due to ischemia may be ongoing, reduced preload, cardiac compressions, myocardial dysfunctions, cardiac manipulations, mitral regurgitation, worsening of a TR or MR are signs that the patient's heart, which is lifted up, or maybe some sponges put under the heart, needs to be verticalized and brought to a standstill. So when we are doing things like distal anastomosis, there may be hypotension, there may be increase in the CVP pressures, because in the distal anastomosis, the heart is lifted up. But any hemodynamic variables, whether it is the stroke volume, the mean arterial pressure, the cardiac output, or the mixed venous saturation, or with the parameters that may be increased, all your pressures, intracardiac pressures, LA pressure, RA pressures, left ventricular and diastolic pressures, pulmonary arterial pressures, the pulmonary capillary wedge pressures, all will be increased. The goals of hemodynamic change would be a decompensation, a deterioration, and maybe a collapse. So there is a mild transient ischemia if it's a deterioration, and a moderate or a severe ischemia if there is a protracted hypotension and the patient needs to be done from an off-pump into a severely on-pump CABG. So restrictive diastolic filling pressures, compression of the ventricles, regional diastolic functions, and myocardial ischemia is all ongoing when parameters are decreased in hemodynamic variables which happen during verticalization of the heart, when particularly the distal anastomosis is being done. Now, during intraoperative echocardiography, you see the global LV function, the RV function. You look out for the mitral, aortic, tricuspid, and the pulmonary valve. If any of them have a regurgitation, see whether that regurgitation, ischemic mitral regurgitation, is a part and parcel of an MI, and so is a VSD. So maybe a thinning out of the LV aneurysm or a worsening of the ischemic MR may all happen during an off-pump CABG. Look out for these. Generally, there is partial clamping of the aorta. So a quick epi-aortic TE scan is done of the ascending aorta to rule out any calcification. When you have all these going on, then during graft reconstruction, compression of the right heart, mitral or aortic regurgitation, any kind of effects of stabilizer, what happens when the stabilizer is put? There will be compression of the LV. There will be a change in wall motion due to stabilizers. There will be effect of vessel occlusion. And there will be TE signs of an impending doom. There would be deterioration of the global LV or RV function and increase in the MR or the TR, which means the ischemia because of the raised intracardiac pressures is worsening. And this worsening ischemia is not going to be helped by the protracted hypotension. So one needs to be very, very careful. You must know what type of stabilizers are put. Is it a fork type in which, sorry, there would be an increase in the mean arterial pressure, a decrease in the pulmonary artery pressures, and a CVP after the stabilizer is removed. In an off pump, remember the pulmonary artery pressures, if they are decreasing and your mean arterial pressures are pulmonary artery pressures are increasing, mean arterial pressures are decreasing, it means the ischemia is worsening. So that is when you need to tell the surgeon to give some rest of 5 to 10 minutes to the heart and maybe pep up your inotropes, giving an epinephrine or an epinephrine or a dopa or a glutamine. So systolic functions are very important to be watched out on. You could do it by doing a fractional aid change. You could do it by doing seeing the ejection fraction of the patient and see what when you have from the baseline the E wave decreasing and the A wave increasing, it means this is an LVOT compression caused by a stabilizer. It is not a regional wall motion abnormality. Whereas both of them will cause an increase in your filling pressures. Your RAP and your CVP and your PAP will increase. But the moment you remove the stabilizer, the PAP will decrease along with the CVP. So that's the thing. Here you see the pulmonary vein Doppler velocities. 4 of them are there. I won't go into the details, but you must know early systole PVS1, late systole PVS2, the diastole is PVD, and the atrial reversal is PVA, which has a negative baseline. They all determine the LA relaxation or the LA contractility and the LV compliance or the LV relaxation. These are how you see the SD ratios. If you see the SD ratios on PVS and PVS1 and 2, you can see that the S is always less than the diastolic, and in high LA pressures, more than 15, your diastolic would be more than the S, and it will be the compression effect. So we are used to seeing the pulse wave Doppler, and we are used to I see the video? The PVS and the PVD, which tell us about the filling and the relaxation of the ventricle. If the S is more than D, it's normal. But so when you see type stabilizer, restrictive diastolic dysfunction. So echocardiographic assessment of the left ventricular systolic function on a big method, the fractional area change. The fractional area change is proportional to the short axis during the systole. It is the end diastolic area minus the end systolic area into 100, and the fractional area change is calculated like this. The Simpson's rule is used to calculate the ejection fraction. The stroke volume is end diastolic volume minus the end systolic volume, and in the estimation of ejection fraction, stroke volume and cardiac output can also be calculated. Stroke volume is usually derived from Doppler and 2D data. Stroke volume may be normal despite a decreased EF or vice versa. So this is stroke volume that you calculate on the Simpson's rule. I won't go into the details because this is not an echo class, but remember you have 3 important parameters for systolic function. One of them is fractional area change, the other is the ejection fraction, and the onset of new regional wall motion abnormalities with S and D being seen on the pulse wave Doppler. Whereas if you have isovolemic relaxation time on the mitral inflow pattern of through an aortic outflow pattern, and you have the mitral inflow velocities of E and A, and you have the deceleration times, and if you see in abnormal waveforms a reduction in size of D wave, SD ratio more than 1, or a pulmonary venous A wave more than 0.35 meters per second, this is pseudo-normalization diastolic dysfunction. So diastolic dysfunction and off pump may not be seen so much and reported so much, but remember, diastolic dysfunction depends on the geometry of the LV, the compliance and the relaxation of the LV, which are going to change minute to minute and second to second during an off-pump CABG. Everything is dependent on the pressure volume curve, whether it moves to the right or the left when you do the anastomosis. The moment the proximal and distal anastomosis is done, your pressure volume curve will move to the right or stay in its normal place. The oxygen capacity would increase. But there is tissue Doppler, there is stress-strain relationship, which are details which one must not know at your level. But it is important to know that a combination of properties are there to tell us about the anterior displacement of a beating heart, which leads to RV deformation, prevents normal RV and LV diastolic expansion, and causes RV diastolic dysfunction. And RV diastolic dysfunction can be very well visualized on an ultrasound in the posterior wall in a displaced 90 degrees deformation of the RV, as you can see in panel B. And when you do a Trendelenburg 20 degrees recovery with the head down, you can see the cross-sectional area of the RV. So if you see the off pump with octopus tissue stabilizer system, you'll see that the stroke volume decreases significantly by dislocation of all the target vessel sites, whether the LAD, the diagonal, the RCA, or the obtuse marginal. There is an increased surgical exposure, increase in preload, cardiac output, and decrease in the ventricular filling pressure. And that's why you have the diastolic dysfunction. So you see for diastolic dysfunction, your IVR in the cardiac cycle. You see the early filling in diastole, the diastole major pattern, and you see the atrial late filling in diastole. And this is what your EM velocity and EA velocities will look like. So you do mitral and pulmonary venous flows across the pulmonary vein, and you see for abnormal relaxation, you see for the blunting of the S wave, which is stage 2, and you see for blunting of SND in stage 3. So whether it is early pseudonormal or restrictive filling, or you have stage 1 of delayed restrictive filling, or stage 2 of pseudonormal, and stage 3 of complete restrictive filling, it is important to have a measure of your systolic and diastolic factors. Now, coming up in a very major way has been the propagation velocity, where we use the color flow Doppler, and the color M mode flow propagation velocity, that is the VP of blood within the LV, is the slope of an iso velocity line connecting the mitral leaflets to some point in the ventricle. So as the mitral leaflets open and close, you have two mitral leaflets, the septal, the anterior and the posterior, and the anterior is the bigger of the two. The posterior is normally short and thick and fixed in most patients with IHD. And when you have the mitral leaflets moving into the LV, the velocity across is normally more than 55 centimeters per second. A diastolic dysfunction is said to be there if your velocity, propagation velocity is low, if it is less than 55 centimeters per second. So you can easily do the color M mode in a mid-esophageal LV view, and VP by slope of the color E wave is done, and it is reduced if you have a restricted filling, as in type 3 diastolic dysfunction. Now, very often you'll see collaterals develop because of ongoing ischemia. So the main vessels have narrowed, the LAD, the RC, and the branches. But if you see, most of the patients will have collaterals. On T, you can also visualize them. So LAD occlusion with octopus should not be for more than 15 minutes. All disturbances should be normalized within 10 minutes of reperfusion once the stabilizer is removed. And highly obstructed vessels which are supplied by collaterals flow should be grafted first to provide flow into more critical vessels before they are grafted. And indications for echo assessment are grade 1 and grade 2 for all complex restenosis patients, revascularization patients, and routine asymptomatic patients. We can know on 4-chamber view, on 2-chamber and long axis view, the basal, the mid, and the apical segments. There are 17 segments. The apex is the 17th segment. This is 16th segment. You have now the 17 segments, and you can see the regional function, the regional flows on different segments, and you can see the normal function when your blood flow, coronary blood flow to the normal value of the function and flow of the blood through it is normal. As it comes down due to atherosclerosis, blockages in the vessel, you can see the curve, and gradually, this is when we put the stabilizer on the myocardium, and as the stabilizer is removed, you can see gradually the reflow happening and the blood coming up again. Now, during this period of blockage, when you put, there may be regional wall motions due to further stress of ischemia or cardiomyopathy or a bundle branch block happening. It can be at rest due to a hibernating myocardium because of the octopus or the afterload mismatch or toxins or pace rhythm, pressure, RV pressure volume curve not being right, and too much of pressors or too little pressors are used. Whatever the reason, the endocardial thickening and the endocardial deformation movement should be looked into. Regional wall motion abnormalities, if you have a normal function, will have an endocardial thickening of more than 30%. If your endocardial thickening becomes less, it becomes 10 to 30%, there is grade 2 score of regional wall motion, that is hypokinesia. A severe hypokinesia is less than 10% with minimal endocardial motion inward towards the ventricle. Akinesia, when there is no thickening or thinning and there is no motion inwards. And dyskinesia is when there is bulging into the systole. Normally in systole there is contraction, but when there is bulging and there is thinning during systole, it means it's a totally dyskinetic segment. So whether it is dyskinesia over a prolonged period, there will be a scar, and if it is in the LV, it will give rise to a aneurysm. So some of the individual segments should be the wall motion score index. Sometimes you're asked a small note on this. Some of individual segment scores after the number which is calculated, whether it is 16 segments or 17 segments or 10 segments. Wall motion score index quantifies the extent of myocardial injury, and a normally contracting LV has a wall motion score index of 1. So this is the mid-esophageal two-chamber view at baseline after the cardiac displacement and placement of an epicardial stabilizer. You can see the RCA. You can see here the Wang et al. Did 22 patients in anesthesia, analgesia, and you can see regional wall motion abnormalities of the LV beautifully in the apical and the lateral segments. Here again, you see on a four-chamber view, the mid, the basal, and the apical segments. On a transgastric view, you can see the two papillary muscles of the LV, the mid-papillary muscle view, where you have the posteromedial and the anterolateral papillary muscles coming to meet in the midline, giving us a very good idea on basal short axis view about in transgastric about the volume status of the patient. So transgastric true chamber view, any close observation in 4 to 5 different views for worsening cardiac function, for weakening, contraction, ventricular dilatation, and increasing MR or TR, with the development of higher cardiac enzyme levels, edema, atrial fibrillation, and regional wall motion abnormalities. So this is the worsening of the MR, which will happen once the stabilizer is in place or when the heart is verticalized. It shows the underfilling of the LV. Aggravation of the valvular regurgitation is a doom sign. It's not a good sign. And one should immediately tell the surgeon to replace the heart in its normal position. Now, this is another video which shows us hypovolemia. You can see the two papillary muscles in transgastric mid-papillary view moving into the midline and meeting there. It shows hypovolemia. It could be due to decreased PAP and CVP due to the stabilizer. It requires fluid loading, a Trendelenburg position, and hypotension. Improve the preload by giving volume and restore the cardiac output. So impact of verticalization of the heart is it impedes the atrial preload. And four-chamber view will show elongation of the LA, as you can see here, compression of the RA and RV, you can see on the right side, and distortion of the IVC and RA. And this is the place where regional wall motion abnormalities will come up. You can calculate the wall motion score index and see the endomyocardial movement. So important, this is the fork type stabilizer which has been put, a nick made into the native artery. You can see the blue colored intracoronary shunt there. And surgical plan and plan for use of shunts should be discussed with the surgeon. You must have a 3D picture of the coronary artery stenosis, either on an angiogram or by doing a 3D transthoracic echo or a 3D transesophageal echo, both in the long and the short axis. Perform proximal anastomosis, always in off-pump CABG before the distal. Allows flow to be directed through the graft to the vessel as soon as the distal anastomosis is completed. Make incision in pleura to the right of the heart so that the heart, which is to be elevated, does not have too much of compression of the IVC in the right side of the heart and gives you better hemodynamics. Stop the middle of the anastomosis to let the heart down on verticalization. If you see this kind of regional wall motion abnormalities. Either here the RV is not filling, or even the LV is not filling, and you can see that if one of them is not filling, it should be redone. Akinesia, MR and TR, if it happens, it shows transient ischemia due to verticalization. Document the baseline function in all these three and look for any new regional wall motion by getting an enzyme study done. We are into a use of different kind of stabilizers. They come in different patterns. They come with suctions. Carbon dioxide is introduced. These stabilizing devices could be fork type, could be producing different hemodynamic profile. They could be the suction type, octopus type, which are there. But whatever we are using and wherever we are, we must know how much of carbon dioxide or how much of suction and how much of air has been compressed into. Compression type of stabilizers provide minimal pressure applied by the stabilization device to avoid direct compression of the LV outflow tract, to prevent any diastolic dysfunction, compression of the beating heart for stabilization of the diagonal arteries. You must do um, different kind of views here to tell you about the bicable view, modified bicable view. Here at 90 degrees in a TEE, you can see on your right panel the entry of the SVC. On the above panel is the interatrial septum. You can see the cavity of the RA, and any cannula which is introduced through a robotic cannulation into the SVC RA junction would be seen here, whether also your PA catheter or your CVP. You can see a bit of the IVC on the left side, and you can see if you turn it towards on the right side, the entire transducer, you'll see the tricuspid valve. So look out for any kind of PFO, any ASD, any kind of left to right or right to left shunt. Excellent reproducible cardiac surface motion to 1 millimeter can be done if you see this view and you see the RA and the RV function through this view. So TE for IABP insertion requires which view? This is again a Viva question. The IABP is done and you can see the upper esophageal views. The upper esophageal aortic short axis view is where you can see the IABP position just proximal to the subclavian artery opening. So you can see it from the descending thoracic aorta, go up and see the IABP cannula tip in the just before it enters the subclavian artery, resting in the aorta, from the descending thoracic aorta to the ascending into the arch of the aorta. So TE for robotic OFCAD is the last kind of CABG that we'll talk about. This is in vogue in many centers which have the Da Vinci Robo. I think in COVID times hardly anyone would have used it. Major use of the Robo has been with 4 or 5 arms, either in the urology labs or in the cath labs, in the cardiac surgical labs for lima harvesting or anastomosis of the lima to the LAD. It is a closed procedure where there is a console on which the surgeon sits and he directs the different arms of the robo to do the anastomosis. You have cannulas put in, you require imperative to have a TE, and that's why I stress on the TE, systolic, diastolic function, regional wall motion score index, and everything about the ejection fraction, the fractional area change, the IVRT, and the E by A ratios and the SD values of more than or less than 1. So this would require cannulas in the SVC and even femoral cannulas, and how they come to rest at the IVC RA junction and the SVC RA junctions is what the TE intensivist or the anesthesiologist has to tell the surgeon during this procedure. So the surgeon sits remotely on a console directing the robo to do the anastomosis. A lot of insufflation of carbon dioxide is done. The hand movements decide the precision with which the sutures are put, and there are different clamps, there are different armamentarium required. It's a very, very unique, and this is how it looks like. You can see the console on which the surgeon is sitting, and you can see the robo arms in black, and the position of the anesthesiologist is always at the head end. He sees the hemodynamics, he sees the intra of TE, and he sees the compression of the LV and the RV. Very important on TE is to see the de-airing after cross-clamp removal and confirming the normal surgical correction in the RV and LV functions at the end of the surgery. So de-airing and removal of all air is important to be told before the sternum is closed and the chest is closed, and before any weaning from cardiopulmonary bypass is done. So many people may do off-pump hybrid anastomosis of the lemur. We did that at AIMS, about more than 60 cases, and we would go on bypass to do the harvesting. So either way it is fine, but best of course is that everything is done off pump. The idea of us going on pump was so that the occlusion is taken care of for a longer period and there is less chances or minimal chances of these stenosis. But I think to each center and each surgeon their own expertise. But bicable view during TE is one of the best views to tell us the position of the cannulas on robotic TE. This is how you'll use the cannulas, 28 venous cannula and with an introducer sheath. And this is how they'll go into the neck of the patient and SVC cannula placement, another one, and you can see through the SVC, it just comes and enters in the proximal part of the RA. And this is the LVOT IVC cannula, which is again coming to rest in the ascending aorta. The femoral artery cannulation is done in a routine way, and TE for endoclamp positioning is carried on in a bicable and a mid-esophageal view. You can see the monitoring of the D on TE, how the LV is full of air, and how the direct inspection of atriotomy, right coronary artery, and aortic root needle vent is done, and how this can tell us more and more about the de-airing. Right from a 4-chamber view, you can move on into a 2-chamber view and then onto the long axis view at 120 degrees, always having ECG with you and TE probe in situ. So that is something about you have a upcap with RAV CABG being done. 1 to 2 milligram per kg heparin is even less and introduced in the subxiphoid area. The number of ports that you put in, this is the no major incision. You can only have small incisions of the ports that are put in on post-op day 5. And this is how the whole console looks like in the OT. Minimally invasive beating heart intrapericardial interventions. The endoscopic robotic device adheres to the epicardium, navigates by crawling like an inchworm, and under the control of a surgeon moves to any position on the surface of the beating heart. And this obviates any cardiac stabilization, lung deflation, differential lung ventilation, and reinsertion of laparoscopic tools, requires carbon dioxide insufflation, and offers the possibility of reduced trauma to the patient. And this 3 millimeter port through which various tools can be introduced or placed has small incisions. So those are the instrumentations that you use in a REV robotic CABG. Anterior wall of RV across the acute margin and onto the inferior wall of the RV of a beating heart is done. Now the risks of TE are many: off-pump CABGs, placement of an IBP, placement of MR severity, especially if under GA, which may be undermined, technical and non-technical abnormalities, no touch techniques for severe aortic atherosclerosis TE. The future application of TE is
Dr. Poonam, please cut short.
Any kind of action. We normally these days see with palpation of the aorta and inconsistent epiaortic scanning. But in the future, we'll have very good epivascular scanning and interventions. Type 2 neurological dysfunctions, also you'll have epivascular scanning with transcranial Dopplers. Myocardial viability, you can do the intra-operative dobutamine stress test and contrast perfusions. Renal perfusion myocardial, you can use renal ultrasound guided interventions and contrast demonstration of myocardial plegia flow. And prediction of long-term graft patency can be done by studying the graft Doppler flow velocities and resistances with contrast perfusion washout. So this is the contrast that you have injected, and you can see how the contrast uptake is there with the Doppler signal there. Telling you the systole and the diastole to be up sharp, showing no blockages. That's again a video showing how to palpate the vein. TE should be used in all OPCABs for the following reasons: to ensure proper diagnosis, that procedure is successful from diagnosis for hemodynamic instability, and ideally when to start, prep up or down the vasopressors, the inotropes, and give fluids, and to ensure the safest manipulation of the ascending aorta, which may be calcified. I would like to say that mythology captivates the gullible, but if you are right, then try not to be
Captivated, logic impresses the simple science, and Appec, which has journeyed since the past and is now there in the present with science, will take its place and remove all mythology. That CABG is safe in the hands of the best surgeon and the best anesthesiologist. Thank you all. I'd like to invite you all for our online fellowships on ECMO. They've started for the year 2021 for cardiac critical care, for echocardiography, for cardiodiabetes and cardiac nutrition, with patient blood management being announced in March this year. We've come a long way from our books that we've written with cardiac anesthesiologists across the country and across the globe. It is only with reading, writing, and practicing the right skills with experts that you learn how to do the right methodology. So this PG assembly is one of its kind, where all of us are learning together, and I hope this lecture gave you some insight into the mannerism of CABG, and one would not be afraid to get it done. Thank you all.
Thank you, Dr. Poonam. Ma'am, there are certain questions from the delegates. Students are asking, do we actually need to know this much in MD anesthesia?
Actually, you need to know 5 important topics for MD anesthesia. You need to know how would you give anesthesia for on-pump CABG. In a non-pump CABG, what is the role of an anesthetist? So it's important to know in cardiac anesthesia, you need to know so much details about TE. But I saw a small note of TE in off-pump CABG in one of the PG exams in MD anesthesia in Subharti University. So when I saw that, I thought I must talk a bit about TE because I was an examiner there, but that was the first of its kind. Anesthesia concerns the right kind of anesthesia induction agents, the maintenance with the relaxants, the coming off, how to wean off, as I detailed from the drugs. We do not do on-table extubation. Unlike most other cases in cardiac, we don't do extubation on table. There is a group in Bombay which is putting in an LMA and does extubation on table, but that percentage is not even 0.001%. If you've seen Dr. Ramesh Keshav and all, I think in the next 6 to 8 hours post-surgery, we do fast tracking of GA. So that's another short note that may come, fast tracking of CABG. But that would be a different topic from CABG. So one is to do on-pump CABG, and very often coming is an off-pump CABG long question. Anesthesia concerns and challenges in off-pump CABG is a long question that comes for most DNB students. And I myself am a DNB examiner, and I've given this question. And there again, you need to tell a bit about the role, at least 4 to 5 views of the TE, which you would want to use. And what is the importance of TE, especially during coming off bypass, if you're doing an off-pump, intra-op to see the worsening of the MR, and before coming off to look for any air. So de-airing is important. Any short note on any of the induction agents may come. What is the role of etomidate? So if you have a patient with severe LV dysfunction, NYHA 3 or 4, you would want to give etomidate and not thiopentone or propofol as one of the induction agents. And why? Because the hemodynamic stability and the myocardial depression is least with etomidate over the other two. So those are important concerns which may come from the PG point of view, for which this PG assembly is. Therefore, since I was given 50 minutes and I think I took 60 and some technical errors maybe made it 70, I apologize for that.
Absolutely no issue, ma'am. It's always good to hear from you.
Thank you so much. Thank you.
Ma'am, there's one more question. I said, what is Romansky criteria?
See, the Romansky criteria is a criteria that people use, like we see the wall motion score index, which should be about 1. When we see the regional wall motion abnormalities, that is the criteria that we are using in plenty. We used to use, at least we used to see 5-6 things. What is the degree of calcification on the valves? What is the presence of a VSD, if there is with MI? What is the grading of the MI? Is it NYHA 3 or 4? What is the grading of the ASA status of the patient? Some 7-8 criteria were taken, and also the Malampati score as to what would be the intubation, like would it be 3 or 4? And also when we are doing it, what would be the regional wall motion abnormalities that we anticipate depending on the wall of the MI which is involved. Is it anterolateral MI? Is it a posterior MI? Or is it just a septal MI? A septal MI would be worse than a anterolateral MI. And how many vessels are involved? Is it double or triple or quadruple? Normally, it's a triple vessel CABG that we do. Very few surgeons would be doing 3 or more vessels. On a beating heart, there are many surgeons who do up to 5 vessels, but generally 3 to 4 grafts suffice.
Thank you so
One
much.
question for student point of view. How much heparin you give for off pump and on pump CABGs?
So as I said in my video, 4 milligram per kg body weight we would give as heparin for on-pump CABG. We need a complete heparinization where the heart can be stilled with cardioplegia. And normally we wait for the ACT to be above 380 or 400 before we go on bypass, which is 3 minutes after giving heparin. Whereas when we do an off-pump CABG, the heparin that we use is 2 milligram or even 1.5 milligram per kg body weight. In a robotic type of off-pump CABG, we are giving 1 to 2 milligram per kg body weight. So normally most of us for robotic CABG, if we are doing a Lima harvesting, after the Lima harvesting, we give heparin. This is important. You give heparin after the Lima has been harvested. And that is 2 milligram per kg body weight in off-pump CABG. So the ACT here does not have to be 400. An ACT above 200 or 250 to 300 is all right for an off-pump CABG. The next question that comes is, can you use an alternative to heparin? Well, if you have heparin resistance or you have HIT, there are CABG instances coming up with a direct thrombin inhibitor like bivaldrodine, like argatroban. Those are drugs which are being used, but they are still in the experimental stage. We would still for CABG like to use only heparin. Then do you completely neutralize heparin and off-pump CABG with protamine? Yes, we do. Even if your ACT is 300 or 350 or 250, give protamine 1 milligram per unit of heparin use. So if you've used total of 50 milligrams of heparin or 70 milligrams, give 70 or 75 milligrams of protamine and see that the ACT comes back to the baseline of 140, 160, and then you go on.
Okay,
Yeah,
thank you, Dr. Poonam. Dr. Akhilesh,
Ma'am,
any
here,
question from PGs?
Sir, no, we have already done with the questions from PGs, and I like to emphasize from this forum only that normally in paper number 3, which is a specialty anesthesia, you always get one question related to cardiac anesthesia. And in one of my DNB exams, we got a question in priming in cardiac surgery, priming in cardiac anesthesia. So we usually get this question, and ACT also normally it comes as a short note.
Yes. So priming, you must know what we add, how much of heparin we add. If we've already given heparin 4 milligram, then during cardiopulmonary bypass to the venous reservoir in which we are adding the cardioplegia, which is generally a ringer lactate or a plasma light these days. We don't like to use colloids for priming the solution. You add normally soda bicarb because you want to maintain the anion gap and you want a bicarb which is between 22 to 32. So you add soda bicarb and you're adding the cardioplegia, which today would be Del Nido or a St. Thomas 2 kind of cardioplegia. You must know the type of cardioplegia. And what is the constituent of the cardioplegia? It's normally KCl with some magnesium chloride and calcium chloride added, to which you're adding soda bicarb. And here you will add heparin only after seeing the ACT. So if your ACT already before going on bypass is 999, you may just add some 1 to 2 milligram of heparin. Otherwise, as the cardiopulmonary bypass goes on, you keep seeing the ACT every 30 minutes and keep adding heparin accordingly. So buffer your priming solution and de-air your entire filter, arterial filter, your tubings, venous as well as the arterial tubings, de-airing by the perfusionist and seeing that your tube is moving up and down, the air column is 0. all this should be done, and this is called priming of the CPB, so that the blood of the patient comes into the physiological status on the heart-lung machine. Thank you,
ma'am. And one more, they always, the cardioplegia is another short note which usually comes in the MD anesthesia exams, and which you have covered it very nicely.
Yes.
Thank you so much, ma'am. Thank you, Dr. Ramesh. Anything you want to say?
No, nicely spoken, detail about CABG. In fact, she emphasized too much in detail about echocardiography. People, okay, to somehow to so understand is okay. It may not come in exams, but other things was very good. And thank you very much.
They usually ask the views seen in TE.
Pardon?
Yeah. The views in TE is usually asked in the exams. The different views and most commonly view we find in TE.
DNB exams, they are asking TE in CABG, off-pump CABG. And it is also to motivate all general anesthesia people, please come into cardiac anesthesia.
Yeah.
And remove your fear of echo. Thank you so much and good luck.
Thank you so much. Thank you so much, Dr. Ramesh. Thank you. We move to the next session. And I'd like to invite Dr. Sanjay Agarwal.
Good afternoon, Akhilesh.
Good afternoon, sir. How are you, sir?
Fine, thank you. How are you?
I'm fine, sir.
Thank you for inviting me for this.
So he's a professor and head of AIIMS Rishikesh, and we had a lot of discussion on airway management and neuroanesthesia with sir. So it's always a pleasure to see you, sir.
Thank you. Thank you very much for giving me the opportunity and inviting me for this. And I'll be going forward with the drug session. I think this is the first drug session of the day, which will be there.
Yeah, it's a first drug session, sir.
And we'll be talking about the neuromuscular physiology, the neuromuscular blocking drugs, and the reversal agents. And
Yes.
for that, I just invite Dr. Uma Hariharan. She's an associate professor at RML Hospital with a special interest on oncoanesthesia, difficult airway, ultrasound guided regional blocks, pain management, palliative care, ATLS instructor, and an obstetric anesthesia. So I invite Dr. Uma Hariharan for her talk.
Good morning, ladies and gentlemen, and my respects to all the chairpersons and dear faculty. Today, I will be talking on neuromuscular physiology, neuromuscular blocking drugs, and reversal agents. This is a very, very important topic for all the exam-going PGs and a favorite of all the examiners. So what is exactly the neuromuscular junction? This is basically a junction between the terminal branch of the nerve fibers and the muscle fibers. There are several vesicles of the substance called acetylcholine, which are basically small uniform sized storage packages which are synthesized by the nerves. And then these acetylcholine molecules, they are taken up by the motor end plate upon nerve stimulation. Acetylcholine receptors are present in the end plate of the muscle, which respond by opening their channels for sodium ion influx into muscle for depolarization. End plate potential is continued along the muscle membrane, resulting in muscular contraction. And after this, the acetylcholine detaches from the receptor and is destroyed by acetylcholinesterase. This can be very easily depicted by the following diagram, which depicts the axon of the motor junction and the neuromuscular junction, wherein this is in contact with the muscle fiber through the presynaptic terminal, and the synaptic vesicles are released into the synaptic cleft, which then attach to the postsynaptic membrane and cause muscular contraction. The neuromuscular terminal has several parts, the most important of which is the presynaptic nerve terminal, which is the terminal part of the motor neuron and which releases the acetylcholine into a gap known as the synaptic cleft. And after this, you have the postsynaptic nicotinic receptors to which the acetylcholine is attached and the muscular contraction is initiated. The physiology basically involves electrical impulse transmitted from the motor nerve, causing presynaptic acetylcholine release and then binding to the postsynaptic acetylcholine receptor. Random or spontaneous release of single vesicle acetylcholine results in motor evoked potential to the tune of 0.5 to 1 millivolts. Now, these can be very easily explained by the following diagram showing the various steps. Number 1, the action potential, which arrives and initiates the synaptic transmission. Then the sodium channels, which open up and depolarize the axonal terminal membrane. Then there is depolarization of the terminal membrane, causing the voltage-gated calcium channels to open up. And then it must be remembered that calcium enters the cell and triggers the fusion of the acetylcholine vesicles with the presynaptic membrane. So calcium is very important in excitation contraction coupling as well as for the transmission at the neuromuscular junction. Acetylcholine molecules diffuse across the synaptic cleft and bind to the receptors on the postsynaptic membrane and cause activation of these chemically gated sodium channels and depolarize the postsynaptic membrane. And then there is spreading of depolarization resulting in action potential in the postsynaptic membrane. And then after this, the acetylcholine in the synaptic cleft is broken down by the enzyme acetylcholine esterase, and the components are taken up back by the presynaptic cell for resynthesis. So this is basically recycling of acetylcholine. After synaptic transmission, the acetylcholine and vesicles are recycled and the process repeats itself. So there is something known as quantal theory, which is nothing but the vesicles loaded with acetylcholine via magnesium-dependent active transport system in exchange for an hydrogen ion, and each vesicle of acetylcholine contains 10,000 molecules of acetylcholine. Large amounts of acetylcholine are released by each nerve impulse, up to nearly 2,000 quanta of acetylcholine vesicles are released, and this quanta together with ATP is stored in the vesicle covered by vesicle membrane proteins. Now, the synaptic cleft is a very important aspect of neuromuscular junction, and this is the place where the released acetylcholine through the active zones travels and meets the postsynaptic receptors and causes the muscular contractions. The synaptic vesicles also have several proteins known as synaptophysin, synaptotagmin, the synapsin and synaptobrevin. Now, these are the proteins which are involved in neuromuscular junction transmission, and these proteins are also, especially the snare protein, is the target for the clostridial toxin. Now, the next pathway is the synthesis of acetylcholine. How is acetylcholine synthesized? This is basically synthesized by the axonal transport and by the combination of ATP with acetate and coenzyme A, resulting in acetyl coenzyme A. And then when acetyl coenzyme A combines with choline, in the presence of choline acetyl transferase, you get the chemical that is acetylcholine. 20% of acetylcholine is in the free state within the axoplasm, and 80% is in the form of vesicles. And this assembly forces the vesicle to form a close acquisition with the nerve membrane, which releases the acetylcholine. And the fusion is disassembled and the vesicle is recycled after the process. Now, this is another picture depicting how the synaptic vesicle is formed, and then acetylcholine is released through what are known as active zones by the active pumping of the calcium into the presynaptic terminal, and then the acetylcholine is released into the synaptic cleft. Now, motor neurons, these are basically nerves that control the skeletal muscle activity. The myelin sheath is not present at the time in the presynaptic terminal, and each motor neuron, it connects to several skeletal muscle fibers to form a motor unit, and the axon divides into telodendron entering the muscle. So the muscle surface is heavily corrugated with deep invaginations of junctional clefts, the primary and the secondary clefts, and whose shoulders they have millions of acetylcholine receptors on which acetylcholine attaches. Now, this is the pathway for the chemical synapse sequence at the neuromuscular junction. As I told you previously, there is depolarization of the nerve terminal, then opening of the calcium channel, entry of the calcium Then mobilization of the membrane-bound vesicle, which then binds to the docking protein with fusion at the active sites and release of acetylcholine into the synaptic cleft. Now, muscle end plate has acetylcholine receptors and sodium channels. There are basically three types of acetylcholine receptors. The most common is the junctional or the mature receptors. The second is the extra-functional or immature receptors, and the third is the alpha-7 subunit receptor. Now, the alpha-7 subunit receptor is generally found in the skeletal muscles of adults with pathologies, for example, prolonged immobilization, chronic muscle relaxant therapy, for example, patients who are undergoing prolonged mechanical ventilation in the ICUs, then stroke, sepsis, and denervation or denervated muscles. Now, these receptors are the ones which are responsible for resistance to non-depolarizing neuromuscular blocking agents, as well as the hyperkalemic response to succinylcholine. This is another favorite of examiners. So you must remember this alpha-7 subunit receptor. Now, coming to the extra pre-junctional or post-junctional receptors, basically these are the receptors which I told you, the alpha-7 subunit receptors, which are involved in the pathological states. Now, there are several drugs which promote desensitization of the nicotinic cholinergic receptors, most important of which is the volatile anesthetics, antibiotics, cocaine, barbiturates, agonists, acetylcholine esterase inhibitors, local anesthetics, bencyclidine, and calcium channel blockers. So you need to be extremely careful with this kind of drugs. Now, coming to the neuromuscular blocking agents. Neuromuscular blocking agents are nothing but agents which cause paralysis of the skeletal muscles, either presynaptically acting via inhibition of acetylcholine synthesis or release, or postsynaptically at acetylcholine receptors. Some act presynaptically at, for example, botulinum toxin and tetanus toxin. And anaphylaxis to neuromuscular blocking agents is very common, with succinylcholine at the highest risk, followed by atracurium, rocuronium. And most of these allergic reactions are seen in the female gender. They are basically classified into non-depolarizing and depolarizing. The non-depolarizing ones are the commonly used, like vecuronium, atracurium. Previously, agents like tubercularine and galamine were also used. Pancuronium is a long-acting agent, which is generally used in cardiac surgeries. Depolarizing agents are succinylcholine and decamethonium, but decamethonium is no longer used due to its renal effects and propensity for tachyphylaxis. Succinylcholine, I must say, has actually stood the test of time. It is still being used commonly, and probably it's still going strong. One of the newer non-depolarizing agents is gantacurium. This was especially popular in the Western world. It's a diester derivative of chlorofumaric acid belonging to the tetrahydroisoquinolones, and it is actually being purported as a replacement for succinylcholine, as it is degraded non-enzymatically to inactive derivatives by L-cysteine in the plasma, and it releases less histamine than succinylcholine, and it is rapidly antagonized by hydrophonium with atropine or even cysteine. Succinylcholine is again one of the favorite short-acting or ultra-short-acting depolarizing neuromuscular blocking agents, and it is used for rapid sequence induction to rapidly secure the airway, as it has a very quick onset of action with a peak in 60 minutes and duration of 3 to 6 minutes with the intravenous dose. It can also be given IM. Elimination is by pseudocholinesterase, and two molecules of acetylcholine are linked through acetate methyl groups to form succinylcholine. It results in fasciculations and flaccid paralysis. It increases the intraocular pressure, the intracranial pressure, and the intragastric pressure, and hence caution is to be exercised in patients with glaucoma, traumatic brain injuries, intracranial space occupying lesions, and gastroesophageal reflux disease. It causes both phase 1 and phase 2 blocks. The neuromuscular blocking effect is prolonged with conditions like hypokalemia, hypocalcemia, low plasma pseudocholinesterase levels, which can be either congenital or acquired, and in patients on several drugs like beta blockers, metoclopramide, lidocaine, oxytocin, volatile anesthetics, anticholinesterases, etc. Fasciculations, which actually cause muscle pain after the surgery, are very bothersome, and they can be reduced by pre-treatment with non-depolarizing neuromuscular blocking drugs like tubercularine. It can cause bradycardia after the second IV injection dose in children, and it can be prevented by treatment with atropine. Increased sensitivity during pregnancy is responsible for the reduced dosage and decreased anticholinesterase levels in these pregnant women. It is incompatible in alkaline solutions and precipitates with thiopentone. One point which must be remembered for succinylcholine is that it is a trigger for malignant hyperthermia, and this can be preceded by masseter muscle spasm. I will not go into the details of malignant hyperthermia, which is a big topic in itself, but yes, during the viva on succinylcholine, the questions can be diverted towards this important and life-threatening event. Succinylcholine elevates the serum potassium levels even in normal individuals to the tune of 0.5 millicoulomb per liter and up to 11 millicoulomb per liter in patients with severe burns, trauma, spinal cord injury, and neuromuscular diseases. Administration soon after anticholinesterase administration can cause prolonged neuromuscular blockade up to 60 minutes due to inhibition of plasma pseudocholinesterase and delayed metabolism of succinylcholine. It is one of the agents which is known to cause histamine release and several other cardiac abnormal rhythms, especially junctional rhythm, and even succinylcholine apnea in patients with reduced cholinesterase activity. This can be measured by a specific number, which is a dimensionless number known as the Dubocane number. Anything more than 70 is considered to be normal and less than 30 is abnormal. Up to 8 hours apnea can occur with reduced Dubocane number patients with succinylcholine. Now, this is a very beautiful picture showing the innervated and denervated muscles. Now, in the denervated muscles, you can see that several receptors have proliferated in the myonucleus, above the myonucleus, and this is responsible for excess release of potassium following administration of succinylcholine, which is much less in the innervated muscle. And hence, these patients who have denervated muscles, you should exercise great caution in giving succinylcholine. Now, there is an entity known as depolarization block or accommodation block, and another one known as desensitization block. Now, accommodation block is something which is preceded by muscle fasciculations due to prejunctional action of succinylcholine, which is a normal phenomenon, stimulating acetylcholine receptors on the motor nerve, causing repetitive firing and release of neurotransmitters. Recovery from phase 1 occurs as succinylcholine diffuses away from the neuromuscular junction down the concentration gradient and metabolized by plasma cholinesterase. But desensitization block is one which develops when acetylcholine receptors are insensitive to channel opening effects of agonists, including acetylcholine, and receptors are in a constant state of transition between resting and desensitized states. This is basically a phenomena which occurs when agonists, they trap the receptors in desensitized state. It can actually be considered as a safety mechanism preventing neuromuscular junction overexcitation. So you cannot actually call desensitization block as completely pathological, because that is how the nature deals with overexcitation. Now, phase 2 block is something which we all must know. It occurs after repeated boluses or a prolonged infusion of succinylcholine. Earlier, before we got to know about this entity, people were using infusions of succinylcholine, and this then led to a prolonged neuromuscular blockade known as phase 2 block. There is fade of TOF, that is strain of fourth twitch response, tetanic fade, and post-tetanic potentiation. This is because of presynaptic block reducing synthesis and mobilization of acetylcholine. There is also post-junctional receptor desensitization. So this is actually a very serious condition which should not go unrecognized. It can be explained further by this beautiful picture, wherein in the first one, there is phase 1 where membrane depolarization is there with initial discharge producing transient fasciculations, followed by flaccid paralysis with the administration of succinylcholine. But with prolonged succinylcholine usage, there is membrane repolarization and the receptor desensitization, which doesn't lead to the effect of acetylcholine on the receptors. Now, coming to non-depolarizing neuromuscular blocking agents, they are basically competitive antagonists of acetylcholine at postsynaptic nicotinic receptors, and hence they do not produce conformational change. They are divided into 3 types depending upon the duration of action: long-acting, intermediate-acting, and short-acting. Long-acting is pancuronium, intermediate-acting is atracurium, vecuronium, rocuronium, and cisatracurium, and short-acting is mivacurium. And this is a very good table which can depict the various neuromuscular blocking agents, the non-depolarizing ones. Tuberculin, which is rarely used, mivacurium, atracurium, vecuronium, and pancuronium. Now, I will be dealing with them one by one in a short manner. But before that, these non-depolarizing agents are also classified based on their chemical structure into benzyl isoquinolinium compounds like atracurium, doxacurium, cisatracurium, etc. And they have characteristic 2 quaternary ammonium compounds joined by a thin chain of methyl groups, and they are more liable to break down in the plasma. They lack vagolytic effects, but they are more likely to release histamine, especially with atracurium, and they are the ones which have several stereoisomers because of chiral atoms in the methyl chain. The another group of non-depolarizing blockers is aminosteroid. Basically, they have a steroid ring, and these include the common ones like pancuronium, vecuronium, rocuronium, etc. Rapacuronium was also part of this, but it was withdrawn due to several episodes of severe bronchospasm. Characteristic is the androstenedione skeleton to which acetylcholine-like moieties are introduced at the A and the D rings. They do not release histamine and they depend on organ function for excretion, unlike the depolarizing ones which are dependent on enzyme degradation. They undergo deacetylation with the metabolite having partial neuromuscular blocking properties. Now coming to vecuronium bromide, this is available as a powder reconstituted with sterile water, and it's a monoquaternary analog of pancuronium. Sometimes, especially in patients with renal dysfunction, prolonged recovery may occur with more than 6 hours infusion because of accumulation of metabolites. It has vagotonic effects and hence can cause bradycardia in conjunction with potent opioids. And we then come to rocuronium. Rocuronium is again monoquaternary amine with rapid onset and intermediate duration. It is 6 to 8 times less potent with more lipophilicity. It is an alternative to succinylcholine, what is known as the modified rapid sequence induction, and it produces intubating conditions within 60 to 90 seconds. It is mostly taken up by liver and eliminated via bile. And the only metabolite of rocuronium is 17-desacetyl rocuronium, which is 20 times less potent and hardly has any neuromuscular blocking effects. It has no direct sympathomimetic effects with mild vagolysis in high doses, but anaphylactoid reactions are more common with rocuronium than vecuronium. And in obese, it must be remembered that it should the dose should be based on actual body weight and not ideal body weight. Now coming to our favorite atracurium, especially we use in renal and liver dysfunction patients. It is an intermediate duration of neuromuscular blocking agent, racemic mixture with no direct cardiovascular effects, but the cardiovascular effects are because of histamine release. Hoffman degradation, it is basically 45% degradation with Hoffman degradation and ester-hydrolysis with non-specific esterases. 10% urinary excretion is also there. The metabolite which accumulates on prolonged usage is the laudanosine metabolite, which is a tertiary amine. Caution must be exercised in patients with cerebral disorders because this has epileptogenic properties. The onset of action is less than 3 minutes and duration is around 30 minutes. It should be used in cautions with patients of bronchial asthma and anaphylactoid reactions. Now coming to the newer agent, which is cis-atracurium bisylate. It is basically an isomer of atracurium with 15% mixture of atracurium. Because as I told you, because of the chiral atoms, it is 4 times more potent. No histamine release occurs, 75 or 77%. Undergoes Hoffman degradation, 15% is excreted unchanged in urine. It can be used in patients with renal failure. It produces less laudanosine and hence it is relatively safer. Now coming to my last topic, that is reversal agent. There are several ideal characteristics of reversal agent. To date, no drug has been able to meet all these criteria fully. But yes, for completion's sake, it can be mentioned that reversal agents can be used to reverse any neuromuscular blocking drug. It can be used to reverse any death, should have a rapid onset with maximal effect, no adverse cardiovascular or any other events, no adverse muscarinic effects like bradycardia, nausea, vomiting, bronchospasm, no histamine release or anaphylaxis, not dependent on organ elimination, no ceiling effect, no depolarizing block on excess usage, and low cost. So these kind of ideal conditions hardly exist. but the most commonly used one is neostigmine. It is ubiquitous, cheap, and routinely used for decades with very little allergenicity. It requires the simultaneous use of anticholinergic agents to prevent muscarinic effects. Only efficacious if recovery from neuromuscular blocking drug has commenced. Now, this is very, very important. Hence, the usage of neuromuscular monitor to detect the TOF response, or at least 2 twitches on TOF should be detectable prior to its administration. So it takes 8 minutes for maximum effect. So this particular duration must be remembered at time of extubation, and hence we should not hasten the reversal process. It has a ceiling effect, and increasing its dose does not increase its efficacy. It also causes depolarizing block if given in excess. So this, again, these are the salient points which must be remembered, especially in cases of delayed reversal, difficult extubations, etc. It is excreted in kidneys, and hence prolonged muscarinic effects can occur in renal insufficiency. There are several other uses of neostigmine apart from reversal of neuromuscular block. For example, treatment of myasthenia gravis, post-operative ileus, and urinary retention. It can also be used as an adjunct in the treatment of sinus or supraventricular tachycardia due to the cholinergic stimulation properties. Elimination is by liver and plasma aspirasis. And the mechanism of action is basically by inhibition of hydrolysis of acetylcholine by competing with acetylcholine for attachment to the acetylcholine esterase at the esteritic site. This results in buildup of acetylcholine, so the level of acetylcholine increases and facilitates transmission of impulses across neuromuscular junction. So it does not antagonize and may even prolong the phase 1 block of depolarizing neuromuscular blocking agents. So this must be remembered. And contraindications are basically mechanical obstruction. So if there is any mechanical obstruction in the intestine or in the urinary tract, it should not be given. Cholinergic crisis can also occur due to neostigmine overdose, resulting in nausea, vomiting, cardiovascular abnormalities, excess salivation, sweating, weakness, and even paralysis. Treatment is with atropine, and if required, pralidoxime can be given for supportive therapy. Now, coming to the latest agent, that is Sugammadex. This is basically a gamma cyclodextrin, which encapsulates or chelates the aminosteroidal neuromuscular blocking drug in a 1:1 ratio. Now, this has a very, very different mechanism of action. This contains 8 alpha-D glucopyranoside units attached by alpha-1,4 linkages into a hollow ring-like structure called toroid, into which the agent is drawn and captured there. It does not reverse residual block by other neuromuscular blocking agents, and it does not require the administration of antimuscarinic agents like atropine or glycopyrrolate. There's maximum affinity for rocuronium followed by vecuronium. Onset is dose dependent, and there are 8 outer tails with negative charge at the tips which attract the positively charged quaternary ammonium agent on the aminosteroid molecule and drawing it into the toroid and holding it irreversibly there. The rocuronium Sugammadex complex is then excreted as such in urine with plasma clearance similar to GFR. It acts more rapidly than neostigmine, and it was approved by the FDA recently in December 2015 and is used successfully to treat anaphylaxis of rocuronium by chelation. So this is a sporadic report which is there in literature. For moderate neuromuscular block, that is up to 2 twitches, dose is 2 mg per kg. And for profound neuromuscular block, for example, when there are no TOF twitches, the dose is 4 to 8. But if you want to reverse the neuromuscular blocking agent, for example, in the cases of difficult airway, CVCI, or failure to intubate situation where you have given rocuronium and then you want immediate reversal, you need a higher dose, and that is 16 mg per kg. So you must remember that the main important aspect with Sugammadex is the cost, and hence it is used very less frequently in developing nations. Because neostigmine is ineffective in such situations where you need immediate reversal, Sugammadex can be very useful in difficult airway conditions. Advantages: undoubted efficacy to block all depths of neuromuscular blocking drugs and not recommended in kidney dysfunction, and other adverse effects like even anaphylaxis and cardiac effects. So thank you very much for your patient listening. I sincerely thank the organizers of the Appec, my head of department, MD Kaur ma'am, all the organizers and other senior faculty at RML Hospital and other ones listening to this lecture, and good luck to all the students. Thank you. Good. तुमने stop किया है?
These are few questions. What is the mechanism of fasciculation of succinylcholine?
Hello, am I audible? Hello. 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 Yes. Basically, succinylcholine goes and acts on the postsynaptic receptors and causes repeated contractions of the muscles, which are small contractions, which are actually visible as fasciculations or small muscular contractions. And this is basically the end plate depolarizations, which occur because of the mechanism of action of succinylcholine mimicking acetylcholine. These are actually pre-contractions, not the main muscle contractions. They're pre-contractions, and because of this, the lot of potassium and other muscle fasciculations are evident, and that is the phase where there is muscle contraction before flaccid paralysis. It's basically a flaccid paralysis caused by succinylcholine and not by other agents.
There is one more question, Dr. Uma. Students want to know what is the mechanism of transient hyperkalemia seen with succinylcholine.
Am I audible now? Yeah. So basically what happens is the receptors are overstimulated by the succinylcholine, especially if a lot of succinylcholine is given, especially in the form of huge boluses or prolonged infusions or repeated doses. And in these cases, there is repeated muscle contractions before the flaccid paralysis occurs, and the stimulation of these, the repeated depolarizations, they lead to the potassium, which is thrown out into the extracellular space, and that leads to the hyperkalemia.
One more question we have. What is the difference between pre-sensitization and pre-curarization?
Yeah. Basically, there are understand. One is pre-curarization. Pre-curarization is nothing but giving of a non-depolarizing neuromuscular blocking agent before succinylcholine to reduce the effects of muscle fasciculation. So there are two things which we must understand, that there is something known as priming. In priming, what we generally do is we give a small subparalyzing dose of non-depolarizing muscle relaxant before a second large dose for intubation. And most of these mechanisms and theories have been developed to reduce the muscle fasciculations and post-operative myalgias following succinylcholine. So that is the only requirement of these. What was the other thing? One is priming, the other thing, pre-curarization. So pre-curarization, we generally do to reduce the fasciculations of these agents, and that can be done with agents like D-tubercularine. So D-tubercularine was the first agent which was used, and that has the maximum efficacy, followed by alkyronium, and they can be used to abolish the effects.
Another question, Dr. Uma, for you. A student is asking that neostigmine has to be given according to total body weight. So for 140 kg obese patient, how much we have to give? Since you mentioned maximum doses 5 mg.
one thing which we must understand is that neostigmine has its own side effects. Not only are we giving glycopyrrolate or atropine along with neostigmine in these patients, especially in obese patients, even though I mentioned that the maximum dose is 5 to 6 milligram per day, increasing the dose has its own negative effects. So we need to understand why we need to give more. So not more than 6 to 7 milligram per kg is what is recommended.
So many queries are coming up. So next question is.
I think the chairperson sir has a few queries. He specially told me.
Can I ask
Good evening,
a few
sir.
questions? Good afternoon, Dr. Uma. You have presented it very nicely as such a
Sir,
vast topic. You have covered it in very lucidly. Just few things just I want to ask you. One is you were talking about pre-colorization. So how will we know that the pre-colorization is done? I have given, you have said tuberculosis is not available nowadays.
Yes, sir.
Now I come to know that now my pre-colorization is over and I can give the dose of succinylcholine.
So generally we are using neuromuscular blocker. I mean, the monitoring that can be used, or most important clinical sign is that the fasciculations will there will be no fasciculations, and then we would know that we can now start with our agent.
Okay, I think so.
Another thing which can be done is attenuation of BP response. BP is also attenuated, but heart rate response is not. So pre-colorization also has an effect on cardiovascular system.
Okay. Actually, what I was looking forward was pre-colorization is usually done 3 minutes before giving the dose of the succinylcholine. Ideally, that is the time which is required. And the presence of diplopia in the patient gives you an indication that yes, my pre-colorization effect will be there, and now I can proceed with the full dose of succinylcholine. One more thing, there is something called self-taming in terms of succinylcholine use. Can we have some idea of this self-taming?
Actually, sir, because of paucity of time, I could not cover a lot of topics because this is a huge topic, and the time.
Succinylcholine is something which is kept on the table viva. So a lot of questions are asked for succinylcholine, and a number of times I've seen self-taming, pre-colorization are some things which are asked to the students, and they are not able to answer.
Yes, sir. Yes, sir. Self-taming, we must remember that basically we are giving succinylcholine only. Self-taming is basically taming the effect of succinylcholine so that the side effects are minimized. In the others, we are using a non-depolarizing agent, that is pre-colorization. Here, we are using only succinylcholine. That is what we need to remember. In this, a small amount of succinylcholine, 0.1 milligram per kilogram, is basically this precedes the administration of the full intubating dose of succinylcholine during rapid sequence induction to decrease the incidence and extent of fasciculations. So this is known to reduce not only the fasciculations as well as the post-operative myalgia syndrome, which is very common with succinylcholine usage. This is due to depolarization by subsequent basically induction of neuromuscular desensitization or accommodation, and then depolarization by the subsequent.
It's very well said, madam. It's 1/10 intubating dose or around 0.1 milligram, which is usually given as succinylcholine to decrease all these effects. One small more question that I want to ask: is there any difference in the doses of the reversal agent in terms of the type of the neuromuscular blocker I am using or the recovery of TOF? Because you touched on those few things. So is there any difference in the dosage? I'm sorry, I'm not able to hear you, Dr. Uma.
Dr. Uma, please unmute yourself.
Yes, sir. Hello. Am I audible, sir?
Now you are audible.
Sir, actually, this topic, I am told that is already being covered yesterday. But yes, depending upon the various degrees of neuromuscular blockade which occurs, the doses may also differ, and that is why nowadays Sugammadex is the favorite, because if you want immediate reversal of the neuromuscular block, especially in cases of difficult intubation, CVCI, that is the answer in the coming days. So, sir, would you like to throw some light on it, sir?
For the postgraduates who are there, I just want to tell you one thing. There are two things on which it depends: the doses of the reversal agent, and it depends on what is the type of the neuromuscular blocker agent that is there, and what is the recovery of TOF ratio which is there. So, if you are using a long-acting blocker like pancuronium, and the TOF recovery is less than 2 bars, in that you have to go in for a higher dose of around 0.07 milligram per kg. And that is if you are using an intermediate acting and agents, and your TOF ratio is 3 or more. In that case, you can decrease the dose of neostigmine to around 0.3 to 0.4, 0.03 to 0.04 milligram per kg. So this is how, yes, you can do it. And one more thing I want to tell the students is that you have to be very cautious. Suppose you like Madam said, you have to wait for 8 minutes to know that the effect of neostigmine has come or not. So if you have to repeat the dose,
yes, absolutely,
it's
sir.
better that you wait at least for 10 to 15 minutes and then give a repeat dose of a reversal agent if you think that the reversal is not adequate. So two things which is important is the dosage, and if you require to repeat the dose is the timing. Then you at least have to wait for 15 minutes. Then only you have to give the repeat bolus dose.
Absolutely right, sir. Absolutely right. We should not hurry up with the extubation, especially in prolonged surgeries with patients with comorbidities, obesity. So a lot of other anesthetic agents are also being given along with the neuromuscular blocker which we are using, and that is why I told you volatile anesthetics, antibiotics, they all potentiate the effects of these agents. And especially which I told that in denervated muscles, I mean, we actually have to be very careful in giving these agents. So that is why nowadays, if possible, in ICUs and all, neuromuscular holidays are given. So in the sense, I mean, the patient is not given the neuromuscular blocking agent for some time. And then, I mean, this itself is a complete topic in itself for an entire discussion.
Yeah, Dr. Uma.
Yes, sir.
There is one from the delegate. Usually when we talk about inadequate reversal of the muscle relaxants, so how adjunct neostigmine glycopyrrolate for reversal? As Dr. Sanjay has told that we have to wait for 15 minutes, that's okay. But after 15 minutes, how much dose can we give?
Sir, the dose which can be given is basically 25 to 50% of the original dose, depending upon patient conditions and depending upon requirement. In most situations, the cause has to be treated. For example, if hypothermia is the cause, or if there is any other concurrent cause which is leading to this delayed reversal, we need to actually wait and sometimes try and analyze what exactly is the reason behind this delayed reversal and treat the cause. That should be our primary aim. But yes, we need, if at all it is required, this is what is there.
One more question regarding the neuromuscular blockade reversal. They say that we all know that the glycopyrrolate is preferred over atropine because it does not process the placenta in a pregnant patient for non-obstetric surgery. They are asking, what about neostigmine crosses placenta? So how to reverse neuromuscular blockade in an obstetric patient undergoing a non-op surgery in 28 weeks, because neostigmine crosses placenta and glycopyrrolate doesn't process the placenta. So what is there any alternative to neostigmine, or what should we do?
So the alternative to neostigmine is Sugammadex. If you have, you can give it, but otherwise it is not available. Then as such, neostigmine is not contraindicated in pregnancy, sir. It can be given.
So do we need to reduce the dose of neostigmine when it has to be given, or we can give the normal dose we give in
Sir,
any?
in most pregnant women, if the surgery is a short duration surgery and we are using succinylcholine, we don't need to give neostigmine at all.
And if at all we need to give neostigmine, if we have used the non-depolarizing agents, then the dose is actually, I would say that it is slightly more, 10 to 15% more, but I do not have literature to support it. So if Sanjay sir can give some insight into this, I would be grateful.
No, again, my thing is, I will again say that we can decrease the doses of neostigmine to around 0.03 to 0.04 and still give
yes, 0.03, yes.
Atropine can also be added in place of glycopyrrolate depending on the patient
yes,
condition.
Yes,
you can decrease
yes.
the dose of neostigmine in that condition.
Yes.
Thank you so much, Dr. Uma.
15% reduction, 15% reduction. Yes, true.
It's a nice interaction.
Thank you so much, Dr. Uma. Thank you, Dr. Sanjay sir.
Thank you very much.
I am sure that delegates have benefited from this lecture. Now I will be displaying 2 MCQ questions, for which the answers delegates have to type in the chat box, and first 2 responders will be the winner.
These seems to be very easy questions. If somebody has listened very attentively to Dr. Uma's lecture, the answers were there in that lecture.
So we have received the answers, and then we will take a short break of 10 minutes and we will resume after 10 minutes for the next session of case presentation. Thank you so much, Dr. Sanjay sir.
Thank you very much.
Thank you, sir. Thank you, everyone. Bye.
Thank you. Bye-bye.
So Welcome back, everyone. That was a quick lunch for us. Now we are going to have our next case discussion of the day. Shobit, can you please show the CV? Shobit? For which the external faculty is Dr. Vimi Rewari. She's a professor in AIIMS, New Delhi, and her area of interest is critical care, hepatobiliary and liver transplant anesthesia, acute pain and difficult airway. Internal faculty will be Dr. Nupur Ebrol. She's assistant professor with us in AB WIMS and RML Hospital, and her area of interest is pediatric and onco anesthesia. The case will be presented by Dr. Raj Rajan. He's third year PG resident in AB WIMS and RML Hospital. So let's start the case. Welcome, ma'am.
Hi, Anchal. I'm unable to start my video. You want me to start it or not?
Yes, ma'am, we want to start. Yeah.
All right. Okay.
Thank you.
Hi. Good afternoon, everyone.
Good afternoon, ma'am. Welcome, ma'am. Dr. Raj Rajan.
Good afternoon. Shall I start now?
Yeah.
Yeah, sure.
Yes. A very good afternoon to everyone. I give my sincere thanks to my whole department for giving me this grand opportunity. And
Dr. Raj, yeah. We were not able to see you. Now it's better. Yeah. Much better to have a physical presence. Not physical. Be able to see what you're speaking. Yeah. Please carry on, Raj Rajan.
Yes. I'm going to present a case of Mrs. Devi, a 60-year-old female, a resident of Karol Bagh, Delhi, a roadside vendor by occupation, who has presented with complaints of swelling over the right upper abdomen over a previous surgical incision site for the past 2 years. The patient also complains pain over the swelling for the past 6 months. Presenting complaints, the patient was apparently normal 2 years back. Then she started developing a swelling over a previous surgical incision site, which she ignored. The swelling was gradual in onset, increasing in size from the size of a peanut and has attained the present size. The swelling also becomes prominent on standing and coughing, and it decreases in size on lying down. The patient started developing pain over the swelling since the last 6 months. This pain was intermittent in nature, dull aching in character. It was mild in intensity, and this pain increased on straining and lifting heavy weights, and it relieved on taking rest. There was no radiation of this pain. The patient was able to climb 2 flights of stairs. The patient doesn't have any complaints of nausea, vomiting, constipation, obstipation, sudden loss of weight, loss of appetite, or any complaints of abdominal distension. Also, there is no history of any yellowish discoloration of eyes, chronic cough, or any difficulty in urination. Also, she doesn't give any complaints of trauma to the abdomen previously. There is no history of snoring or daytime sleepiness. Patient doesn't give any history
Why
of...
did you want to know, Dr. Raj, why did you want to know difficulty in urination?
Regarding this patient came as the complaints of pain, ma'am. Also, she was a known hypertensive, ma'am. So because of that, I wanted to know whether she had any end organ damages.
So why will a difficulty in urination be able to tell you that the patient has end organ damage in the form of renal dysfunction, you mean?
Yes, ma'am.
Yeah, how will that difficulty in urination be able to tell you that?
She might see, ma'am, a decrease in the frequency, a decrease in the amount of urine that she is passing, which might point towards oliguria, or any pain during micturition, which might show towards any renal parenchymal diseases, or any blood in urine, which might go towards the renal parenchymal diseases and related.
Okay. Fine, go ahead.
She also doesn't give any history of snoring or daytime sleepiness. There is no history of weight gain, cold intolerance, or any fatigue. Past history. Patient has previous history of open cholecystectomy for polylithiasis done 10 years back under general anesthesia, which as per her history was uneventful and the records of which are not available. A patient is a known hypertensive since last 10 years, diagnosed during previous surgery, and she was started on medication for the same. The patient is not taking regular medications for the same and gives history of taking on and off medications during symptoms of fatigue and headache. She also doesn't have any history of chest pain, gabra, difficulty in breathing, or hunger at night causing any sudden awakening. She also doesn't give any history of weakness or paralysis of any extremities or any sudden episodes of fall. Patient has no...
What do you understand by Dr. Rajarajan? It's all right if I interrupt you in between and ask you questions?
Sure.
Okay, so what exactly do you mean by air hunger at night?
By this, I am trying to find out.
And what are you trying to rule out? Yeah.
Yes, I'm trying to rule out whether the patient is having any symptoms of paroxysmal nocturnal dyspnea, to rule out any cardiac complications of ventricular failure.
Between orthopnea and PND?
Yes. Orthopnea is a condition, it occurs immediately on lying down. When the patient attains a recumbent position, she starts developing the symptoms. Whereas in paroxysmal nocturnal dyspnea, the patient goes to bed and the symptoms develop after a few hours, and she gets up with a sense of air hunger, and she tries to get air by going to a window and trying to get fresh air, and it gets relieved after some time.
So that's not entirely correct, but what are you trying to rule out by eliciting symptoms of either orthopnea or PND?
I'm trying to rule out the cardio complications related to hypertension, whether she is having any end organ damage to CVS, like any left ventricular hypertension.
What is the pathophysiology? What is the pathophysiology of orthopnea or PND? Why does it happen?
In orthopnea and PND, whenever the patient lies down, there is due to the vasodilation, there is an increase in venous return to the heart, which increases the blood volume to the left ventricle and increases the afterload, and it increases the stress on the right atrial enlargement. Increase to the right atrial.
Increases the preload, not the afterload. Yeah.
Increases the preload, and due to the congestion, due to increase in blood to the left ventricle and relative to left atrium, it might cause pulmonary congestion, and patient develops symptoms of dyspnea.
That's correct. That's absolutely correct. But the only thing that you were not correct about is that orthopnea doesn't happen as soon as the patient lies down. It happens after 2 or 3 hours of lying down. And PND is generally associated with air hunger, like you rightly said, and patient gets up gasping for air. So the mechanism for that is not entirely known, but it is said that it is associated with some depression of the respiratory centers in the medulla. And that is why that patient experiences that feeling of air hunger along with increased congestion of the lungs because of a failing heart, right? So that is the difference between orthopnea and PND. So orthopnea doesn't happen as soon as the patient lies down. It happens after 2 or 3 hours or once the patient has fallen asleep, right? Or without falling asleep also, but after 2 or 3 hours of lying down. Yeah? Okay, carry on.
Past history in patient is a known hypertensive since last 10 years, diagnosed during the previous surgery, and she is not taking regular medications for the same, and she is saying on and off medications during symptoms of fatigue and headache. Also, she doesn't give any history of severe headache, bleeding from nose, undue anxiety, flushing of face, or dizziness. She also doesn't give any history of diabetes mellitus, tuberculosis, asthma, in thyroid diseases, seizures, allergy, or any other medical illness. Personal history. Patient is a roadside vendor by occupation. She belongs to lower socioeconomic status and educated up to 8th class. She is a vegetarian by diet with normal bladder and bowel habits, with normal sleep pattern. Patient is a non-smoker and non-alcoholic. There is no history of any tobacco use or substance abuse. Family history, ma'am. Patient is married with 2 children. Her father was a known hypertensive and he died due to a sudden cardiac related ailment. She also has 2 siblings with brother, also a known hypertensive, and a sister without any comorbidities. Treatment history. Patient is a known hypertensive for the past 10 years on irregular treatment. Patient doesn't have any records of the medications that she is taking. General examination.
So after the history, what is your diagnosis?
Yes, ma'am.
Based on history alone.
Based on my history, patient is a 60-year-old female, a known hypertensive on irregular treatment, has presented with complaints of pain and swelling over previous surgical incision site, probably a case of incisional hernia.
Correct. So knowing that this patient has comorbidity in the form of hypertension, would you like to ask any more questions to the patients in the history?
I have mentioned negative history related to her hypertensive complications from whatever end organ damages which I have mentioned.
Okay.
So
the only thing that you probably have missed out is questions to rule out causes of secondary hypertension. Have you asked all of them? What are the causes of secondary hypertension this patient could be having?
Yes, ma'am. Secondary hypertension, it could be due to renal causes. It can be either renal parenchymal diseases or like or a renal vascular diseases. In history, I have asked her regarding the urinary difficulties or any blood in urine to rule out any symptoms.
Right.
She might also have endocrine related diseases, ma'am. Like pheochromocytoma, Cushing's, Cons, acromegaly.
Right.
I asked in history regarding severe headaches and anxiety, flushing, dizziness related symptoms. I have asked it. Also, she might other causes might be like coarctation of aorta or pregnancy induced, or she can obesity, obstructive sleep apnea. For that, I have asked about snoring and daytime sleepiness, and other vascular diseases might also lead to it, like peripheral arterial diseases, coarctation. For this, I have asked regarding she is able to move. She doesn't have any pain in the limbs. Her functional status.
What about pheochromocytoma? Have you asked relevant questions to rule that out?
Regarding pheochromocytoma, it is not periodic. As per her history, it is for a long period of 10 years, and she is on irregular treatment, and she doesn't
exactly.
In terms of flushing or palpitation.
She is not under regular follow-up with her physician. She's not taking regular monitoring of her blood pressure. So it could be an intermittent hypertension. It's not very easy to elicit from history. What are the other things that you can elicit from history which can rule this out?
Palpitations, from history of palpitations.
Right.
That regarding palpitations will come. Flushing.
Right.
That I have mentioned it.
Okay, fine. Carry on. Go on to the examination.
General examination. Patient is an adult female, aged 60 years, conscious and oriented to time, place, and person. And the examination was done with the patient lying comfortably in bed. Weight of the patient is 75 kgs. Height is 150 centimeters. BMI is 33.3. Patient doesn't have no pallor, icterus, clubbing, cyanosis, edema, or lymphadenopathy. There is no rise in JVP, jugular venous pressure, or any dilated veins over the neck. Vitals. Pulse rate of the patient is 76 beats per minute, measured in left radial artery, regular in rate and rhythm, normal in volume and character. There was no radial or any radiofemoral delay. All peripheral pulses were palpable. Blood pressure measured was 170 by 100 mm of mercury, taken in the right upper arm in supine position. Her respiratory rate was 14 per minute. It was regular and thoracoabdominal. Patient is afebrile. Venous access could be easily accessed in both the hands. Airway examination. Patient doesn't have any visible craniofacial abnormalities. Both nares appear normal and patent. The interincisor gap is 5 cm. Belongs to modified myelopathy of grade 2. She has good oral hygiene. In dentition, there is no artificial or loose or buck tooth. Her temporomandibular joint mobility is normal. Her neck range of movements are found to be normal. Her sternomental, thyromental, and hyomental distances are within normal limits. Systemic examination.
Yeah, carry on.
Of the abdomen. On inspection, the shape and contour of the abdomen is normal. Umbilicus is inverted and in midline. A scar of size 10 cm in length seen over the right subcostal region. A swelling of size 6 into 4 cm approximately seen in the middle of the scar mark. There is no visible peristalsis or pulsation seen over the swelling. There is no ulceration or any skin changes over the swelling. All quadrants of the abdomen were moving normally with respiration. There is no distension, spider nevi, distendal veins, or discoloration seen anywhere over the abdomen. On palpating the swelling, a swelling of size 6 into 6 cm is present over the right subcostal region, 5 cm below the right subcostal margin. It is oval in shape, smooth on surface, with well-defined margins, easily reducible, soft, doughy feeling. It is non-tender and without any pulsations. Expansile cough impulse was positive. There is no local rise in temperature, no guarding or rigidity, or there is no organomegaly. On percussion, a shifting dullness could not be elicited. On percussion over the swelling, the note was dull in nature. On auscultation, no bowel sounds were heard over the swelling, whereas normal peristalsis sounds were heard all over the other parts of the abdomen. Respiratory system examination. On inspection, the trachea appears to be in midline. The shape of the chest was normal with a respiratory rate of 14 per minute, thoracoabdominal in nature. Bilateral chest movements are found to be equal. No visible scars, sinuses, veins over any part of the chest. There was no usage of accessory muscles of respiration. On palpation, all the inspective findings were confirmed. On percussion, normal resonant note was found on both the sides of the chest. On auscultation, bilateral air entry was found to be equal and bilateral vesical breath sounds were heard. There was no any other added sounds. Cardiovascular system. On inspection, there was no visible precardial bulge, no visible pulsations or rise in JVP, no scars, sinuses, dilated veins in any part of the thorax, no bony abnormality of spine or ribcage noted. On palpation, inspective findings are confirmed. Apex beat was felt in the left fifth intercostal space, 1 cm medial to the midclavicular line. No heaves or thrills are palpable. On auscultation, the heart rate was 75 per minute, regular. S1 and S2 were heard in all the 4 areas with no murmurs, no other abnormal heart sounds were heard. Examination of central nervous system. Her higher functions are found to be normal without any neurological deficits. The cranial nerves were found to be intact. The sensory functions and reflexes were found to be normal. Her motor system, normal tone and power was found in all the limbs without any atrophy. Her cerebellum and autonomic functions were within normal limits. There was no carotid bruit appreciated. Spine examination, no gross deformities seen with patient in sitting position. Provisional diagnosis. 60-year-old female patient, known hypertensive, on irregular treatment, presented with complaints of pain and swelling over the previous surgical incision site, a case of incisional hernia, posted for open mesh plasty.
So you don't want to mention anything about the hypertension?
I mentioned known hypertensive on irregular treatment.
You want to specify? You want to specify or classify the hypertension?
Yes. Hypertension, according to JNC 7.1, it is classified into either normal, which is systolic and diastolic of less than 120/80, or pre-hypertension, where the systolic is between 120 to 140 and diastolic is between 80 to 89.
So, so Rajan, Rajan, this has been modified in 2017 now by the ACC-AHA. So the classification is slightly different now. This is in 2004, I think. This was, when was the 7th report published? This is quite a while back. Yeah, so the recent ones is in 2017 by ACC-AHA. So the term pre-hypertension has been removed now. So it is normal, elevated, stage 1, stage 2, and hypertensive urgency. Okay, so you can go back and read about it. Okay, okay, fine. And so you will like to say that this is, since it is more than 140 systolic and more than 90 diastolic, so it falls into stage 2 hypertension. Okay, according to the ACC-AHA guidelines. Okay, and if it is more than 180, 110, that is in a hypertensive urgency, right? So you can say it's essential, most likely essential hypertension, stage 2, right? Because 170, 100 is the blood pressure that you measured. Okay, and before classifying the stage of the hypertension, would you like to measure it a certain number of times in certain position? What is white coat hypertension?
White coat hypertension is elevated systolic and diastolic of more than 140/90 when the patient comes to a clinic, whereas the clinic or an office, whereas when it is measured in a home setup with ambulatory blood pressure management monitoring, it is usually on a lower limit. So
right. So either this is from a Western standard. So when the patient is in the hospital, the blood pressure readings are obviously elevated because of the anxiety. And at home, the blood pressure readings are much less. So that's termed as white coat hypertension. So, so this is an essential hypertension and stage 2, provided that you've measured it at least 2 or 3 times at 5 minutes interval, right? So you have this patient who's scheduled for incisional hernia repair, right? Okay, so the surgery is scheduled for tomorrow, and today you go for a pre-anesthesia checkup, and you get this history and examination, the one that you mentioned. So now what is your plan? What are you going to do? So we'll divide the discussion into 3 parts: pre-operative, intraoperative, and post-operative, right? So in the pre-operative phase, what is your plan? What are you going to tell the patient? What are you going to prescribe? What are you going to look for? What investigations are you going to order?
In pre-operative period one, the blood pressure being more than 180, 170, blood pressure being 170 by 100, it is on a higher limit. So I would like to optimize the patient. And this case being elective surgery, I would like to optimize the patient for over next 4 to 6 weeks rather than optimizing it immediately.
Okay.
So I will advise
so you'll cancel the patient. You'll cancel the surgery?
Provided it is an elective surgery, I will ask to...
Yeah. So this will be in consultation with the surgical colleague, right? So if it is not an emergency, it's an elective surgery. So you're going to reschedule the surgery?
Yes, ma'am. I would like to reschedule it for at least 4 to 6 weeks afterwards.
4 to 6 weeks, irrespective of the patient's end organ damage or not?
That depends on the investigation.
After 6 weeks, so you have already taken the decision of postponing without investigating the patient, right? So without investigations, how can you say that you're going to postpone the surgery? And also say the patient goes home and is lost to follow up and then comes with obstructed hernia, right? That scenario is very much possible. The patient is having pain, right? So how will you proceed? Because you've just mentioned the history and the examination, right? We still don't know what the investigations are. So first, let's go to the part where you're going to, what investigations would you like to know for this patient?
In preoperative period, after examination, I would like to order some investigations, which include a complete blood count and a fasting blood sugar, along with a renal function test to know for urea creatinine, and then a liver function test to look for total bilirubin and liver enzymes. And I would like to also have a baseline ECG and a chest X-ray to be done for this patient.
Okay. So what are you looking for in the ECG? And what are the likely changes that you can see in a patient who's 60 years old and has a chronic hypertension for past 10 years?
Yes. Patient being hypertensive for the past 10 years, ma'am, on ECG, I will expect to see any changes for changes of related to left ventricular hypertrophy, like
which are
the changes of SB1 plus RV6, that is S wave in V1 plus R wave in V6. It should be more than 35 mm, which is diagnostic of LVH. Other conditions include S wave in V1 of more than 20 mm, or R wave in lead 1 of more than 20 mm, or R wave in V6.
Okay. You will look for left ventricular hypertrophy. Okay, there are various criteria which you can use, and you mentioned quite a few of them. Okay, what else? What else are you going to look for in the ECG?
ECG, I will look for any ischemic changes, whether if she is having any.
Okay.
Have any history, but still I will look for ischemic changes to look for T wave or STT wave changes. And
can you have STT changes without having an ischemia in these patients?
Yes, ma'am, possible. It's possible.
Why and how?
Because of long-term ventricular hypertrophy, ma'am, it can be there can be silent MI or any conditions of T wave changes. Inversions are possible due to stress on the myocardium or increased demand, which the patient is on irregular treatment also.
Okay, so that's called a strain pattern. Okay, a strain pattern which is very commonly seen in patients who have LVH. Okay, what else can you see in the ECG besides ischemia?
I can look for any rhythm abnormalities, for any.
So arrhythmias are also quite common in these patients. So you have to rule that out. Okay, what else? So ECG, you've ordered an ECG. What about a chest X-ray?
Chest X-ray, I would like to get it done, ma'am, to look for any cardiomegaly, to look for signs of cardiac hypertrophy, and any increased lung markings, ma'am, which suggestive of any pulmonary hypertension. And I will look at the general respiratory state of the patient.
So by doing these investigations, what are you trying to achieve?
I'm trying to optimize the patient. I'm trying to find out whether the patient is having any complications and whether it has to be optimized before taking the patient for surgery.
Okay.
And
so basically, you're trying to identify any end organ damage. Okay. So what does that mean? Why do you need to do that? Why do you need to ascertain whether the patient has any end organ damage due to hypertension?
Because anesthesia induces a major stress response. Anesthesia and surgery induces a stress response, which if you haven't corrected before taking the patient, it might lead to perioperative morbidity and mortality, which we doesn't want to encounter. So
yes, because it increases the perioperative risk of complications, okay, depending on what organ and in what capacity it is involved. So that is why it is important to know and rule out any end organ damage, right? Okay. So what else? Besides these investigations, would you like to order any more investigations? Say this patient gives you a vague history of dyspnea on exertion and tiredness. Would you like to order and some vague chest pain? You know how patients say that if I climb the stairs, I feel a little heavy in the chest. Not exactly, not a typical chest pain. And is also saying that I can't climb more than one flight of stairs without getting dyspneic. She's obese also, right? So it's very difficult to ascertain whether it's because of underlying cardiac disease or because of the obesity itself, right? So would you like to order any other investigation in this patient?
if at all patient complains of any fatigability, I would like to get a thyroid function test to know for her TSH status and to rule out whether the patient is hypothyroid.
Okay.
And if, according to the functional status of the patient, if she's functional capacity is less than 4, then I would like to get a 2D echo to be done.
Okay.
Any changes in the myocardium.
That's correct. So what are you going to look for in the echocardiogram? In a 2D echo, what are you going to look for? Or what are you anticipating?
In a 2D echo, I will look for the chamber dimensions, major chamber dimensions. And then I will look for the any presence of normal ejection fraction. What is the ejection fraction? And then I will look for any regional wall motion abnormalities. And also I will look for any diastolic dysfunction, left ventricular diastolic dysfunction, or the presence of any interatrial or interventricular septal defects, or any blood or clot in the chambers.
Okay. So if the patient has an ejection fraction of 60%, and are you satisfied? Has no regional wall abnormalities, ejection fraction of 60%. Are you going to look for something specifically in these patients? Or you are happy and you will take up the patient?
I will look for the diastolic function, whether the patient
Correct. Very good. Why do you want to look for the diastolic function?
Because in these patients, there will be, due to left ventricular dilatation, left ventricular hypertrophy, there might be increased diastolic volume. So it will be difficult for this patient to, the stroke volume will be reduced.
So what is, you are confusing two issues. What is the difference between left ventricular hypertrophy and left ventricular dilatation?
Left ventricular hypertrophy is due
so
to
what happens in plain left ventricular hypertrophy? What happens? What are the changes that occur in left ventricular hypertrophy alone? In hypertension, when the patient has left ventricular hypertrophy, what is the basic mechanism or underlying mechanism of the left ventricular hypertrophy?
It is basically due to the increased afterload due to the peripheral vascular resistance, because of which the left ventricular starts compensating for the increase in the blood volume, which is accommodated in the left ventricle, and it starts hypertrophy, and eventually it at a later stages it
leads to what? Rise in
interventricular pressure.
Rise in left ventricular end diastolic pressure. Okay. Okay. So the rise in left ventricular end diastolic pressure leads to what?
It further leads to reciprocal change in the left atrium, so it can lead to left atrium dilation, and eventually.
So what happens? What happens because of left ventricular hypertrophy? There is impaired relaxation, which means the left atrium is unable to empty completely into the left ventricle. So there is dilatation of the left atrium, right? So this is in plain left ventricular hypertrophy. So what happens in left ventricular dilatation? Do you see left ventricular dilatation in patients with hypertension? Can you see it?
No, usually.
You can actually, okay? So left ventricular hypertrophy is an eccentric hypertrophy and is because of pressure overload. Over time, if it remains uncorrected, then it leads to a volume overload and dilatation of the left ventricle. So a plain left ventricular hypertrophy, a patient can be in heart failure, okay, but that is with a preserved ejection fraction, okay. A patient who's untreated, remains untreated, it can progress on to left ventricular dilatation, which means both pressure overload as well as volume overload. And then it manifests as heart failure with reduced ejection fraction. Okay. So later on, not initially, it is preserved ejection fraction. Later on, it goes on to reduced ejection fraction where the left ventricle dilates, okay, with volume overload as well. So both these things need to be ruled out. So just because it's hypertension, it's not straightforward, just pressure overload. If it remains uncorrected or untreated, it can move on to reduced ejection fraction or dilatation of the left ventricle as well. Okay. So that is what you are going to, just ordering a 2D echo is not enough. You should also know what you're going to look for in the echo. Okay. It's very important to understand that as well. Right. Okay. So carry on then. So you've ordered these investigations. Okay. So what next now?
Having ordered the investigations, ma'am, I will see for any end organ damages, if anything present, ma'am. So based on that, I will decide my plan of action and to start on which type of antihypertensive drugs and to be started on which dose and how to maintain it and how to bring it under control and the target goal which should be maintained for each patient. And after optimization, I can plan for the surgery after optimization.
Okay, so say for the sake of discussion, we are going to say that this patient comes with impending obstruction or partial obstruction and the surgeons say that it's an emergency and we need to take up the patient. So what pre-operative instructions will you give to the patient? We'll start with that and then we'll move on to the intra-op management.
Yes. If the patient has come with the emergency, like obstruction, and if the BP is still...
It's not an emergency, it's a semi-emergency. Impending obstruction, okay? So what are you going to do? With a blood pressure of 170 and 100.
Yes, ma'am. I will ask for any medication history, ma'am, whether she is taking any previous medications. If not, I will start.
She's not. You already know that. You already know that. She does. You don't know the medication history. Yeah.
And then I will start it at least 24 hours before the surgery, if it is a semi-urgent. And then based on that, on the morning of surgery, I will measure the BP and then take the patient accordingly, ma'am. If the BP is still on a higher side, ma'am, if the BP is less than 110, 180 of 110, then it should be taken under emergency concern. So
the BP is less than 180, 110, isn't it? It's 170, 100. It's varying between 160 to 170 and 90 to 100. Okay. So will you still cancel the case or will you take up the patient?
If it is an emergency, ma'am, I will definitely take the case with explaining all the...
Right. So what are the pre-op instructions that you're going to give to the patient? How will you prepare the patient for surgery?
I will prepare the patient by asking her to take the medications, continue it, and I will ask her
what medication? She's not on any medications. Dr. Rajajan, she's not on any medications.
Okay. I will start her on medications, ma'am.
What medications?
She's
scheduled for surgery tomorrow. She's scheduled for surgery tomorrow. And today evening, you've gone to see her. What medications are you going to start?
I will start her on a combination.
And why?
Yes. The BP being 170, 110, ma'am, it is more than the target goal, ma'am. So I would like to start
170, 100. It's 170, 100.
170, 100. I would like to bring it down to 140, 90. Target goal of 140, 90. So I would like to start at two drug combinations. Two drug combinations, including a diuretic and a ARBs.
So 1 day prior to surgery, you will give a diuretic and a ARB to bring down the blood pressure to 140, 90. Do you think it's possible? In your hospital, are you the person who prescribes antihypertensive medications? No, just asking. Does the cardiologist do it, or you're free to prescribe antihypertensives?
Usually, you get it from a medicine consultant.
Right. So if it's an emergency, is there a point in starting antihypertensive medications? That's my question.
If it is an emergency, I won't start it, ma'am. I will explain the risk. And
obviously, there is no point in starting an antihypertensive medication just a day prior to the surgery, right? Okay. What else are you going to, how else are you going to optimize the patient? What else are you going to prescribe?
I will prescribe an anxiolytic, ma'am, before.
Right. Which one? Which one?
If I have time, ma'am, I will prefer a oral alprazolam. If it is an emergency, I will prefer IV midazolam.
Okay.
Before entering the OT.
Yeah.
Then I will check for the NPO status of the patient, ma'am. The case, if it is an emergency and obstruction, then I will change my plan accordingly, ma'am.
Okay.
And I will ask for other medications, intraoperative. I will look for any complications which is about to be happening in the perioperative period, and I will get ready with my drugs and OTs and all the airway equipments, whichever I wanted in the period.
Okay, so this patient, you said, is obese. The BMI is 33. Okay. Did you rule out the history of reflux in this patient?
Yes, ma'am. According to history, she doesn't have any history of vomiting, constipation, obstipation, and also
so that is different. That is different from reflux. Okay, obese patients, one should always rule out history of reflux. Okay, and so what will you? So you brought the patient has been shifted into the OR. So what is your plan going to be? What is your plan? First, discuss the plan, and then how will you go about it?
For the selective or emergency patient?
For the emergency surgery.
After taking the patient, wheeling in the OT, and I will connect all my standard monitors like ECG, SpO2, NIBP, and then I will take a wide bore IV cannula, either 18 or 20 gauge, and then I will start the IV fluids, and then I will give my pre-medications like injection midazolam if not given previously. I will give.
What is your plan, Dr. Rajraj? What is your plan?
Being an emergency surgery, and if it is an obstruction, my plan of surgery will be.
I told you very clearly, it's a semi-emergency. It's a semi-emergency. You still need to take it up. So what is your plan going to be?
My plan will be general anesthesia with endotracheal rapid sequence induction with control mode of ventilation.
Anything else? Anything else besides general anesthesia?
I will augment it with a regional anesthesia if possible.
What regional anesthesia?
This patient being an upper abdominal, I would prefer to give a regional block like a subcostal tab block.
Subcostal tab block. Or will a single shot subcostal tab block? How will you do it? The patient has a large swelling over there.
The anatomy is ultrasound guided. If ultrasound guided and if the anatomy.
No, but that there is an incision there and a large swelling. How will you give it? Don't you think it's going to be technically difficult? But you will not be able to see any landmarks, even with ultrasound. What else can you do?
I can go for epidural.
Yes. Why? Why is it important in this
pain,
patient?
Stress response, reduction in stress response for perioperative pain control.
Correct.
Used as a sole technique.
Good and perioperative analgesia, right? So that is why epidural is a good idea. Okay. What else? Anything else? Okay, so what is your choice of induction agent?
In this patient, my choice will be injection propofol.
Okay.
And I will induce with injection propofol, and I will check for my ventilation. And this patient, if it is an obstruction, I will do a rapid sequence induction. And my relaxant of choice will be injection vecuronium. And I will intubate the patient with the endotracheal tube, and I will secure the airway, and I will keep her on control mode of ventilation, and I will maintain her on oxygen, nitrous, and desk fluid.
Why did you choose vecuronium? She has query obstruction. Do you not like to do a rapid sequence intubation?
For rapid sequence intubation, I will give a short-acting depolarizing like succinylcholine.
Okay, so you will use propofol, you will use dexamethasone, and you will intubate, right? That's it. Nothing else.
I will obtain the laryngoscopy response with the help of drugs like xylocaine or beta blockers like esmolol. Before.
What are you going to use? What are you going to use in what dose? What dose? Sorry?
5 mg per kg.
You're not audible, Dr. Raj.
1.5 mg per kg at 1.5.
Of 1.5 mg per kg of
2% lignocaine.
Okay. You're going to use that for obtaining the pressure response. Okay. What are the other options for obtaining the pressure response?
Other options can be decreasing the laryngoscopic time to less than 15 seconds, or giving a beta blocker like esmolol at a dose of 0.5 mg per kg before intubation, or I can use a bolus of NTG at a dose of 50 to 100 mg just before intubation, or I can use drugs like opioids like fentanyl at a dose of 2 mg per kg.
Okay.
Yes.
So in a rapid sequence intubation, would you use fentanyl?
In rapid sequence, yes, ma'am, I will give.
What is a modified rapid sequence intubation, and what is the difference between modified and rapid sequence?
In modified one, the Selix maneuver is not used, and also mild positive pressure ventilation is allowed during airway, checking of airway. Para-oxygenation.
Why do we avoid opioids during rapid sequence intubation?
Complaints of muscle rigidity.
What is the what you are going to give a relaxant, no? So that doesn't come into play. What is the effect of opioids on the LES, lower esophageal sphincter?
It will relax it. It will relax it, and aspiration chances increases.
Correct. So in the ideal RSI, you don't use opioids, right? Okay, so the other options, like you said, esmolol, lignocaine, that can be used safely to upturn the pressure response. Okay, say this patient was on a ACE inhibitor and a beta blocker and a diuretic, right?
Yes.
Okay, I'm giving you a hypothetical situation. These 3 drugs and is for elective surgery. Okay, what are you going to do for the drugs in the morning of the surgery, and how will you proceed for induction of anesthesia?
Yes. For elective surgery, ma'am, I will check the nature of the surgery and check for the nature of surgery, and if I expect any rapid shifts in rapid fluid shifts during surgery or any increase in blood loss, then I will ask to skip.
This is the surgery. This is the surgery. Same patient.
For my incisional
same surgery.
For this incisional hernia repair, ma'am, I don't expect much of blood loss, so I will ask her to continue all the medications perioperatively.
Even ACE inhibitors?
Even ACE inhibitors.
So what is the problem of continuing ACE inhibitors, and what do the guidelines say?
ACE inhibitors are known to cause profound hypotension during induction. Profound hypotension. Based on this, studies tell to avoid it previous day of surgery.
So the largest RCT which was done on the effect of ACE inhibitors, 100% of the patients who had the morning dose of ACE inhibitors had some amount of hypotension, and some had very dangerous levels of hypotension. Okay, so that is why it is recommended that it may be avoided on the morning of the surgery. Okay, so that is irrespective of the kind of surgery, whether it is associated with major blood loss or third space losses or not. Okay, so that is only because of the hypotension that is associated during the time of induction of anesthesia.
Sure.
So it would be ideal for you to say that I would avoid ACE inhibitor. Nobody is going to say that you're wrong in that. In some situations, you prefer to keep the ACE inhibitors only if the indication for the ACE inhibitor or the ARB is the underlying heart failure. If the indication of starting an ACE inhibitor and ARB is in heart failure, then you continue the medication, otherwise not. Okay, if it is being given in the evening of the surgery, you can continue it, but not on the morning of the surgery. Okay, what about beta blockers? Are you going to continue it in the morning?
Yes, ma'am, I will continue it perioperatively. I will give it to
Why? Why? What if I tell you to discontinue beta blockers? What is the problem?
Sudden stoppage of beta blockers might lead to rebound hypertension and tachycardia. So that should be avoided.
Why does that happen?
The beta receptors are sensitized because of the drugs, ma'am. So once we stop it, ma'am, there is increase in sensitivity, and there occurs increase in heart rate and contractility.
So it is, no, you will have to slightly modify your answer. The thing is, because of the chronic use of the beta blockers, there is upregulation of the adrenergic receptors. So that is why they are more prone to develop tachycardia and hypertension, rebound hypertension, because of the upregulation of the adrenergic receptors. Okay. And the diuretic, what about the diuretic? Are you going to continue it on the morning of the surgery?
Yes, ma'am, I will continue it on the morning of surgery.
Okay, correct. So except for ACE inhibitors, all the rest of the medications you're going to continue in the morning of the surgery. Okay, fine. What about the induction of anesthesia?
For my elective patient, ma'am, I will induce the patient after taking on table and after connecting the monitors. I will induce with injection propofol. After giving pre-medication like midas and fentanyl,
so
I will induce the
when
patient.
When you take the patient, Dr. Raj, let me tell you the exact scenario. When you attach the monitors, the heart rate was 60 per minute. The blood pressure was 110 by 70. Okay. So what is your the mode of induction of anesthesia?
When the heart rate is 60 and blood pressure is
obviously the patient is on beta blockers, the heart rate is going to be on the lower side, right? And she's well controlled on antihypertensives. Her blood pressure is 110 by 70.
I will pre-medicate. Usually I will pre-medicate with injection midazolam 1 mg, and I will give her.
Why? Why?
Anxiolysis and sedation.
She's not anxious. Her blood pressure, heart rate is 60. Her blood pressure is 110 by 70. You've given a dose of alprazolam in the night and the morning of the surgery also. Why would you want to give her midazolam?
It has augmentation effect with opioids, so that can be.
Okay, so you want to give midazolam 1 milligram? What else?
And I will give injection fentanyl at 2 mics per kg.
Okay.
For 10 mics. And
okay.
I will give injection lignocaine 2% at a dose of 1.5 mg per kg. For my patient, I will give 80 mg. And I will start my induction with injection propofol.
Okay.
Graded doses in increments of 20 to 30 mg till the patient loses the verbal response.
Okay.
And then after checking for check ventilation is done, I will after check ventilation is done, I will give my muscle relaxant, injection at a dose of 6 mg. And after this, I will oxygenate the patient with 100% oxygen, and along with the inhalation agent for a duration of 3 minutes. And after oxygenating, I will secure the airway. I prefer to secure the airway with the second generation supraglottic.
So my reason for asking you this question was, Dr. Rajraman, what happens? What problems are you anticipating during induction of anesthesia in a patient who's a chronic hypertensive on multiple antihypertensive drugs? So what are the problems that you are anticipating during the process of induction of anesthesia? Induction of anesthesia and intubation of endotracheal intubation. So if you know the answer to that, you'll be able to answer my question. I mean, the logic behind my asking you that question.
The patient being chronic hypertensive on multiple medications, she is more prone to profound hypotension following our induction agents.
Correct. Yeah.
Following during a laryngoscopy, there is increased response, and she might go for profound hypertension also during laryngoscopy. And so we should make sure it doesn't happen. So based on this, I have decided.
Anything else that you can do besides this? What is the hypotension due to?
Hypotension is mainly due to reduced volume status. When reduced volume status, these patients are vasodilated and they might be hypovolemic due to taking diuretics.
It is relative hypovolemia due to profound vasodilatation. Okay. The patient is already vasodilated because of antihypertensive drugs. On top of it, your induction agents add to the vasodilatation. So it is a relative hypovolemia. Okay. Unless the patients had a bowel preparation, which can add to the hypovolemia. So this is not absolute hypovolemia, it is relative hypovolemia, right? Because of the redistribution of the blood volume into the peripheral vasculature, correct? So this is what you're scared of. So what are you going to do to prevent this from happening? What is more detrimental to this patient, hypotension or hypertension? You need to understand this.
It's more detrimental.
Hypotension is more detrimental. Exactly, you're right. So how will you prevent it?
I will prevent it by administering IV fluids, crystalloids, prior to giving induction agent. At least
yeah, so at least 200 to 300 ml of IV fluids before you start your induction, right? In a patient who already has a blood pressure on the lower side, 110 by 70 is a lower side for a hypertensive patient, isn't it? Then what else? The next point you said was right. You will titrate your induction agent to the end point. Okay, you will not give a bolus of 2 milligram per kg of propofol irrespective of the blood pressure. What else? Can you modify the choice of your induction agent?
I can modify it to injection etomidate if it is available.
Yeah. Okay. Why? Because propofol is notorious for causing hypotension in normal patients also. So in a hypertensive patient on multiple antihypertensive drugs, it tends to cause a lot of hypertension, and sometimes they go into refractory vasoplegia. Okay. So it is better to use either very small doses of propofol or another induction agent such as etomidate. Right? Yeah. Okay. So the choice of, what about the prevention of pressure response during laryngoscopy?
For preventing the pressure response, I prefer to put a supraglottic device rather than laryngoscopy and intubation for this patient.
Okay. Okay.
Prevent our hypertensive response.
All right. What else?
I can deepen the plane of anesthesia before doing it. The plane using
with what? With what?
Inhalation sevoflurane or desflurane. I will prefer to use inhalation sevoflurane.
So that will also cause a fall in blood pressure.
Often the laryngoscopic response.
So the blood pressure, the heart rate is already 60. So esmolol is not ideal for preventing intubation response, right? So after induction, baseline is 60. After induction, it goes down to 50. So what is the ideal agent in this scenario to prevent hypertensive response?
Okay. It will be lignocaine.
Sorry?
It will be lignocaine.
Lignocaine. Anything else?
NTG, nitroglycerin.
No, but the patient is already hypertensive. Post induction, the blood pressure is 80.
I'm not sure.
Okay, so a high dose opioid would be a very good choice.
Sorry to interrupt you, ma'am. Only 10 minutes left, ma'am, for Viva.
Oh, okay.
Just a bit.
We started late, right? Okay, fine. So going on to, so the surgery started. So there was a question from one of the participants saying that will you use a supraglottic airway for rapid sequence intubation? But we were discussing about elective surgery where the choice of a supraglottic airway is all right, but not for an emergency surgery where the risk of aspiration is there. Okay, so that should be clear. Okay, so now the surgery has started, and after the incision, the blood pressure increases to 190 by 200 by 120. So what are you going to do?
Sudden intraoperative hypertension. First, I will try to look for the cause of it.
It is not sudden. I said after giving the incision, the blood pressure increases to 190 by 120.
A sudden increase in 190 to 100 after incision most probably reflects the patient is in lighter plane of anesthesia and due to pain. It might be due to pain. So I will try to deepen the plane of anesthesia and give pain relief.
So there is a difference. There is a difference between lack of anesthesia and lack of depth of anesthesia. They're two separate things. So if after incision there is a sudden rise, there is tachycardia and increase in blood pressure. So it is most probably because of lack of anesthesia, right? So what are you going to do for that?
Having given the induction dose with, having given pre-medicated with fentanyl, I will prefer to give other analgesic like paracetamol.
At that point? No. What about the epidural that you had placed? You don't want to activate that?
Epidural, sure.
Yeah, so this is the point where it's going to come into use. Yeah. So you should have remembered to activate it before the incision. So where are you going to place the epidural in this patient? What level?
Lower thoracic of T10 to T12.
So maybe T8 to T9 would be more ideal. It's subcostal, right? The incision is subcostal. So T8 to T9, T6 to T9, any level. Okay. And what are you going to give through it?
I will give a test dose. Initially, for activating it, I will give a test dose of ligno-ADR. And after confirming the position of the catheter.
Test dose of, sorry, what test dose are you going to give?
Lignocaine and ADR. Lignocaine and ADR at a dose of 45 mg lignocaine. And
so this patient, this patient is beta blocked, what is it going to tell you?
There won't be any increase in heart rate response. Response to ADR will not be there.
So how are you going to modify your chest dose?
I can give opioid, just fentanyl.
Yes, how much? How much?
Around 50 mics of fentanyl. 50 mics or 250.
No, it is 100 mics actually. If it is intravascular, what will happen? Actually, under anesthesia is not very useful. Giving a bolus dose of fentanyl is more useful if the patient is awake, because that will go into the intravascular compartment, and the patient will have symptoms of either sedation or the symptoms of having IV fentanyl. Okay, so what else can you do? Or you can give plain lignocaine, and all these are pertinent only if the patient is awake. In a patient who's asleep, it's actually not really helpful. Okay. And what is the amount of volume of the local anesthetic that you're going to give here?
Test dose, I will give 3 ml of 2%.
No, the local anesthetic dose. Local anesthetic, what dose, what concentration, what volume? And why is it important? Why am I asking you this question?
Being an analgesic dose, I will prefer 0.25% of bupivacaine at a dose of at a volume of 4 to 6 ml in increments. If the catheter is
why can't you give 10 ml?
Already the patient being in hypotension, I don't want to get
Dr. Raj, you're confusing. The patient is hypertensive at the moment. 190 by 110. Yeah. What is a congruent epidural, and what is the advantage of a congruent epidural? A congruent epidural is where you place the epidural congruent to the incision site, so that the amount of local anesthetic that you give is just enough to cover that site. Because if you give too much of it, it is going to increase the sympathetic blockade and cause hypotension, which you do not want. Okay, so placing a congruent epidural is very helpful in these situations where you do not want the adverse effects of the epidural to come into play. Right? Okay. So you are going to give, and you are going to augment the analgesia by giving an epidural dose of local anesthetic. Okay. And if that's not corrected, you're going to give an additional intravenous dose of an opioid, of whatever opioid you're using, to augment the analgesia. Right? Okay. So now your patient, the surgery is over, and the patient's time for reversal. Any extra precautions during the reversal of anesthesia?
The main response, what we are concerned during intubation, even the
same. Okay. So now you've given your reversal of your muscular blockade has been done. The inhalation agent has been switched off, and the patient is breathing, but the patient is not is still unconscious, is not responding to verbal commands. So what are the possible things that can go wrong at this point?
The patient might be hypothermic. Hypothermia might be
the temperature is normal.
And she might be in deeper plane of anesthesia, if at all we switched it. Or
no, you switched off the inhalation agent 20 minutes back.
The gap between the giving a relaxant and the duration might not be enough.
The neuromuscular blockade is adequately reversed. The tidal volume is adequate. The rate is 15 per minute.
I would like to get a ABG and look for any metabolic disorder.
No, so what I'm trying to ask you is that what are the CNS complications of a patient who has large surges of blood pressure intraoperatively? So what can you expect in these patients?
Due to lowered cerebral autoregulation, the patient might have cerebral ischemia, and it might have led to any stroke or
correct. So stroke, either ischemic or hemorrhagic, both can occur depending on how the blood pressure behaved intraoperatively. Okay, so stroke is number one thing that you have to rule out. What is the second thing? You've heard of press? posterior reversible encephalopathy syndrome, which is a hypertensive encephalopathy. Okay. And what else? Seizures. Okay. So these are three common situations which you need to rule out if the patient is not awakening after anesthesia. Okay, in a hypertensive patient who's had a very labile blood pressure intraoperatively, so you need to worry about these three things, right? Okay, so now let's say the intraoperative period was eventful, post-operative period was uneventful, you extubated the patient is awake, obeying commands, and you shifted the patient to the recovery room, right? So in the recovery, and you went inside to start the next case. So now you get a call from the recovery room saying that the patient is having a very low blood pressure of 80 by 100, 80 by 50. So what are you going to do? What are the possible reasons for it, and how will you treat it?
Operative hypotension, it might be due to surgical loss or acute bleeding. That might
be. Okay. So you've ruled that out. The first thing that you do is that you look for bleed. So that there is no bleed, there is no blood in the drains, and there is no obvious hematoma on the incision site. What else?
That might be due to any drug related, what we are giving it post.
So what is the first thing that you will rule out? So whether a drug has been administered to the epidural. Okay. So if somebody is administered a local anesthetic to the epidural, that could be a cause for hypertension, isn't it? So you rule that out. What else?
Or that can be it can be due to beta blockers, which we have given if any drugs intraoperatively or postoperatively to maintain any hypertension. That can be a reason, no? Or
what else? What are the other complications of hypertension that can manifest as hypotension in the postoperative period?
Due to decreased sympathetic.
What about ECG changes? Would you look for ECG changes to rule out any coronary event? Okay, so that is one, again, because of the underlying uncontrolled hypertension. That could be one thing that you need to rule out. Okay, how will you treat it? Say you ruled out everything. The blood pressure is still 80 by 50. The patient is conscious. The heart rate is around 64. How will you treat it?
First, I will try to increase the fluid status of the patient by giving IV fluids.
Okay.
And after checking, after giving the volume, if the patient is not responding, then I will go with.
See, the blood pressure is 80 by 50. You will not wait for IV fluids. You will start running the IV fluids simultaneously. What will you do?
I will give a vasoconstrictor, like a sympathomimetic agent.
Yes. Which one? Which one? Sorry, I can't hear you.
Mefentramin. Or
okay. What is? Ephedrine. Ephedrine. Why? Why ephedrine and not phenylephrine?
It is a short duration of action, short duration, and
both have the same amount of duration of action. Why phenylephrine? Why not phenylephrine? Between ephedrine and phenylephrine, how do you decide which one to use?
Patient is already on beta blockers, so
the heart rate. So the heart rate decides. Okay, if the patient is tachycardic and hypertensive, you use phenylephrine. If the patient has a normal heart rate with hypotension, it's better to use ephedrine. So you will give a bolus of ephedrine. You will simultaneously rush in 200 to 300 ml, a bolus of IV fluids, and look for response. Okay, and simultaneously also rule out all the possible causes of fall in blood pressure. Right? So what are your intraoperative targets for a patient who is has chronic hypertension, okay, but is otherwise well controlled? The baseline blood pressure is 120 by 80. So intraoperatively, what are your blood pressure targets going to be like?
My target will be within 20% of the baseline, from lower to higher. It should be within, not lesser or.
In terms of what? The systolic blood pressure, the diastolic blood pressure, the mean arterial pressure.
Arterial pressure, mainly the mean arterial pressure.
The mean arterial pressure. Actually, it's not very clear, so you can use any. The systolic blood pressure, the mean arterial pressure, or the diastolic. Which is more important? Systolic blood pressure or diastolic blood pressure?
Diastolic is more important. Diastolic.
Why? Why?
Myocardial blood supply is mainly dependent on diastolic blood pressure. So,
Perfusion, yes. So you should not cause acute decrease or fall in the diastolic blood pressure, right? So that is the reason why an isolated systolic hypertension you should not treat. Because if you treat an isolated systolic hypertension, not only the systolic blood pressure, even the diastolic blood pressure will fall, which can be more detrimental than helpful, right? So that is the reason. Okay, do we still have time? Anchal?
Ma'am, we have to wind up now. Actually,
Okay.
so many questions are also coming.
Okay, fine. So let me ask Nupur to give her presentation, then we can take the questions after that.
Okay, ma'am.
Yeah. Thank you.
Over to you, Dr. Nupur.
thanks a lot.
Please.
Myself.
Yes, you are audible.
Am I audible?
Yes, you are audible.
All right. So definition of primary systemic hypertension is defined as persisting an average of 2 or more readings on 2 or more occasions, systolic blood pressure of more than 140 and diastolic of more than 90. This was the JNC 8 classification. The ACC classification gives it as 130 and 80. This is the GNC 8 classification and the European Society of Hypertension, where they have given grade 1, grade 2, and grade 3, and they've also mentioned specifically the isolated systolic hypertension. The classification can be because of either the essential systolic and systolic hypertension with wide pulse pressure. Systolic and diastolic hypertension can be essential or primary, where the etiology is unknown, or it can be secondary to various causes like renal, endocrine, neurogenic, and miscellaneous. Renal causes can be acute or chronic glomerulonephritis, chronic pyelonephritis, polycystic kidney disease, diabetic nephropathy, hydronephrosis, renal vascular stenosis, and renin-producing tumors. Endocrine can be because of endogenous steroids like adrenal Cushing's, primary aldosteronism, congenital adrenal hyperplasia, pheochromocytoma, acromegaly, hypothyroidism, carcinoids, or by exogenous steroids like oral contraceptive pills and corticosteroids. Neurogenic causes includes increased intracranial pressure, section of the spinal cord, dysautonomia, Guillain-Barré syndrome, sleep apnea, and miscellaneous causes like coarctation of aorta, pregnancy-induced hypertension, polyarteritis nodosa, acute porphyrias, hypercalcemia, alcohol, and drug-induced. Pathophysiology, I'm giving my slides. I hope all of you go through. We know about the 4 major sites, that is the arterioles, the capillary venules, and the heart, and the 4th side, the kidney, which regulates the volume of the intravascular fluid. The baroreflex humoral mechanism and the renin, angiotensin, aldosterone system basically regulates the blood pressure. In hypertensive, baroreflex and renal blood volume control systems are set at a higher level, and this is the take-home message that I would want to take. So when we are managing these patients, we must maintain the blood pressures in and around the baseline blood pressure of the patient. The end organ damages that we are worried about is the cardiovascular, wherein the patient can have left ventricular hypertrophy, angina or myocardial infarctions, arrhythmias, congestive heart failures, and aortic dissections. Cerebral complications include stroke, transient ischemic attacks, hypertensive encephalopathy, or the Press syndrome that we've talked about. Renal includes the nephropathy, and ophthalmological includes the retinopathy and papilledema. So the patient can present with either can be oligosymptomatic, symptomatic, and polysymptomatic, because hypertension per se does not produce much of symptoms unless there is an end organ damage. So the perioperative goals is for elective procedure when the patient is asymptomatic with mild to moderate hypertension. We must proceed without any increase. We do not defer these cases for any this thing. The evidence of end organ damage with severe end organ, when there is an evidence of end organ damage or if there is severe hypertension, the BP has to be lowered gradually, and this gradual is the take-home message for you. And it should be lowered to a target of 140 to 90, which has to be done over a period of 6 to 8 weeks. For emergency procedures, a main systolic and diastolic pressure of about 20% of baseline must be maintained. And as ma'am has already mentioned, diastolic blood pressure is more relevant to us. The lower limit of autoregulation is 113 millimeters in severe untreated or uncontrolled hypertensive, 96 millimeters in formerly severe, now treated hypertensive, and 73 millimeters of mercury in normotensive patients. So the recommend goals according to JNC 8 and American Heart Associations are given for general patients. We should try and maintain 140/90 by JNC and 130/80 according to AHA. For older patients, 130 systolic, and diabetics 130/80, and in chronic kidney disease also 130/80. These are again these are the recommendations of when and where to start the treatments. I'll give out the handouts. And we'll go through this. I'm running through this because of paucity of time. We have a lot of questions. The classification of antihypertensive drugs include those targeting the renin-angiotensin system like ACE inhibitors, angiotensin receptor antagonists, and direct renin antagonists, adrenal blockers like beta blockers, alpha and beta blockers, and alpha-adrenergic blockers, calcium channel blockers, diuretics, vasodilators, centrally acting agents, and ganglion blockers. So these are the various mechanisms where these drugs actually work, their dosages, their onset and duration. During the pre-op evaluation, we must do routine investigations, including complete blood count, renal function tests, serum electrolytes, liver function tests, sugar levels, electrocardiography, and chest X-ray. We must ascertain end organ damage because we must ascertain the cause of hypertension by doing an ultrasound abdomen, renal function test, thyroid profile, fasting blood sugar, postprandial and HbA1cs, serum cortisol and BMA levels, and investigation to ascertain the end organ damage, which decides the plan of anesthesia. These include the ECG, echocardiograph, chest X-ray, renal function test, and fundus examination. Investigations pertaining to antihypertensive patient. If the patient is on diuretics, we would want the morning serum electrolytes. All antihypertensive drugs are continued even on day of surgery. As mentioned, ACE inhibitors or ARVs may be omitted. Treat hypokalemia and hypomagnesemia if present, and in patients with white coat hypertension, we must administer benzodiazepines night prior to surgery. Intraoperative concerns monitoring, we must involve ECG, NIBP, pulse oximeter, end-tidal carbon dioxide, and urine output. Pulmonary arterial catheterization invasive monitoring has to be done only for patients with who are either in failure or have recent myocardial infarctions. Intraoperative goals is to minimize the wide lability of BP and to prevent myocardial ischemia, cerebral hypoperfusion, cerebral hemorrhage, and hypertensive encephalopathy, and renal failure. Induction can be done with opioids, inhalation agents, both of which can produce hypertension, and we must watch for that. And therefore, we can give, prior to induction, we can give 200 to 300 ml of fluid bolus. During laryngoscopy, we have to minimize time to under 15 seconds. Opioids like fentanyl can be given in a dose of 2 to 5 mics. Lignocaine, esmolol, and elabetalol can be given prior to intubation to obtain the laryngoscopic response. The intraoperative concerns include both hypo and hypertension. Causes of hypertension can be because of systemic vasodilatation by general anesthetics, sympathetic blockade by the regional anesthesia, hypovolemia, excessive blood loss, mechanical ventilation, drugs, arrhythmias, acute coronary events, and pulmonary thromboembolism. Hypertension can be because of laryngoscopy and intubation, the surgical stimulus, inadequate plane of anesthesia or analgesia, hypothermia, hypervolemia, reversal and recovery, and during the post-operative period, hypoxia, inadequate analgesia, or a full bladder. So intraoperative control can be done by anesthetic agents using opioids, inhalational agents, butorphanol, lignocaine, antihypertensive drugs like alpha, adrenergic blockers like alpha blockers, beta blockers, and both alpha and beta blockers like labetalol. We can use calcium channel blockers like diltiazem, ACE inhibitors like enalapril, direct vasodilators, and dopaminergic agonists. Intraoperative fluid management is vital in these patients, and in patients with diuretic therapy and vasoconstrictors, they are usually relatively hypovolemic, and therefore, because of the vasodilatation, they go for relative hypovolemia and present as hypotension. So adequate replacement must be given. We must watch for overhydration, which can lead to post-operative hypertension. In presence of left ventricular hypertrophy, the left ventricular compliance curve shifts upwards and leftwards, and a higher left ventricular diastolic pressure is attained. Thus, a higher pulmonary arterial occlusion pressure is needed, sometimes over 20 millimeters. During extubation and emergence, we must ensure adequate analgesia, supplement analgesia with regional blocks in the perioperative period, consider antihypertensives just prior to extubation, and avoid hypothermia, hypoxia, hypercarbia, and ensure a decompressed bladders. Post-operative concerns include both hypertension and hypotension. Hypertension can be because of emergence, pain, hypothermia, hypercarbia, a full bladder, or a relative hypovolemia. Hypotension can be because of the regional blocks or because of bleeding. We must check for, especially in case of intra-abdominal surgeries like this, we must check for our abdominal sites also, because the patient can be bleeding inside, and we must check for the drain sites. So to conclude, identify the cause of hypertension when patient comes to you with primary diagnosis if present. Identify the end organ damage. The goal of controlling perioperative hypertension is to protect the organ function. We must proceed for elective surgery for class 1 and class 2 hypertension, maintaining the intraoperative blood pressure to 20% of the pre-op values. Continue all the hypertension even on the day of surgery, maintain euvolemia in the intraoperative period, and ensure an empty bladder on extubation. And we must take all special cases during induction and extubation. Thank you.
Thank you, Dr. Nupur, for a very nice presentation. Can you please mute yourself? Yeah. Thank you. So, ma'am, we have a few questions from the delegates. So, first question is, can we give the patient a calcium channel blocker like amlodipine a day before surgery and on the morning of surgery to control the blood pressure?
I can read it, Shiva. I can read it. The thing is,
ma'am, your voice is not.
Yeah,
I've got it on the chat. Ma'am.
Am I audible now? Am I audible now?
Yes, ma'am. You're audible. Yes,
yeah.
Okay.
Audible. So, like I said, what are we going to achieve by giving one dose of amlodipine? Because the effect is going to be unpredictable. If the blood pressure is 170 and 170 by 100, it is unlikely to cause any complications. And we also have a lot of short-acting drugs by which we can titrate intraoperatively and manage the blood pressure much better. That is under our control. By giving a pre-op and a morning dose of an antihypertensive, whose effect we will not be able to control because it's a longer-acting drug. Sometimes these can even cause hypotension and may not have any effect on hypertension at all. So we anyway may need to give intraoperative drugs to control the blood pressure. So I would suggest that having the control in your own hands by using your own drugs, short-acting drugs to control the blood pressure would be a much better idea. Just giving one dose of an antihypertensive preoperatively does not serve any purpose. Then somebody said, I can read it from modified RSI versus RSI. So the conventional RSI or rapid sequence induction is an induction agent, a hypnotic agent, followed by a short-acting neuromuscular agent, either a succinylcholine or rocuronium, high-dose rocuronium. Okay, so that is an ideal rapid sequence intubation. A modified rapid sequence intubation is if you change anything out of this. Some people use short-acting opioids to prevent intubation response. So that becomes a modified RSI. Some people give ventilation during this time. So that becomes a modified RSI. So that is not an ideal RSI. There are various variations of modified RSI. So which is away from the ideal RSI is called a modified RSI. So that is why I said giving fentanyl. Sometimes you need to give fentanyl, say in a pregnant patient who has high blood pressure, who has eclampsia or has heart disease. You give fentanyl before intubation in those patients. So that's a modified RSI because you are worried about the harm that it will cause to the mother. So before intubation, you give fentanyl. So that is a modified RSI. In ideal RSI, you just give thiopentone and scoline in a pregnant patient. Whereas in a modified RSI with patient with heart disease, you give fentanyl, a high dose fentanyl, thiopentone, and succinylcholine. So that's what it means by modified RSI. Then, like you rightly said, your textbooks say that ACE inhibitor should be continued unless there is major fluid shift. But the recent evidence, a lot of it, and even the guidelines, the literature says that avoiding ACE inhibitor in the morning is much better for preventing post-induction hypotension. And since the duration of action of ACE inhibitor is very long, the effect continues for almost 24 hours. So omitting it in the morning actually does not cause any harm. But omitting it for more than 48 hours can cause harm. So it is better that you restart the ACE inhibitor as early as possible in the post-op period. So that is why there is confusion. If you read your textbooks, they are going to say this, but the evidence and your clinical practice says that giving the ACE inhibitor in the morning causes much more harm to the patient rather than any advantage. Okay. Then can pre-medication such as glycopyrrolate be helpful in preventing direct myocardial depression? Because no, actually glycopyrrolate is an anticholinergic drug. So that will just lead to it has more of an anti-sialagogue effect than a chronotropic effect. It will cause a slight increase in heart rate, but it has more effect as an anti-sialagogue agent. So really it is not going to cause it has no effect on the heart. So it is not going to affect the myocardial depression or myocardial contractility at all. If at all, it is going to increase the heart rate a bit. And sometimes that can be more detrimental because in patients in whom you are trying to control the heart rate to control the blood pressure, in these patients, if you give an anticholinergic drugs, after induction, once the surgery starts, the blood pressure really shoots up because of the increase in heart rate. So the next question is congruent epidural. So congruent epidural is that if you're placing, like I explained during the viva, that you're placing the epidural congruent to the incision site. So if it's a lower abdominal incision, then you place the epidural at L1, T12, L1, or if it's even lower, then L2, L3. For thoracic and upper abdominal, you place the epidural between T6 to T9. And for breast surgery, you place the epidural between T1 to T4. So that the amount of local anesthetic that you give is just enough to cover the incision site. So that's what is a congruent epidural. Then, which came out only for hypertension diagnosis, should we go according to 2017 guidelines? So actually the 2017 guidelines are quite easy to remember, and it's actually the American College of Cardiology and AHI have come out with very good intraoperative BP targets based on that classification. So I would suggest that you look at that and base your intraoperative management of blood pressure according to their guidance. And they say that if the blood pressure is very well controlled, it is between less than 120 with antihypertensive, your BP targets should be between 10%. If it is more than 130/80, it should be plus minus 20%. So they've given very specific instructions of how to manage blood pressure according to the baseline blood pressure. And their classification is much easier to remember. So there is nothing wrong to go with the ACC-AHA guidelines, easier to remember and easier to implement. Then dose of labetalol prior to laryngoscopy. I would not advise giving labetalol for laryngoscopy because firstly, it takes about 5 minutes for the onset of action. And secondly, the duration of action is much longer. So what happens is that small amount of duration of the intense stimulation that you need to cover is actually extends on for a very long time. And sometimes it may precipitate as hypotension later on. So this can easily be covered by a short-acting agent such as esmolol. So I would prefer to use esmolol for preventing pressor response vis-a-vis labetalol. So labetalol is the agent of choice for controlling intra-op hypertension per se. If it is the blood pressure continues to increase intraoperatively beyond 5 minutes,
and it's not relative or subject to an intense stimulation, then I would use labetalol in increments of 5 milligram to a total of 25 milligram initially, but you can go up to, actually the maximum dose as seen in clamtic patients is up to 300 milligram. So we never need to do that. Generally, it is controlled by 20 milligram itself. So 5 milligram increments every 5 minutes to a total of 20 milligram. Then 2017 ACC guidelines are very well given. You can look it up. Like I said, it is normal is less than 120/80, elevated is 120 to 30 systolic and less than 80 diastolic. Grade 1 is between 120 to 130 and more than 80 diastolic. And grade 2 is more than 130 systolic and more than 90 diastolic. And hypertensive urgency is more than 180 systolic and more than 110 diastolic. So, and a bit about hypertensive emergency and urgency. So there is a difference. Urgency is without any end organ damage, and emergency is with end organ damage, such as an MI, a cerebrovascular event, or a renal event. So all these acute increases in blood pressure, acute hypertension associated with end organ damage is an emergency and needs to be treated, where the blood pressure should not be brought down acutely. In the first hour, only 25% should be brought down. And the next 2 to 6 hours, again 50%, about 160, 100. So that is a difference that most people don't know about. So, and the PGs should remember the difference between hypertensive urgency and emergency. I think I've finished all the questions.
Yes, ma'am.
Until I took away your work, sorry.
Thank you so much, ma'am. It was an extensive session on a very important topic, regularly asked in exams. By whatever case you get, you can be asked hypertension anytime. That is for sure.
I know. And it is a very common thing. Almost 1/3 of your patients that you manage have some sort of hypertension. So you see this every day. Every day.
Thank you very much,
ma'am. Dr. Eminent wants to say something. Ma'am, please unmute yourself, ma'am.
I said, thank you so much, Dr. Vimme. It was a very good presentation. And thank you so much for all your inputs. Thank you. Grateful.
Thank you. It was a pleasure to interact, and your resident was extremely good as well. I think he could answer most of my questions. And I think I listened to the last one also. The last resident was also very good. And I think all credit goes to your department and to you for kind of training them so
much,
well.
Doctor. Yeah, thank you so much. It's very nice interacting with you. Thank you.
Same here, same here. Thank you so much. All the organizers, Nupur, she's been interacting with me a lot, and Anchal and Shiva, all of you, thank you so much. Bye-bye.
Right.
Bye-bye.
Thank you. Bye. Bye. Bye.
Thank you. We will now move to our next session, which will be chaired by Dr. Jaswinder Kaur Kohli. Dr. Jaswinder Kaur Kohli, she's a professor in cardiac anesthesia in AB Wims and Dr. RML Hospital. Her special interest is in regional blocks, pediatric cardiac anesthesia, and transesophageal echocardiography. Welcome, ma'am.
Thank you, Dr. Shivpriya. Thank you, Dr. Shivpriya. Now, our next speaker is Dr. Nidhi Bhatia. She is additional professor in Department of Anesthesia and Intensive Care, PGIMR, Chandigarh. Her areas of interest are trauma, obstetric anesthesia, airway management, and ultrasound guide regional anesthesia, and providing basic life support and advanced cardiac life support. Welcome, Dr. Nidhi Bhatia. Over to you, Dr. Nidhi.
A very good afternoon to all of you. At the outset, I would like to thank the organizers for giving me an opportunity to speak at this great academic event. Now, during the course of the next half an hour, I'll be discussing the anesthetic concerns in patients with a pacemaker or an intracardiac device and how best we can deal with them. So first and foremost, what do you mean by a cardiac implantable electronic device? A CIED refers to any permanently implantable cardiac pacemaker or an implantable cardioverter defibrillator, that is an ICD. Now, the history of these devices dates back to 1958 when the first battery-operated pacing device was introduced by C.W. Lillehei, who was a cardiothoracic surgeon, and Earl Bakken, who was an electrical technician. As you can see from these pictures, these initial devices were large, bulky, handheld external devices. Then in 1960, Wilson Greatbatch, an engineer, created the first implantable battery-powered device, and the generator of this device was placed under the skin in the abdomen just above the belt line. In 1980, the natural progression of pacemaker developments led to the invention of an ICD by Michael Morkover in Baltimore. Now, implantation of ICDs during that time required thoracotomy, which was a significant operation for the patient with poor heart function, with implantation of a large pulse generator in the abdominal cavity. Advances in electronic miniaturization as well as improvements in battery technology have led to the development of very small but electronically complicated programmable pacing devices, which we now use. So what would you do and how would you go about anesthetizing a 65-year-old female who has come to you for an open cholecystectomy and is giving an history of having undergone permanent pacemaker insertion for complete heart block around 6 months back? She is presently on a dual chamber rate adaptive pacemaker mode. Her airway examination reveals a modified Mallampati class 2. Her hematological biochemical investigations are within normal limits. Chest X-ray shows intact leads of the pacemaker with an ECG showing a sinus rhythm with paced beats. Her two-dimensional echo revealed concentric LVH with an ejection fraction of 50%. So when we have to anesthetize such patients, what all we need to keep in mind and how do we address the various perioperative concerns that may arise. So during the course of this lecture, we'll be discussing all of this, and our main learning objectives would be initially, firstly, what is the difference between a pacemaker and an ICD? What are the indications and techniques of pacing? What are the various pacemaker codes and the pacing modes? And what are our major preoperative, intraoperative, and postoperative concerns? So firstly, what are pacemakers and how are they different from ICD? A permanent pacemaker is an implanted device that provides electrical stimuli, thereby causing cardiac contraction when the intrinsic myocardial electrical activity is inappropriately slow or it is absent. Cardiac pacing is one of the most reliable treatment for various cardiac arrhythmias, especially bradyarrhythmias, and currently sophisticated multi-programmable devices are available which can pace the atria, the ventricles, or both. In addition, biventricular pacemakers are available, which are used for ventricles that don't contract at the same time, making heart failure worse. A biventricular pacemaker paces both the ventricles at the same time and increases the amount of blood pumped by the heart. And this is also known as cardiac resynchronization therapy, or CRT. An implantable cardioverter defibrillator, or an ICD, it looks similar to a pacemaker, though it is slightly larger, and it is a specialized device which is designed to directly treat many dysarrhythmias and is specifically designed to address ventricular tachyarrhythmias. It can send low energy shock that resets an abnormal heartbeat back to normal, and it can also be used to send high energy shock, that is defibrillatory shock, if an arrhythmia becomes so severe that the heart cannot pump at all. Now, it is very important to keep in mind that all modern ICDs also function as pacemakers, and these devices can be single chamber, dual chamber, or they can be triple chamber devices. How can you differentiate a pacemaker from an ICD on a chest radiograph? Firstly, the ICD, like I said, is slightly larger than a pacemaker. And secondly, and most important, is the presence of a shock coil or a shock conductor distinguishes a defibrillation system from a conventional pacing system. These shock coils, they appear as sections of the lead which are wider and they are more radiodense. The pacemaker is mainly made up of three components: a pulse generator, a lead, and an electrode. A pulse generator generates electrical signals which makes the heart beat, and it includes a battery and electric circuits for pacing and sensory function. Then the leads are insulated flexible wires which conduct electrical signals between the heart and the pulse generator. These leads may be unipolar or bipolar. In the unipolar lead, the pulse generator functions as an anode and the lead functions as a cathode. Whereas in a bipolar lead, both the anode and the cathode are present on the lead itself, and thus the distance between them is much smaller. The advantage of this is that these bipolar leads have a reduced susceptibility to electromagnetic interference or EMI. Then the third component of a pacemaker is the electrode, which is the exposed metal end of the lead, which is in contact with the endocardium or the epicardium. Now, what are the indications of pacing? There are a variety of indications for which a pacemaker may be placed. These include acquired AV block, which includes a third-degree block or a complete heart block, and a second-degree AV block. Then after myocardial infarction, presence of a persistent second-degree or third-degree block, infranodal AV blocks, bifascicular or trifascicular blocks, then sick sinus syndrome, sinus node dysfunction, hypertensive carotid sinus and neurocardiac syndromes. So all these conditions make the pacing essential. What are the various techniques of using pacemakers? These pacemakers can be placed permanently or they can be temporarily used. Pacing can be provided by either application of external pacing pads or urgent insertion of a transvenous pacing lead via central venous access. And thirdly, they can be implanted permanently, and both these leads and the pulse generator can be implanted. Regardless of how it is provided, pacemaking programming must always be individualized to the needs of the individual patient. In permanent pacing, the leads are inserted transvenously through the subclavian or the cephalic vein, with the leads positioned in either the right atrial appendage or the right ventricular apex. And this is also known as endocardial pacing. And the leads are then attached to the pulse generator, which is inserted into the subcutaneous pocket below the clavicle. Now, when we are not able to have a good transvenous access, or in cases where the chest is open during cardiac operations, the lead can be placed epicardially as well. Now, what is the 5-letter identification code of pacemaker classification? To understand the language of pacing, it is necessary to comprehend the coding system that was developed originally by the International Conference on Heart Disease. Now, whenever we talk about pacemakers, we talk about its code, and the pacemaker is defined by a 4 or a 5-letter code. Now, the first letter in this describes the chamber that is being paced. The second letter describes the chamber where the sensing is taking place. And the third letter describes the response to the sensed events, that is whether the response is inhibited, triggered, or both. The fourth letter indicates rate modulation, and the fifth multi-site pacing. Now, what do you mean by rate modulation? Position 4 specifies the presence or absence of rate modulation. Now, we all know that optimal systemic perfusion requires modulation of the heart rate to meet the metabolic demands. So rate modulation, which is also known as rate adaptation, it allows the pacemaker to increase the paced heart rate in response to certain physiological conditions such as exercise, temperature, etc. So if you have a rate responsive pacing, the paced heart rate may increase in response to these change in physiological conditions. Then the position 4 in the code provides information about the presence or absence of multi-site pacing. For example, if the leads are in more than one cardiac chamber, it is a multi-site pacing. That is, sorry, if the lead is in a single, if more than one lead is in a single cardiac chamber, or if there is biventricular pacing, then you call it a multi-site pacing. The various types of pacing modes are asynchronous pacing, single chamber demand pacing, and a dual chamber AV sequential demand pacing. Now, an asynchronous pacing is a simple form of a fixed rate pacemaker which discharges at a preset rate irrespective of the inherent heart rate. It can be either atrial, ventricular, or it can be dual chamber, and is used safely in cases with no ventricular activity. The problem with this is that it competes with the patient's intrinsic rhythm and may result in induction of tachyarrhythmias. Continuous pacing wastes energy and it decreases the half-life of the battery. Then what is single chamber atrial pacing? In this system, the atrium is paced as well as sensed, and the impulse passes down the conducting pathways, thus maintaining atrioventricular synchrony. A single pacing lead with electrode is positioned in the right atrial appendage, which senses the intrinsic P wave and causes either inhibition or triggering of the pacemaker. And this is useful in patients with a sinus arrest and a sinus bradycardia provided that the atrioventricular conduction is adequate. Single chamber ventricular pacing, the VVI, is the most commonly used form of pacing in which the ventricle is sensed and paced, and it senses the intrinsic R wave and inhibits the pacemaker function. This type of pacemaker is indicated in a patient with a complete heart block with chronic atrial flutter, atrial fibrillation, and long ventricular pauses. Single chamber ventricular pacing is not recommended for patients with a sinus node disease, as these patients are more likely to develop the pacemaker syndrome. For example, if the patient's device is programmed to VVI 70, then the device would pace in the ventricle only when the native ventricular rate fell below 70. And if the ventricular rate was more than 70 per minute, then the device would sense this activity and inhibit further pacing. Now, what is dual chamber AV sequential pacing? In this, the atrium is stimulated first to contract. Then, after an adjustable PR interval, the ventricle is stimulated to contract. These pacemakers preserve the normal AV contraction sequence and are indicated in patients with AV block, carotid sinus syncope, and sinus node disease. The disadvantage of a dual chamber pacing is the development of pacemaker-mediated tachycardia due to retrograde conduction or ventricular atrial conduction, in which the ventricular conduction is conducted back to the atrium and is sensed by the atrial circuit, which triggers a ventricular depolarization, leading to a pacemaker-mediated tachycardia. Now, on an ECG, how would you know that the patient's pacemaker is atrially, ventricularly, or atrioventricularly sequentially paced? In atrial pacing, the electrical spike appears before the P wave and the QRS complex is more or less normal, provided there is a normal intrinsic AV conduction. In ventricular pacing, the electric spike is followed immediately by a wide QRS complex, and in AV sequential pacing, there are two spikes, one before the P wave and the other preceding the QRS complex. So I just mentioned the pacemaker syndrome. What exactly is a pacemaker syndrome? This is most commonly seen in the setting of a single chamber device with ventricular sensing and pacing lead. Since there is no atrial sensing lead to guide the ventricle contracts at a programmed rate regardless of the timing of atrial contraction, and this leads to loss of AV synchrony, which leads to loss in stroke volume and cardiac output. Patients with intact retrograde VA conduction may also develop a mistimed atrial contraction, producing similar effects. Its signs and symptoms may vary from mild to severe, and the onset may be acute to chronic, and the various symptoms include hypotension, syncope, vertigo, fatigue, exercise intolerance, weakness, lethargy, or even a congestive heart failure. And this can be managed by upgradation to a dual chamber device instead of a single chamber pacemaker. So with this background in mind, what are our main perioperative concerns in patients with CIEDs? Now, we all know that the number of patients with cardiac implantable electronic devices is increasing, and preoperatively, it is important that a routine systemic workup is done, especially of the cardiovascular system. All anesthesiologists should be familiar with the basics of current technology, and it is desirable in general that a pacemaker be checked within the last 12 months and an ICD within the last 6 months. The anesthesiologist also needs to be able to obtain certain key information and understand what can cause problems with these devices. What are some of the implications to device function associated with anesthesia and surgery? It is important to keep in mind that there may be damage to or there may be reprogramming of pacemaker systems secondary to cautery use. The anatomical consequences are there associated with various surgical procedures. For example, pneumothorax following thoracotomy or a cardiac surgery may change the pacemaker function due to lead dislodgement or an increase in impedance. Then there may be physical damage to leads through direct trauma. Device or lead infection may be there associated with perioperative bacteremia, and there may be complications associated with the failure to return devices to preoperative settings. Now, our main perioperative concern is the electromagnetic interference. So we'll be discussing how electromagnetic interference can be prevented. Now, the commonly encountered sources of EMI in the perioperative setting are, most common is the electrocautery, then the use of nerve stimulators during MRI, radiofrequency ablation, extracorporeal shockwave lithotripsy, ECTs, then patients having fasciculations, shivering, large tidal volumes may also result in electromagnetic interference with device function. Now, what are the adverse outcomes related to the exposure of the pacemaker to EMI? One is there may be failure to deliver pacing or defibrillation if an ICD is present. There may be changes in pacing behavior. There may be inappropriate delivery of a defibrillatory shock or inadvertent electrical reset to backup pacing modes. Any of these can result in significant morbidity and mortality due to hypotension, dysarrhythmias, myocardial tissue damage, myocardial ischemia. So how would you evaluate the patients preoperatively and prevent all these complications from happening? The patient should be questioned about the initial indication for the pacemaker and the pre-implantation symptoms such as lightheadedness, dizziness, or fainting. And if these symptoms occur even after pacemaker insertion, then cardiac evaluation must be done thoroughly. You need to conduct a focused history. The general physical examination should be done to rule out the presence of any bruise or signs of congestive heart failure. Routine biochemical and hematological investigation should be performed as indicated on an individual basis. A 12-lead ECG and a chest X-ray should be done for visualization of continuity of leads, and measurement of serum electrolytes, especially potassium, should be performed. It is also important to determine the CIED's type, its manufacturer, and the primary indication for placement, and you need to determine the CIED's current settings and function. It is important to keep in mind that although most of these device generators are in the pectoral region, however, some of them may be in the abdomen or in an alternate position in the thorax. And some cardiac implantable electronic devices are now implanted entirely within the heart, that is leadless pacemakers. Another very important thing that we need to determine preoperatively is to see whether the patient is totally dependent on the pacemaker or not. A patient with an absent intrinsic heart rhythm is completely pacing dependent. On the other hand, a patient which has some intrinsic heart rhythm or has an inadequate intrinsic heart rhythm may be considered relatively or functionally pacing dependent. So what are the indicators which tell us that a person is pacing dependent? So first and foremost is that if the CID was initially implanted due to bradycardia that caused syncope, or if the CID was implanted following successful atrioventricular nodal ablation, or if there is a lack of spontaneous ventricular activity when the pacemaker is programmed to the VVI mode at a low rate. On an ECG, if the ECG demonstrates an intrinsically conducted rhythm, that is, there are QRS complexes which are not preceded by a pacing artifact, then the patient is unlikely to be highly pacemaker dependent. On the other hand, if every P wave or a QRS complex on the ECG is preceded by a pacemaker spike, the likelihood is high that the patient is pacemaker dependent. So you also need to estimate the likelihood of EMI based on the characteristics of the proposed surgery. It is important to remember that EMI is more likely if the surgery is less than 15 centimeters from the device or the leads, or if the surgery is above the level of the umbilicus. Then monopolar cautery rather than bipolar cautery is used. In those cases also, the chances of electromagnetic interference is more, and long or frequent bursts of cautery are used, or the CID has unipolar leads. These all also increase the chances of EMI. Other factors which are important from anesthesia point of view are the serum electrolytes, especially potassium. The potassium, we all know its equilibrium across the cell membrane determines the resting membrane potential. Acute increase in extracellular potassium concentration may increase the resting membrane potential to less negative value. So less current density is required to initiate an action potential, thus making the capture easy. On the other hand, decrease in extracellular potassium results in more negative resting membrane potential, which makes the pacemaker capture difficult. Then following myocardial infarction, the scar tissue may be unresponsive to electrical stimulation and may cause loss of pacemaker capture. Then if the patient is on antiarrhythmic drug therapies, these drugs have also been found to increase the pacing threshold. Alkalosis, acidosis, hypoxia, these all increase the pacing threshold, whereas the anesthetic drugs are not likely to change the threshold. Now we talked about the various sources of EMI. So how do you manage these during the intraoperative period? The first and foremost is electrocauteries. The likelihood of adverse EMI-CID interactions decreases with the distance from the EMI source to the pulse generator. With modern subpectoral devices, potential for interactions is markedly reduced when the surgery is below the level of the umbilicus and the cautery dispersal pad is placed so as to direct the current away from the pulse generator. Bipolar cautery should be used as much as possible as it has less EMI. If monopolar cautery is planned superior to the umbilicus, ensure that the pacing function of a CIED is altered to a asynchronous pacing mode in a pacing dependent patient, and you need to suspend an ICD's anti-tachycardia function if it is present. Position the electrosurgical unit's dispersive electrode so that the current pathway does not pass through or near the cardiac implantable electronic device generator and leads. Electrocautery should not be used within 15 centimeters of the pacemaker. Frequency of the electrocautery should be limited to 1 second bursts in every 10 seconds to prevent repeated asystolic periods, and short bursts with long pauses of cautery are preferred. Use a more cutting than a coagulating current and use harmonic scalpels. Now, if you need to do a radiofrequency ablation, in these cases, an ICD should be disabled and a pacemaker should be reprogrammed to an asynchronous mode. And you need to keep the radiofrequency current path as far away from the generator and the leads as possible. During lithotripsy, avoid the focus of the lithotripsy beam near the generator. During ACT, alter the pacing function of a cardiac implantable device to an asynchronous pacing mode and suspend an ICD's anti-tachycardia functions if it is present. Monitor and treat ventricular arrhythmias that may occur secondary to the hemodynamic effects of ACT. Now, what do you do if you have to get an MRI done in a patient with these devices? MRI has previously been contraindicated in patients with CIEDs due to concerns surrounding the generation of heat, effects on pacing function, and the possibility that magnetic fields will induce currents down the leads. It is critical to understand that it is not just the pulse generator that must be MRI safe, but the leads themselves have special designs and must be MRI safe as well. Having a CID present is generally considered a contraindication to MRI. However, there are several manufacturers that have MRI safe pacemakers. So if this is in place, you need to interrogate the device before an MRI scan, suspend the anti-tachycardia function of an ICD if it is in place, alter the pacing function of a pacemaker to an asynchronous pacing mode, ensure that the individual capable of programming the device remains in attendance for the duration of the MRI scan, and you reinterrogate the device and restore its permanent settings immediately after the MRI is completed. Now, what do you do if you need to give an emergency cardioversion or a defibrillation to a patient with these devices in situ? You need to terminate all sources of electromagnetic interference and remove the magnet to re-enable the ICD's anti-tachycardia therapies. Then observe the patient for appropriate anti-tachycardia therapy from the ICD. However, if the above activities fail to restore the ICD's anti-tachycardia therapy, follow the ACLS guidelines for delivered energy level and pad placement. You need to position the cardioversion and defibrillation pads so that they are not directly over the cardiac implantable electronic device generator. Pads should be placed on the patient in the posterior-apical or the anterior-posterior fashion, ensuring that the apical pad is at least 5 centimeters from the location of the generator, and use a clinical appropriate shock energy output regardless of the presence of a CIED. Now, we commonly say that magnets may also be applied when we are using these devices intraoperatively, and what is the effect of magnet application and what are the risks associated with these. The magnet is placed over the pulse generator to trigger the reed switch present in the pulse generator, resulting in a non-sensing asynchronous mode with a fixed pacing rate called the magnet rate. Activation of the reed switch shuts down the demand function so that the pacemaker stimulates asynchronous pacing. Now, not all pacemakers switch to asynchronous mode on application of a magnet, and the response varies with the model and the manufacturer, and this we all need to keep in mind. A magnet can be secured over the pulse generator of an ICD if it does suspend the arrhythmia detection function of an ICD and prevent its discharge. Subsequent removal of the magnet promptly reactivates the ICD. And in a patient with an ICD, the magnet response will always be to deactivate the ICD, and the pacing behavior will not change to an asynchronous mode. So like I had mentioned initially, all ICDs also function as pacemakers. So when you apply a magnet on the ICD, the magnet response will only deactivate the ICD. It will not deactivate the pacing function of an ICD. So if you need to deactivate the pacing function as well, or you need to convert the pacemaker into an asynchronous mode, you have to do it by reprogramming the pacemaker of the ICD. What are the risks associated with magnets? The variability of response between devices is there, as there is no universal standard. Switching to asynchronous pacing may trigger ventricular asynchrony in patients with myocardial ischemia, hypoxia, and electrolyte imbalance. Constant magnet application over the pacemaker may alter the programming, leading to either inhibited or triggered pacing, or may cause continuous or transient loss of pacing. And the use of magnet may be safe in non-programmable pacemakers. However, most of the current devices should be considered programmable unless known otherwise. So coming to our patient who has come to us for a cholecystectomy, should we reprogram the device prior to surgery in this patient? This patient is on a dual chamber rate adaptive pacemaker mode that was inserted for a complete heart block. It is likely that the patient is functionally dependent on the pacemaker, and since the patient is posted for cholecystectomy, location of the AMI source is also closer to the device. So reprogramming the device to an asynchronous mode should be done prior to surgery. Since the position 4 of the pacemaker code specifies rate modulation, consider suspending it if it's enabled. If this is not possible for some reason, the mode of rate response must be known so that conditions causing changes in the paced heart rate can be avoided. For example, shivering and fasciculations should be avoided if the pacemaker is activity rate responsive. Ventilation should be kept controlled and constant in case of minute ventilation rate responsive, and temperature must be kept constant in temperature rate responsive pacemakers. Now, what are our special intraoperative concerns in these patients? The patients with these devices are at high risk of dysarrhythmias and potential interference from EMI. The cardiac rate and rhythm must be continuously monitored, and the peripheral pulse must be continuously assessed due to the risk of pulseless electrical activity in this high-risk population. The artifact filter on the ECG monitor should be disabled to detect the pacing spikes. Any changes in electrical activity or sudden hemodynamic instability that seems temporarily related to AMI should prompt one to ask the surgeon to stop using cautery until the hemodynamic conditions are stabilized. Assure that appropriate monitoring and vigilance is maintained with the immediate availability of temporary pacing or external defibrillation if necessary. Now, what is our choice of anesthetic technique? Both narcotic and inhalational techniques can be used successfully, as these do not alter the current and voltage thresholds of the pacemaker. Skeletal myopotentials, electroconvulsive therapy, succinyl fasciculations, myoclonic movements, or direct muscle stimulation can inappropriately inhibit or trigger stimulation. The muscle fasciculations induced by succinyl choline can be avoided by using non-depolarizing muscle relaxants or defasciculating with non-depolarizing muscle relaxant before giving scolin. Etomidate and ketamine should be avoided, as these may cause myoclonic movements. Pacemaker function should be verified before and after initiating mechanical ventilation, as there may be dislodgement of pacemaker leads by positive pressure ventilation or nitrous oxide entrapment in the pacemaker pocket. Avoid use of nitrous oxide in patients with newly implanted pacemakers, as it might cause expansion of prepectoral air pocket, leading to device malfunction. Patients who are highly pacemaker dependent will not mount a tachycardia response to hypertension, which results from hypovolemia or sepsis. In such patients who are paced 100% of the time, it may be desirable to reprogram the lower pacing rate to a higher rate, which is more appropriate to the underlying hemodynamic status. If an increased heart rate is required emergently and reprogramming is not immediately available, then placing a magnet may also help. This step will typically accelerate pacing to the magnet rate, which is device specific, but is often more than 85 beats per minute. So what are our post-operative management concerns? For a cardiac implantable electronic device that was reprogrammed pre or intraoperatively, ensure that backup pacing and cardioversion defibrillation equipment are immediately available until the cardiac implantable electronic device's permanent settings are restored, and ensure that the patient remains in a monitored environment until these settings are restored. So to conclude, the ideal perioperative management of patients with a CIED derives from multidisciplinary approach. Anesthesiologists must be familiar with the current recommendations and their implementation. Recommendations continue to emphasize the need for an individualized and a thoughtful approach to each patient, with specific actions taken to minimize the exposure of the device to electromagnetic interference and to protect patients from untoward hemodynamic effects as a result of such exposure in the perioperative period. Thank you for your patient hearing, and all questions are welcome.
Thank you, Dr. Nidhi. It was wonderful lecture, and this topic is very important. And also for the students who are appearing for the MD exam, spots may come as a if pace beat is there to identify the spot.
Yes.
Really wonderful lecture, Dr. Nidhi.
Thank you so much, ma'am. Thank you.
Dr. Shivpriya.
Thank you very much, Dr. Nidhi. It was a wonderful lecture.
Thank you so much.
Thank you, ma'am.
Any questions, Dr. Shivpriya?
No, ma'am. Till now, there are no questions. So we can go for a quiz, a small quiz.
There is one question from my side.
Yes, ma'am.
Do you need invasive arterial blood pressure monitoring in this case, particularly this case?
No, not particularly in this case, but yes, in cases where we feel that in this patient, the cardiac status was good enough and the patient had come for not a very major surgery. It was an intermediate grade surgery, like for an open cholecystectomy. So it is not mainly required in this case, but yes, when your cardiac status is borderline or the patient is critical and the ejection fraction is not good, or the patient or the surgery is maybe closer to the device, to the generator, it becomes all the more important in arterial monitoring. And plus it also arterial monitoring and or maybe even a pulse oximeter, it tells you whether your mechanical capture is also there, because the ECG will tell you the electrical capture, but actually if that is going on to a mechanical capture, you can tell by these various monitoring devices. So it becomes important when your surgery is major or maybe the cardiac patient.
Thank you, Dr.
One question has come, ma'am. What are one delegate is asking precautions to be taken during peripheral nerve block?
Yeah, so during peripheral nerve block, like if you're using an ultrasound, it's okay, there is no problem, but the problem arises when you're using a peripheral nerve stimulator. Yeah, so during the use of a peripheral nerve stimulator, the peripheral nerve stimulator is also known to induce a lot of electromagnetic interference with the functioning of the device. So if you have a patient who has a pacemaker in C2 and the patient is totally dependent on the pacemaker and you need to use a peripheral nerve stimulator, it is advisable to reprogram the device to a fixed mode and then use a peripheral nerve stimulator. But best is to avoid the use of peripheral nerve stimulator and do an ultrasound guided block.
Any other question, Dr. Shivpriya?
No questions, ma'am.
I think this lecture was so self-explanatory and our student doesn't require any question. They don't have any question. Thank you so much, Dr. Nidhi Bhatia.
Thank you. Thank you.
Thank you, ma'am.
Thank you.
So I'm going to display a small quiz, MCQs. We'll give you 30 seconds time for this. Delegates, please type their answer in chat box.
The questions are not visible on screen.
Okay, ma'am. Is it visible now?
Yeah, it's visible.
We can move on to our next lecture, ma'am. Jaswinder, ma'am.
Yeah, our next session.
Okay, thank you, ma'am. It was nice being here. Thank you so much.
Thank you so much, ma'am.
Our next session is on cardiovascular monitoring, and this is very important topic, and this can come as a long question in your exam, and also in your practical and viva. They can ask you so many questions on spots, as in on equipment session. They can ask you so many questions. So for cardiovascular monitoring, our speaker is Dr. Itishri. She is Associate Professor in Department of Cardiac Anesthesia, and her special interests are pediatric anesthesia. Her special interest is in cardiac anesthesia and especially the cardiac monitoring.
Thank you
Over
so
to
much,
Dr. Itishri.
Thank you so much, ma'am, for this kind introduction. And you are my mentor. And I really want to say a lot of thanks to, I want to say a lot of thanks to MD Kaur ma'am for giving me this opportunity to present on this topic. It has really been really wonderful on our part, ma'am. Thank you so much, ma'am.
We proceed with you.
A very good evening to all the seniors and faculty members present over here. A warm welcome to the postgraduate students, and my heartfelt thanks to Dr. MD Kaur ma'am and to the organizers of Appec for giving me this opportunity to present on this interesting topic of cardiovascular monitoring. Well, as an anesthesiologist, we all know that we need to monitor the hemodynamic parameters of our patients and to keep them near normal. And for this, we have various monitoring modalities, and of which the most basic one is the arterial blood pressure monitoring. Well, as far as our set of patients are concerned, if they are critically ill or if they are suffering from some cardiovascular ailment, the non-invasive blood pressure monitoring has the biggest limitation, that it tends to overestimate your pulse pressure, and we cannot do a beat-to-beat monitoring of the patient. In that case, we need an invasive arterial blood pressure monitoring, and the major indications are the surgical procedures if they are associated with large fluid sheds, cardiopulmonary bypass, procedures on the aorta, if the patient is suffering from some cardiovascular ailment, or he's critically ill requiring anotropic support, he needs frequent blood gas monitoring, and massive trauma cases, sepsis cases, and of course, if we cannot measure the pressure non-invasively. So some contraindications are also there, especially infection at the active site, infection at the site of cannulation and coagulopathy. So there are certain terms which we need to know before we get into the monitoring of our pressures, the invasive pressures. First of all is the zeroing, which means the use of atmospheric pressure as a reference standard against which other pressures are measured. Followed by leveling, which is the selection of position of interest, which corresponds to the phlebostatic acids, that again corresponds roughly to the position of the right atrium or to the aortic root. Otherwise, if we don't use this position, otherwise the hydrostatic pressures within the fluid column will cause error in our readings. And calibration is an adjustment of the system gain to ensure proper response to a known reference value. Now, the information that we get from the arterial line is the heart rate and rhythm, systolic, diastolic, mean, and the pulse pressure, as well as the pulse pressure and systolic pressure variation. There are various AIBP monitoring components, and they consist of a column of fluid that directly connects the arterial system to the pressure transducer, which is known as the hydraulic coupling. We have arterial cannula, direct catheter over needle technique, or we have the leader cats where we insert the needle over a guide wire. Then we have fluid filled tubings with stopcock. These arterial cannula, they should be, kink resistant, they should be incompressible, they should be less thrombogenic and biologically inert, while these fluid filled tubings also should be incompressible, contain bubble-free fluid, and then not more than 1.2 meter in length and around 1.5 millimeter in diameter. Now, this tubing is connected to a transducer, a piezoresistive silicon transducer that acts on the principle of the Wheatstone bridge, where the mechanical arterial waveform is converted into an electrical waveform, which is displayed onto the monitor with the help of the amplifier that increases the voltage complexes. And then we have a flush we have a flush device. As you can see over here, the flush device, it is pressurized to a pressure of 300 millimeter of mercury, and that rate of 1 to 3 ml per hour, so that the system is not clogged and there is no retrograde arterial blood flow into the tubings. So the technical aspects of IABP monitoring is that the IABP is an underdamped second order dynamic system. Now the complex mechanical arterial waveform, it is actually analyzed by breaking it into series of simple sinusoids oscillating in the same phase. This is known as the Fourier analysis. And these sine waves are actually the harmonics or the fundamentals of the fundamental frequency, which is clinically present as the pulse rate, which is considered to be 60 beats per minute, or in case of harmonic, this is 1 hertz. And about 6 to 10 harmonics are required to reproduce most consistent arterial waveforms. So a second order system is characterized by elasticity, mass, and friction. Now the terms are natural frequency and damping coefficient. The natural frequency is the frequency with which the system oscillates after a stimulus, while damping coefficient, they reflect the frictional forces that brings back the system to rest. So as the natural frequency of arterial pulse, it ranges between 16 to 24 hertz, the monitoring system should have a greater frequency response as to produce the original wave form. Okay, so this natural frequency, it can be increased by reducing the length of the cannula or increasing the diameter of the cannula, or reducing the compliance of the diaphragm, or reducing the density of the fluid, while damping is increased just by the reverse waves and by inclusion of more of three-way taps, bubbles, and clots. So fast flash test is there in order the waveform is or it is a normal arterial waveform. We pressurize the whole system with 300 millimeter of mercury pressure at a rate of around 30 to 60 ml per hour, and we get this square waveform. And for once we stop the pressure, we get 1 and 2 oscillations. Now, if after stopping the pressurization, the oscillations are like you get a continuous reverberations, and there is an overestimation of the systolic blood pressure and underestimation of the diastolic blood pressure, then your system is underdamped. While if there are no oscillations and there is an underestimation of systolic pressure and overestimation of the diastolic pressure, then your system is overdamped. So a normal arterial pulse pressure waveform, it consists of a systolic upstroke, systolic peak pressure, systolic decline, and a diachrotic notch. This diachrotic notch is actually produced by the closure of the aortic valve, and the blood reflects back onto it. And in case of, if we are measuring the central aortic blood pressure waveform, then this diachrotic notch is called as incisura, followed by a diastolic runoff. This diastolic runoff is a very important thing because 40% of the ejection fraction depends upon this diastolic runoff. It happens because of the Windkessel effect, which is actually the elasticity of the aorta that stores the blood once the left ventricle has contracted completely. And then it causes, the movement of the blood into the periphery for the perfusion of the organs, followed by an undiastolic pressure. So this Windkessel effect, it diminishes with age as the aorta loses its compliance. Then something important is that as the pressure waveform, it moves towards the periphery, there is a distal systolic amplification of this pressure waveform because of the reason of this peripheral arteriolar resistance that is encountered as the blood moves away from the aorta, and the arteries, they lose their elasticity. So in the aorta, we have a lower systolic pressure as compared to the dorsalis pedis, and the diachrotic notch, it moves more and more and more towards your diastolic runoff limb, and finally disappears. And this is the reason of this is the loss of the compliance of the arteries, that in old age you have this more of distal systolic amplification, while in neonates you don't have this phenomena as much. Then there is something which is known as augmentation index, which is called as ratio of amplitude of reflected wave to the forward ejection wave, and signifies the cardiac load as well as the arterial compliance. And then there is augmentation of systolic pressure due to addition of converted kinetic energy when the blood hits your cannula within the system. So this is known as end pressure product or the end hole artifact. So various disease processes, disease states have different kinds of arterial waveform. Like in cases of aortic stenosis, we have pulsus parvus et tardus. In cases of aortic regurgitation, we have Bispherians pulse. While in cases of pulsus paradox, in cardiac tamponade, we have an exaggerated state of pulsus paradoxus. We can also measure the systolic volume responsiveness by measuring the systolic pressure variation when the patient is under mechanical ventilation, because in this phase, during inspiration, your left ventricular preload, it decreases while your preload increases while your afterload decreases, while the reverse happens during expiration. When your preload during expiration, it decreases while your afterload increases. So this causes a change in your systolic pressure variation, causes peak changes in your systole, and a large systolic pressure variation, more than 50 millimeter of mercury, is predictive of that the patient is volume depleted and he needs more fluids. Same is the case with pulse pressure variation, and the normal values are 13 to 17%. And for both, the prerequisite is that the patient should be under mechanical ventilation and he is completely paralyzed with a tidal volume of 8 to 10 ml per kg. If it is less than that, then your excursions will be less and it won't be recorded properly. Now, there are various sources of inaccuracy. The most common insertion sites are the radial artery and the femoral artery. In case of radial artery, we use catheter over needle technique because of the small lumen of the small lumen or calibre of the vessel. Same is the case with neonates and children. And we use catheter over wire technique in cases of femoral artery cannulation. So there are various troubleshooting techniques which I have stated in my PDF and you can go through. Coming on to the central venous pressure waveform. Again, the central venous pressure waveform is this. It measures the pressure in the vena cava and so gives an estimation of the preload and the right atrial pressure and the intra. Now, concerned, yes, the most important thing is that the measurements should be done at the end of expiration as to minimize the effects of the intrathoracic pressures. Now, the first one is this A wave that happens because of the right atrial contraction in the diastole, and this happens after your P wave in the ECG. Then is the C wave. It happens because of the tricuspid closure during the isovolumetric right ventricular systolic contraction, followed by an X descent. This X descent happens because the right ventricular contraction is happening and it is pulling down the tricuspid valve downwards, followed by a V wave. This V wave is happening because there is a rapid influx of blood happening in the atrium at the time when your right ventricle systole is happening. And Y descent, it happens because of the opening of the tricuspid valve and the blood rushes down into the right ventricle in the beginning of the diastole. So the decreases in CVP, they happen because of the decreased intravascular volume status or increased cardiac performance, while increases, they happen in increase in volume or venous return, decreased cardiac performance, or an impediment to your venous return. There are various indications. Main ones are, you want to measure the CVP, you want to do an advanced hemodynamic monitoring, IVC filter placement, infusion of irritant substances, central venous oxygen monitoring. Some contraindications are there, but the absolute contraindication is no consent and an uncooperative patient. As far as coagulopathy is concerned, INR more than 3 warrants caution, and a platelet count less than 10,000 warrants caution. So there are various methods of measurement, the indirect assessment and the direct assessment through a fluid film manometer, or in our setup, the pressure transducer systems. So this CVP, it might be single, double, or triple lumen, and it is made mostly of polyurethane, which has a high tensile strength and high degree of biocompatibility, and the flow characteristics, they depend upon the internal diameter and length of the CVP catheter, and the catheter may be coated with certain materials, antimicrobial as well as antiseptic agents and heparin to prevent the thrombotic complications. So the various sites are the subclavian vein, internal jugular vein, and a femoral vein, and rest, some more which we don't often follow. And the depth of insertion can be assessed by this Perry's formula. So there are various techniques of insertion also. It is wire through thin wall needle technique, catheter over the needle technique, then wire through the catheter technique. This is a modified Sendlinger technique. And the catheter over the needle technique may provide more stable venous access if manometry is used for venous confirmation. There are various steps for patient preparation, but when we are using the internal jugular vein, then it is recommended either to keep the patient flat or supine, or otherwise a slight Trendelenburg position of 15 to 30 degree. It helps in, dilating your internal jugular vein, and it increases venous return by approximately 37%, and it also prevents inadvertent air embolization. Then to increase chances of successful cannulation, try rotating your head to the other side, but not more than 30 or 40 degrees, and some Valsalva maneuver also helps in increasing the cross-sectional area of the jugular vein. So these are the various steps. I'm not going into the details of that. Once you have inserted your CVP, you have to measure, you have to confirm your CVP placement. Initially, we think that, okay, if the blood is not coming back through the force or the color of the blood, no, they are not the right techniques. Either through the manometry or pressure waveform analysis, or by doing your venous blood gas. Continuous cardiography also helps us. Transesophageal and chest radiography should be done once if the patient is in OT, once the patient gets out of the OT. And ultrasound is useful either in your static it helps even before cannulation of the CVP, either by monitoring the static ultrasound, where we tend to see where the vessel is lying, or under a real-time ultrasonographic guidance, which is actually recommended in your internal jugular vein cannulation. So it's very important to know the position of the tip of the CVP line, because there is if you enter more inside, there is always a chance of causing pericardial tamponade. So the CVP line should lie at least about 1 to 1.5 centimeter above carina. If it is more than that, then there are always chances of increased risk of infection and thrombosis. So the correct positioning of CVP but depends upon the side of the entry, and it depends upon the intended use of the catheter as well. So this is the diagram, you can go through it. There are various methods of central venous, internal jugular vein cannulation also, and we most commonly use a central method because it has a low incidence of pneumothorax and hemothorax. We also use the anterior mode, but it has more chances of causing carotid artery puncture. So this is the diagram that tells about various positions of the internal jugular vein. Then we have subclavian vein cannulation also. We have supraclavicular, infraclavicular, and USG guided cannulation. The USG guided central venous cannulation has high success rate on first attempt, and it is helpful in accessing when you have a difficult anatomy, and it is it has a but we need, of course, a trained personnel for that and experienced personnel for that. So it can be either in plane or out. It can be either in plane or the outer plane. In the in plane technique, we can observe the whole length of the needle, while in outer plane or short axis view, we'll just be able to observe the tip of the needle. So there are certain factors that affect the accuracy of CV measurements. They are the device factor, artifacts, and the patient factors. Now coming on to, there are various ways to, troubleshoot, which I have written over here. And once you're removing the catheter also, it's very important that you press on the side and you apply a pressure dressing over the airtight occlusive dressing over the side for 24 to 72 hours. Otherwise, there are chances of air embolism. In various conditions, we have different forms of waves, like in atrial fibrillation, there is loss of A wave. In AV dissociation, we have Canon A waves. In tricuspid regurgitation, we have tall systolic CV waves, and so on. Now coming on to pulmonary artery catheter, it is based upon the principle of flow-directed PA catheter via balloon flotation. And the main premise is that once you inflate the balloon and it gets into the pulmonary capillaries, there is a static column of blood. This static column of blood, it corresponds to your pressures. It corresponds to your left atrial pressure. And so if there is no mitral valvular pathology, then it corresponds to your left ventricular end diastolic pressure. So it is a flexible balloon-tipped polyvinyl chloride catheter which softens at the body temperature. It has a length of 110 centimeter. And it is marked at 10 centimeter intervals, and it has a syringe of volume 1.5 ml for inflation of the balloon. Now, at the tip, we have the PA distal lumen through which we can measure the PA pressures. We can monitor the oxygen, the mixed venous oxygen saturation. Mind it, it should not be used for injecting your drugs or your medications. Immediately proximal to it is the balloon. 4 centimeter proximal to it is the thermistor, which measures the temperature, and through the cable connected to a cardiac output monitoring system, we can measure the cardiac output through the thermodilution technique. 30 centimeter, we have proximal injectate lumen for measuring the CVP, for injecting the cold fluid for cardiac output measurement, and proximal infusion technique lumen at 31 centimeter for injection of drugs and fluids. Now, there are various indications you can go through, and contraindications as well. The thing is that once we enter, we monitor the various waveforms, and through that we get to know at what level are we inside the heart chamber, or if we are in the pulmonary capillaries. And the various markings also help us in guiding that. So in the right atrium, it is present at around 20 to 25 centimeter, and we tend to get this CVP waveform. While in the right ventricle, there is a sudden increase in the systolic blood pressure, while your diastolic blood pressure, it remains low at around 5 millimeter of mercury. And once we enter inside your pulmonary artery, there is a sudden appearance of your dicrotic notch and your increase in the diastolic blood pressure around 10 millimeter of mercury. And once we wedge, there is again reappearance of central venous waveform, which is of course a little late according to the ECG as compared to your right central venous pressure waveforms. So it's very important that we wedge at the in the actual zone, that is the zone 3 of the lung. It is very important because in the zone 3 of the lung, your pulmonary arterial pressures are more than the pulmonary alveolar pressures. And if we wedge in wedge zone 1 or in wedge zone 2, our pulmonary alveolar pressures are more than your pulmonary arterial pressure. So we will not get the actual estimates of the heart chambers pressures. So it's very important that the tip of the PAC should lie within 2 centimeter of the cardiac cell hood on the chest X-ray, and the tip should be curved without loops or knots, and in the medial and middle third of the ipsilateral lung field. Various hemodynamic parameters can be measured directly, that is the cardiac output, the stroke volume, the systemic vascular resistance, pulmonary vascular resistance, and the mixed venous oxygen saturation. And there are many derived parameters like cardiac index, stroke volume index, and SVRI, PVRI, and left ventricular stroke work index. So there are through these, if we are in the wrong place or if there is any pathology, our pulmonary arterial pressure waveforms or pulmonary capillary wedge pressure waveforms are going to change. Some complications. Then coming on to cardiac output monitoring, we have a lot of modalities ranging from absolutely non-invasive to very invasive ones, that's the PA artery catheter. And PA artery catheter and thermodilution method is the gold standard for measuring your cardiac output, which is presented as stroke volume into heart rate, and it provides a global assessment of the circulation. The most basic principle is that of the Fick method, where the oxygen consumed by the tissues per unit time is equal to the amount of oxygen extracted per unit time from the circulation. And based on this Fick method, we have indicator dilution method, that is the thermodilution, where the indicator might be the temperature, that is the cold saline or the lithium or some dyes. So thermodilution method is used by using the PAC. Multiple measurements can be done over time. With 10 ml of 0.9% saline or 5% dextrose, ice cold saline is injected as a bolus within 4 seconds. And the cardiac output waveform is, wave is or trace is obtained. Higher the cardiac output, faster the blood flow, and shorter and steeper the thermodilution curve. While in low cardiac output states, the curve is slurred and lazy. Then we have certain pulmonary artery catheters where we can continuously measure this cardiac output by embedded heating filament, which is releasing small thermal pulses every 30 to 60 seconds. Then we have transpulmonary dilution cardiac output measurements, PICO, where we inject the fluid through the central vein, and while we measure the temperature or the temperature at the arterial end. So this artery has both pressure as well as temperature measuring properties. And there's a thermistor dangling in the arterial circulation, and it measures the changes in the blood pressure. It correlates well with the PAC measurements. And then the important thing is that we can have an estimate of the global end-diastolic volume as well as the total intrathoracic blood volume, and so that we can monitor the pulmonary edema as well. So it is less invasive and have a goal-directed algorithm available. Then we have LIDCO, where lithium is used as the indicator dilution. Again, it is minimally invasive, but it is prone to technical errors. Then there are some minimally invasive techniques based on continuous arterial pulse wave analysis, which can be calibrated like Vigilio, which is non-calibrated like Vigilio or LIDCO Rapid or PROACT, while can be calibrated like your PICO, EV1000 and LIDCO Plus. Then we have methods of esophageal Doppler, pulse dye densitometry, and bioimpedance and bioreactance, cardiac output monitoring, and transesophageal echocardiography. Now, this transesophageal echocardiography is an ultrasound technique using an endoscopic transducer to image the heart from within the esophagus. And we have multiplane TE probe, which can be moved into various angles, and from where we can obtain images at various levels and angles, images of the heart at various levels and angles. The ultrasound used is between 3.5 to 7 megahertz. There is a temperature sensor to warn the possible heat injury from the transducer to the esophagus. And conventionally, the transducer is located at the apex of the triangular field of the display and at 0 degree. The patient's right side is depicted on the left side and vice versa. So the 2D T provides tomographic or thin slice imaging, while matrix T provides the 3D images, and that can be used to acquire a volumetric data set. The M mode is the most basic form of echo, and it provides additional information characterizing the motion of the cardiac structures. While Doppler echocardiographic is used to measure and assess the flow across the heart waves and chambers, various methods use a continuous wave and pulse wave technology, and it is helpful in measuring the flow across and assessment of the pressure difference across the stenotic valve between the two chambers, intracardiac shunts, and the pulmonary vein blood flow as well. There are general indications, contraindications to TE, and complications as well. And we can measure the cardiac output based on either modified Simpson rule or by information on the blood flow by Doppler frequency shift analysis. So the take-home message is cardiac vascular monitoring is an indispensable part of anesthesia and critical care monitoring. There are various modalities ranging from very invasive to non-invasive ones. We must know interpretation of data imparted through these devices, their troubleshooting, and their limitations as well. Thank you.
Thank you very much, Dr. Itishri, for such a wonderful and extensive lecture on this cardiac monitoring. And it is very useful. I think this lecture is very useful for all the students. One thing I want to add, that from examination point of view, there are certain questions which examiner usually ask in the exam, like what is Allen's test, what is modified Allen's test. All the exam going PGs must know what is Allen's test and what is modified Allen's test, and what is the significance of Allen's positive and Allen's negative, and different types of pulses in different valvular heart diseases. Okay, and one thing also very important, if you are getting any neurosurgery done, especially a posterior fossa tumor patient in the sitting position, some surgeon, they will ask you to keep the transducer at the level of circle of Willis. Then you should also know what are the different positions you keep the transducer. Dr. Itishri, one thing I want to ask,
Yes, ma'am.
Can you differentiate different types of shocks with the help of PA catheter and CVP and arterial pressure waveform?
Yes, ma'am, they can be like with the help of PA catheters, we can differentiate different types of shock, ma'am. For these, we need to monitor our right atrial pressures, the pulmonary capillary wedge pressures, the cardiac output, SVR, and systolic blood pressures. Now, in case of cardiogenic shock, our right atrial pressures will be increased, our pulmonary capillary wedge pressure will be increased, while the cardiac output will be decreased, and your systolic blood pressure will be decreased. However, the SVR might be increased. In cases of hypovolumic shock, we will observe a decrease in all the parameters except in the SVR, which might be increased or decreased depending upon the state of the amount of hypovolemia which is existing. And in cases of septic shock, we all know that the right atrial pressure and the pulmonary capillary wedge pressures, they tend to remain normal until extra fluids are given to the patient. And however, the cardiac output could be normal, or it might be hyperdynamic circulation with an extremely low SVR.
Thank you. One more thing. Can you explain what is phlebistostatic axis?
Okay, ma'am. Actually, phlebistostatic axis is the axis. It is the reference point at which we want to zero our transducer. And because whenever we are measuring our invasive pressures, they are measured through this hydrostatic column of fluids. So this hydrostatic column of fluid will also exert some pressure if they are not measured at some reference point. So this phlebistostatic axis, actually it is corresponds either to your in cases of CVP, it is the right atrium or the tricuspid valve, and in cases of invasive arterial blood pressure, it is considered to be aortic root. And this can be like over the surface. We draw a line in the fourth intercostal space at the nipple, and the point at which it intersects at the mid-axillary line. This is actually the phlebistostatic axis, and here the measurement in our blood pressure or CVP levels is minimal. I mean, the error in the measurement is minimal.
Can you tell us some other uses of T, like in critical care and resuscitation?
Yes, ma'am. Actually, T has actually come up in a big way.
Also. Yeah, I think it was not. We were.
Yes, ma'am. Actually, T has actually come up in a big way in critical care scenario, and especially.
But in the morning, they were saying that there sometime last year they were having some question on T also.
Okay, ma'am.
Poonam was saying, and Dr. Akhilesh was also saying.
Okay, so actually T has actually come up in a very big way. First of all, of course, we can monitor, I mean, the function and the contractility of the heart, then some valvular pathologies if they are present. If T is there inside, we can very easily monitor, some vegetation, especially if they are present in the posterior part of the heart, like, the mitral valve or the tricuspid valve, or in the left atrium, the thrombus is very easily observed because the T is there behind in the esophagus. Okay, and then of course, T has a very big role in by measuring the collapsibility or the distensibility of the IVC or the SVC, or by measuring the left ventricular end diastolic area, we can decipher if the patient is hypovolemic or not. And then in pulmonary thromboembolism also, it has a big role. I mean, in the sense, it gives a surrogate if there is an acute or dilatation of your RA or the RV chambers and increase in their pressures. Then during resuscitation also, ma'am, like it's very important, like first, the biggest thing is these patients, if they are intubated and if they are like chronically, if they have, if they are suffering from ARDS or something, in that case, they are much better than TTE, because TTE is prone to error. You cannot easily, see the structures. And then of course, every time you cannot interrupt the CPR sequence if it is going on. So T once put inside, it is there inside, and you can monitor the CPR, and you can also monitor the quality of the CPR by seeing if the left chamber are adequately being compressed or not, and if LVOT, there is blood flow through the LVOT or not. So these are some indications of T in critical care and resuscitation.
Thank you very much, Dr. Itishi. Dr. Shripriya, any questions?
No, ma'am, not till now. And thank you so much for your insights also, ma'am.
One thing more I want to add, for the PG students, if you have options of CVP and you have intravenous catheter in the emergency room, and if patient comes of trauma patient comes, and patient is in the shock. If PG thinks that I will put central line, it will be good for me. Let me put central line. I will not put IV cannula. But I want to emphasize that 16 gauge IV cannula and 16 gauge your CVP cannula, which has length of 7 centimeter, and 16 gauge IV cannula, which is of just 3 centimeter. The flow rate of fluid will be 3 to 4 times in IV cannula as compared to the CVP cannula. And it is because of the Poiseuille's law that resistance is equal to 8 NL divided by pi r raised to the power 4. If length is more, resistance will be more. So at the time of resuscitation, your main emphasis will be on the fluid volume you have to give. So you will choose the IV cannula. Anything else? Thank you very much, Dr. And thank you very much, Dr. MD Kaur and all the faculty for giving me this opportunity. And I am really thankful to you. Thank you very much, madam. And this session is going very, very, very good. I'm really.
Ma'am is saying something. Ma'am, please unmute yourself. MD ma'am.
Thank you so much, Dr. Jaswinder and Dr. Itishri, for being with us.
Thank you so much, ma'am.
Giving us such an elaborate talk. I think PGs must have been helped by whatever you have concluded with your concluding remarks. Dr. Jaswinder, it must have helped them to stimulate them to know what pertinently they should know. Thank you so much.
Technical aspects they should know.
Yes, that's all.
That is very important.
That's very important. Basically, we are aiming at the PGs, so their point of view is more important from the examination side. Whenever we see that this is to be expected from a PG student, and then if they are clear about it, and especially from your deliberations, then that is the main aim of the PG assembly. Thank you so much.
Thank you. Thank you.
Thank you.
So now let us proceed to our next session, which will be chaired by Dr. Suniti Kale. Shobhit, please put the CV. So Dr. Suniti Kale, she is professor and consultant at VMCC and Safdarjung Hospital. Her area of interest is pediatric anesthesia and ATLS. I welcome you, ma'am, on behalf of Appec.
Thank you so much for the kind introduction. Am I audible?
Yes, ma'am, you are audible, ma'am.
Okay.
Welcome, ma'am.
Okay, thank you. Thanks a lot for inviting me as a chairperson for this session. And of course, it's the last session of the day. But we have two important topics. Capnography, as we all know, is the gold standard for securing airway during anesthesia, even outside the OT. And I have the pleasure of introducing the speaker for the day, who is, I haven't got him on my screen as yet.
Shobhit, please put the CV slide.
Okay, so I am pleased to invite the speaker for the day, Dr. Dheeraj Bhandari. He is a professor in anesthesiology and intensive care at Mahatma Gandhi Institute of Sciences, Sevagram, Wardha, Maharashtra. His area of interest is difficult airway, critical care, obstetrics, anesthesiology, and critical care. So without taking any further time, I invite Dr. Dheeraj to proceed with this most important lecture. Dr. Dheeraj, please.
Thank you, ma'am.
Shobhit, please start the recording. Shobhit, please start the recording.
For having me here to talk about capnography with all of you. What we'll do is we'll talk about basics of capnography for something which will help us manage day-to-day clinical cases. This is something going to help you with the rapid revision before examinations. There will be occasionally brain teasers, but this is not going to be a substitute to in-depth reading of this important aspect of monitoring in anesthesia and acute care medicine. We'll talk about history, guidelines, nomenclature, physics of capnography, equipment, respiratory physiology, a normal capnograph, what are its components, abnormal cap, the common ones, of course, with probably some case scenarios, and the role of capnography beyond operation theater. But before we proceed to that, we need to understand that the capnography is a friend of ours. It's a friend of anyone who is practicing into acute care medicine. It is good for the patients, it is good for the anesthetists, it is good for the surgeons, but it also helps you for medical legal purposes, and it always gives you a peace of mind whenever you are dealing with any clinical cases. If you look into the evidence part of it, post 1985, in the Western setup, at least it has been clearly documented that there has been significant decrease in the malpractice claims, amongst various other reasons like improved curriculum training, skill-based trainings, and other things. One of the important reasons has been and steady adoption of the newer technology into the practices, and one of them definitely is capnograph. This has been endorsed by the various society guidelines as and when updated, and this is all based on robust evidence. So again, this is a Zoom meeting. It's difficult to have an interaction. Wherever I feel that there's a question, I'll give a moment for the pause. Those of you who can guess the answer would be good enough. Otherwise, I'll keep on telling about what the particular reference was. Now, this particular thing, a bird which is being shown into a capnography presentation. Any guesses what it is about? Yes, this is a canary bird. It's a very soulful bird. It is continuously chirping. It is sort of trying to play some songs or something out of its own thing. A very soulful bird. The coal miners, they use this bird to take them down along with them to the coal mines. What happens is whenever there is a presence of toxic gas or the oxygen concentration is less, this bird's chirping go down. It stops singing, and this alerts the coal miner that there are presence of toxic gases around and they should probably exit the area. Sir Humphrey Davy in contributions, but specifically I'm talking this Humphrey Davy lamp. Again, same principle. Whenever the coal miners, they carry it with them and the presence of toxic gases are there, or whenever the oxygen concentration is less than 17 to 80%, the flame of this lamp goes off. What I'm trying to emphasize here is, as scientists, as human beings, we always had this quest to discover gases around us, and the EtCO2 or the carbon dioxide has been no exception. This is one of the oldest capnograph which has been used. This is called as the Goddard capnometer. I am just putting the picture out here to understand you that look at the device size and compare it with the device size which you have today. The technology has evolved over a period of time so much, but you should never forget your history if you have to go into the future. So based on this, where do we stand in terms of guidelines? Now, if you look at the WHO, WFSA guidelines, these guidelines are about the minimum anesthesia monitoring. The common thing amongst all of them is to have a vigilant anesthesia professional every time present in the operation theater. Along with that, if you look, they say that it is mandatory to have a CO2 detector for intubated patients. American Society of Anesthesia guidelines, it goes even one step further. It says it should not be only expired CO2, which should be continuous with an alarm system, not only during general anesthesia, but also during moderate or deep sedation. This is a very important point. The Great Britain and Ireland Society, again, the inspired and expired carbon dioxide has to be measured. European Board of Anesthesiology, again, it's a mandatory thing. Canadian Society, for mandatory for GA as well as sedation. The Australian and New Zealand College of Anesthetists, carbon dioxide monitoring is mandatory during general anesthesia. Where does the Indian Standard of Anesthesia guidelines? We have also mentioned that yes, it is a desirable standard, and hopefully over a period of time, whenever the guidelines are revised, this might probably come into the basic standard. The availability, the widespread use, and it's going to be a bottleneck, but hopefully we'll be able to overcome these problems. Now, before we venture into the physics of capnography, equipment used for capnography, let's have a look at the nomenclature. There is something called as capnometry and capnography. As the name itself implies, capnometry is basically numbers. It will give you a number about inspiratory carbon dioxide, expiratory carbon dioxide, or probably both. But capnography is something a graph, and a graph is always plotted against two different axes. So on the basis of this, capnography can be divided either into time capnography or volumetric capnography. A time capnography is again very important, something which we are using in day-to-day practice. Most all of our monitors, wherever using capnography, this is a time capnography. That is, the capnograph or the EtCO2 trace is monitored against a breath-to-breath sequence against a time. Whereas in volumetric capnography, this is done against the tidal volume or the volume which is calculated, and this is plotted against the carbon dioxide concentration. Its advantages, its disadvantages, I'll be talking about in my upcoming slides. Then PaCO2, PaCO2. But remember the difference, one is a capital A and another is a small a. The capital A stands for partial pressure of CO2 in the alveoli. The small a stands for partial pressure of CO2 in arterial blood. Now there is something PeO2, that is the partial pressure of CO2 end of expiration. And then there will be a gradient between arterial and end tidal carbon dioxide. And this is what we call as A minus ET PCO2. It's always good to remember. We'll talk about this more in detail in our upcoming slides. Now coming to the physics of capnography. If you want to have a one-liner answer, the most common answer will be infrared spectroscopy, but that's not the end of it, isn't it? If you talk about physics of a capnography, at least there are 5 different technologies which are very clearly used. Infrared spectrometry, molecular correlation spectrography, Raman spectrography, mass spectrography, and of course the photoacoustic spectrography. You can see here the carbon dioxide can be measured 5 different techniques. Mass spectroscopy and Raman spectroscopy additionally measures oxygen as well as nitrogen and most of the airs. But the commonly used the technology is about the infrared light. We'll not go into much of detail. It's a fascinating read. If you have time and you find the inclination, you should definitely read about these techniques. Mass spectroscopy, what it does is it separates the molecules on the basis of mass to charge ratios, and almost all the components of the gas are allowed to be found. I'm not going to go into detail, but probably this is an interesting thing to know. This is a mass spectroscope. This is somewhere around in 1963, and I'm sorry for the small design. But what used to happen is the patient's expiratory gas samples from individual operation theaters used to come to this centrally located machine, which was also in one of the rooms in operation theater, and the gases used to be measured here. So it was not a continuous measurement, but a continual measurement. What I mean to say is frequently repeated, and there was basically a limitation was it was not a continuous. So it's like something you send to a lab, the lab gives you back the report. But that is how it started, the concept, how it started, isn't it? The advantages were rapid response, very accurate if appropriately used, and a wide range of gases can be measured. But as you can see, this is disadvantages is it's bulky, expensive, and discontinuous. The next principle is about Raman scattering. There is an intense coherent monochromatic light source, and this will pass through the gas chamber. The gas molecules will scatter the light, and some of them will get absorbed. If you can see here, there is a helium neon laser light. There's a gas sample which has to be measured, and the light will pass through this. Some of these molecules will absorb the gas. Then based on specific gas filters and a counting circuit, you will have a digital count for each of the gas, which can be computed and analyzed and put up as a graph and a number. Raman spectroscopy was used in Rascal monitor. It's a very important phenomenon for all of us to know. Again, can you see this monitor? Oxygen, nitrogen, nitrous oxide, isofluorine, CO2, almost everything is measured. But again, it was bulky and the cost was not there. So far as mass spectroscopy and Raman spectroscopy is concerned, their accuracy is very nice. They have multiple agents capacity to measure, but there are better techniques which are more cost effective, less bulky, and which can be used in clinical practice in a more better way. And one of them is infrared analysis. You all must be knowing this physics. There are radio waves at one spectrum and the gamma rays at the other spectrum. The radio waves have the wavelength almost in the meters, like almost they say if you want to compare it, it will be somewhere in the height of buildings to humans, whereas the gamma rays will have the height of atomic nuclei. Just before the visible spectrum, you will have infrared somewhere around the height of point. Now, this is something which is a very fascinating thing. So how does an infrared spectrograph run? The advantage is it's a compact design, less expensive, and it becomes most commonly used technique. Therefore, infrared is absorbed by polyatomic gases. That is the molecules which are made up of more than 2 different atoms. CO2, nitrous, water vapor, all of them can absorb infrared rays. So what happens is you'll have to find out a specific length for your desired particular. If you want to measure CO2, you'll have to put a particular filter. If you have to measure a particular anesthesia agent, you'll have to use that particular agent. So what happens is there is an infrared source, then there is a filter. Suppose if I am measuring a CO2, it will allow the lights only in the range of 4.4 micrometers, and rest of them will be filtered out. Now, whenever this rays passes through the gas sampling chamber, some of these rays will get absorbed. So if the amount generated is X and the amount returning back is Y, the difference will be computed and you will get a graph as well as number as to how much amount of carbon dioxide is there at a given phase of time in the gas sample. This is how it works. Very simple thing to explain. I'm not going to go into the details about infrared spectroscopy and everything. This is what I was trying to tell. Between 4 to wavelength, you will have CO2, nitrous oxide, and inhalational agents at different wavelength, and you will have to put a particular filter for every time. So that means what happens, if I am to choose a particular gas to be selected, I'll have to put a particular filter. In the monitor, you'll have to select the agent. But with newer technology, what happens is there are multiple filters which can be put at the same time. And what it leads to? It leads to identification of agent automatically, the newer technology, isn't it? You have your newer monitor, you don't need to select the gases, but if you look at the older monitor, you need to select the gases and they can automatically quantify the agent. The physics about all of this is right now out of the scope of this topic. I just wanted to give you an introduction about the whole thing. Next is molecular correlation spectrograph. Again, an infrared technology, but the advantage is it's highly efficient and specific. That is, it creates a short light path. Now, what happens with this is you can do gas sampling, or exact identification of the gas, even with less sample of gas. And how is this useful? I'll talk to that about when we talk about different type of side stream capnographs. Now, the equipment used. CO2 can be done detected by 2 different things. One is a qualitative or semi-quantitative thing, what we call as the colorimetric carbon dioxide detector, and the second is capnograph, that is the quantitative detectors. If you talk about colorimetric capnography, we all know CO2 solution is acidic. We can use a pH sensitive dye which can be used in the litmus paper, and whenever the carbon dioxide will come into contact with this, there will be a change into a color. For example, you can look here. This is connected, suppose, to an endotracheal tube or an ambu bag. Whenever the carbon dioxide will come through it, if it's in a lung, there will be a change in the color, and based on how much the change of color is there, you can have a rough approximation in which quantitative range it will form. So it's a semi-quantitative thing, but then it will give you an accurate indication. There are limitations. You cannot use this as a continuous thing. It's one sort of thing. And if there are positive results at times because of gas or gastric secretion. Again, this is a Phenom CO2 detector used to be with ambu bag. And this is something for the NG tube or the Riles tube, what we say. You can connect it at the end, and then you can see whether it is in the esophagus or in the stomach. Now, how do you sample the gas in a normal capnograph? I'm not talking about the colorimetric now. You can either have a mainstream capnometer or you can have a side stream capnometer. The difference is the time lag. I mean, how much time is it required for the capnograph to be measured? We'll see about it. These all diagrams are from capnography.com. It's a wonderful site, and without that, this presentation is very difficult. Now this endotracheal tube, this is your ventilator breathing circuit, and you have a mainstream capnograph which detects the CO2 then and there itself. You have the infrared source as well as detector. So this is a mainstream. It has a very rapid response time, say in milliseconds, almost 50 to 60 milliseconds. But in a side stream capnograph, what is happening is you will have to pump out the air actively to the separate monitor, isn't it? And there it will measure. So there will be a response time which will be almost around 1 to 4 seconds. Now again, based on how much of air has to be pumped out, this can be the conventional one where it used to be 150 to 200 ml per minute of gas being sampled out. Now imagine what happens if you are using a 150 to 200 ml for pediatric, or for that matter infant who have such a less tidal volume. There will be a lot of dilution and there might be fizzles. So with the newer technology, as I was talking about during the molecular correlation spectrography, even a sample of 50 ml of air is sufficient for us to detect. So this is how the technology has evolved, and now the side stream capnograph can be used, the newer technology, even for infants, isn't it? I'm not going to go into much details, but the advantages of mainstream are there is no sampling tube or obstruction, no delay time, and it was traditionally suitable for neonates or low flow anesthesia. Disadvantage was, if you look at the weight, it's a significant weight. There will be traction, measurement of other gases used to be a problem, but now this has been solved with the newer version. Their case can be clogged by secretion, and this is again a potential for disconnection. You have multiple disconnections, you have chances for disconnection also. But with side stream, whatever the disadvantage mainstream were there, they are all automatically into edges. And if you look at the disadvantages, flow was an issue, but with newer technology been solved. Transit time delay is there. Tube obstruction can be there, as we commonly see. Water vapors are there. You need to regularly place the traps. Calibration and weight can be a problem. Now, there are certain advantages, recent advances. One of them is Philips CO2 connector. What I was talking about, that mainstream normally used to be for CO2 only, but with this technology, even the gases can be measured. And there is something called as the phase-in monitors. One of this is phase-in emergency capnometer. It's a meter, so you will only have the number. But look at this device. It's such a small device. You can literally carry it with yourself, use in the emergency department, and you will be able to know whether your tube is in the pen, and secondly, what is the current CO2 value. So technology has evolved over a period of time. This is again for spontaneously breathing patient, you can measure CO2, very important and very useful. Now coming to the respiratory physiology and normal capnography, I'm not going to go into details, only bare essential. Okay, so this is the difference I was talking about, the volume, this is the volume capnograph and the time capnograph. Time capnograph, you have 4 phases, 1, 2, the plateau phase 3, and then the downstroke, that is the inspiration starting 0. And the volume capnograph is something you'll have only 1, 2, and 3 phase. The inspiratory phase is lagging. That is the one difference. And second thing, this is measured against the tidal volume. So we'll have be able to calculate the effect to tidal volume as the dead space, and the dead space can be further into physiological and anatomical space. The monitors are able to do that. Now let's talk about a normal capnograph. A normal capnogram has 4 phases. Phase 1 is one which reflects the inspired gas, which is normally devoid of carbon dioxide. And the phase 2 is the expiratory upstroke. This is the transition between the anatomical dead space, which does not participate in the gas exchange, and the alveolar gas, which will start coming from the respiratory bronchioles and alveoli, where the gas exchange would have, it has just started. Phase 3 is the alveolar plateau. Traditionally, PCO2 of the last alveolar gas sample at the airway opening is called the PET-CO2. This is important. If somebody asks you, okay, which is the PET-CO2? The last sample just before the in-stroke, which is the highest number, is the PEO2, which is calculated. And then the phase is the inspiratory downstroke, the beginning of next inspiration. Now, there is further detail. Additionally, you can see a hump here. That's a very minor. This is called as the additional phase terminal upstroke. This is seen in pregnancy, OBs, and children, where the suddenly last of the alveoli, which has low VQ, will suddenly start emptying. They contain more of carbon dioxide, and you will see a sudden slight increase before the inspiration. Normal value, as I've already told you, 35 to 40 millimeters of mercury, and you need to understand the difference between the time and the volume capnograph. Additionally, we talk about the angles, the alpha angle and the beta angle. The alpha angle is the angle between 2 and 3 phase, isn't it? This is normally around 100 degrees, and the airway caliber at this angle. For example, if I have a bronchospasm, I will have a prolonged phase 2, and the phase 3 will also be plateaued up, and the angle between the phase 2 and phase 3 will go up. But if you give a bronchodilator or correct that thing, your angle will start coming back, and you can judge your response as to how much it is helping you. If you talk about beta angle, it is between phase 3 and 0. Normally it is around 90 to 1 again. But if you have a problem with rebreathing, so what will happen is rather than coming down, slowly coming down with a greater angle, to understand that there is some problem with rebreathing. Lastly, it's an important thing. This is very important. It might be a sort of additional viva question if you are doing good viva, that phase 3 is never a horizontal one. You see there is a slight upturn. That is because all alveoli don't have the same amount of ACO2. The alveoli low VQ will expire towards the end, and therefore you will always have a slight upsloping. This is very important for us to understand. Now, having talked about normal capnogram, let us see if we can identify some common abnormal capnograph. It is beyond this time to have it completely covered, but yes, some common things we'll definitely try to cover. The uses we have all seen, and there are 3 important things when we talk about capnography. The numerical value, it will also help you, the shape of the curve, and if you have a blood gas, the difference between EtCO2 and PaCO2 will additionally tell you a lot of information. So let's see a case examples. A 32-year-old patient is posted for laparoscopic cholecystectomy. He is induced with general anesthesia, propofol, and scoline. The tube position confirmed with CAFE. After the patient starts spontaneous breathing, aptracurium is given. The surgical team, they start their cleaning and draping. Immediately after around 2 to 3 minutes, the resident anesthesiology notices following change with the graph, isn't it? So what is happening here? I'll pause here for a second. What is happening? The phase 2 and the phase 3 is prolonged. The alpha angle has prolonged. So this is basically something to do with the airway caliber. So there has been airway obstruction or bronchospasm. Now the reason can be probably it is secondary to atracurium causing some amount of hysteresis or some sort of bronchospasm. So you need to look into that. Now just few spots, if you can see, there's a hyperventilation causing the PCO to decrease down, and there is a hypoventilation which is causing the PCO2 to gradually rise up. Now the difference is, if this diagrams, if I have to draw it again, I'll probably decrease the rate here. This is hyperventilation, so this graph will come very close. And if it's a hypoventilation, this graph will come more spaced out. That's another way to make out, isn't it? Coming to another example, a 35-year-old patient with community-acquired pneumonia with moderate ARDS is ventilated with, just will talk about intermittent mandatory ventilation. The resident who has come for night shift calls you and says there is something wrong with the capnograph. He has not seen a graph like that. He is unable to figure reason. You ask for the trace of capnograph. Now it's a telemedicine time, and you see this capnograph, isn't it? Yeah, the shapes are different. So what can be the reason? Yes, you are right. The reasons can be that one of them have a mandatory breath in between the spontaneous breath. So this is an intermittent mandatory ventilation. Again, a 41 kg thin-built ASA1 is being operated for radial fixation under GARA. The first-year anesthesia resident notices the capnography has some abnormal waveforms, and he then calls you and requests you for guidance. So what are your differential diagnoses here? Yes, it's a ripple effect. It's a cardiogenic oscillations. At times, especially in ICU where the heated humidification is used, you can also have the water in the ventilator circuit, which might also cause some sort of a ripple effect. So you should be aware about this. Another example, a 46-year male patient is operated for radical cholecystectomy under GA and RA, is maintained with a routine inhalational agent. Curium is given intermittently. The traces the capnography, something like this. I'm sorry, graph has gone up, but this is basically a curare cleft. I'm sorry for that. So you see that there's a curare cleft. The anesthesia resident say that I am giving a good volume of muscle relaxant, but their problem with the drug is not working. So shall we change the drug? So you say, okay, I'll come just 2 minutes. And you reach there and you see that they are coming sporadically and not at regular intervals. You just then notice that the surgeon is doing a deeper dissection and is occasionally pressing abdomen for exposure. So you need to understand that curare cleft, even though common with muscle relaxant patient, but even at times with pressing of abdomen and thorax, you might be able to see this particular effect. A freelancer in his private practice who has his own capnography monitor starts a fresh passed out anesthesiologist along with him for cases, an ideal scenario, isn't it? But then the surgeon who owns the OT suite is a very basic Boyle's machine. There is no closed circuit. They are doing a modified radical mastectomy under TIVA. The younger colleague who is new to all these things notices something peculiar about the capnograph. So what is this capnography looking like? Yes. This is basically a signature effect, or what we call as the Bain anesthesia system or the Mapleson-D system, causing the rebreathing. You should be aware about this. Okay. Next, a 52-year-old renal malignancy patient is being done under anesthesia. Almost around 4 hours of has been done, and the anesthesia resident sees the capnograph. He says probably the machine had problem. Last time also there was some problem with the capnograph, and he tends to ignore it. There is a consultant, but begs to differ. He says, even before we label this as a machine problem or just want to ignore this, I have a particular suspicion that there might be a specific problem. So what do you think he's suspecting here, he or she, the consultant? Probably they are suspecting expiratory wall defect. What they do is they open the expiratory wall, they see that the moisture is there and it is causing the expiratory wall to stuck, and they clean it, dry it and put it back, and temporarily it is okay. Once the case is done, they summon the engineer to repair the things back. This is very important, isn't it? Just few spotters, you can have differential lung emptying like one lung anesthesia, sampling leaks, sampling by oxygen face mask, or nasal cannula can give you a capnograph like this. Probably last few cases, you are being called to OT by the resident urgently saying that the ETCO2 is rising despite adequately ventilating the patient. Now, this is something which will ring the bell. Your immediate concern is, are you looking at a malignant hyperthermia? Though rare, but this is something which is most dreaded and most of us worry. But then you notice that there is no fever, the rise of ETCO2 is slow, there is no muscle rigidity. You look at the soda line to the corner of your eye and notices that it is exhausted. You ask the resident who checked the anesthesia machine, and the resident proudly says that he supervised the self-checking of advanced anesthesia workstation. You ask about when soda lime was changed, and the resident then appears baffled. See, I'm continuously using resident examples here. We all have been residents. We all have made that mistakes, and things go on. Another mistake I would like to especially is, why didn't the consultant also check about soda lime at the start of the machine? So just don't get bother the comment that all the mistakes are being done by resident. This is how things are learned, isn't it? Don't bother about that. Malignant hyperpyrexia. It's a very classical thing. Initially, if your soda lime is good, you will not have a rise in the inspiratory CO2. But as the soda lime starts getting exhausted, your end expiratory as well as the inspiratory, both of them will increase. Now, the role of capnography beyond operation theatre. For procedural sedation, for example, in interventional radiology, ERCP suites and everywhere, the most important thing is morbidity and mortality are documented because of hypoxia, and capnography is a better monitor to detect these complications earlier stage, even before pulse oximetry. And therefore, many of the societies have mandated that even for procedural sedation, you should have a capnography being used. Pulmonary resuscitation. It confirms the advanced airway placement wherever you are doing a CPR. It monitors the effectiveness of chest compression. If you are not doing an adequate CPR, it helps you. Return of spontaneous circulation is probably most early indicated by a rise in ETCO2 when you are looking at the monitor. Although not very accurate, but this also can serve as a marker for prognosis. For example, if the ETCO2 is less than 10 millimeter mercury after 20 minutes of CPR, you can probably accurately predict death, isn't it? Capnography in ICUs. Intubation confirmation, very important. Most of these ICU patients are sick, they have a borderline cardiorespiratory reserve, and you really need to be good and sharp, and these techniques will help you. If you look at the 4th National Audit Project, almost 75% of death, neurological injury could have been prevented by capnography in the ICU. Again, as I've elaborated, bronchospasm, indirect way to see about your cardiac output, isn't it? With the cardiac output rising, your ATCO2 will go up. With your cardiac output coming down, if a patient is in shock, your ETCO2 will come down. Neuro ICU, to have a good amount of ETCO2 so that your ICP and secondary brain injuries are in a proper way controlled. Brain death. Volumetric capnography, as I was talking about, dead space assessment, cardiac output measurement, metabolic rate determination. This is coming up in a nice way. So this is basically the past and present and future of the capnography. We all need to embrace it. We all need to accept it and learn this technology in a better way. It has to be integrated with a clinical sense. It will go in a long way in patient. Thank you again for any questions. I will be happy to answer them.
Thank you, Dr. Dinesh, for this wonderful, very elaborate presentation. And I think the historical perspective was pretty interesting for all of us. It was also interesting to have those case presentations going on because, am I audible?
Yes, ma'am, you are audible.
Sorry. Okay.
Yes,
Okay. So thank you, Dr. Dheeraj, for a nice elaborate presentation. The historical perspective was really, it was interesting. I hope the postgraduates enjoyed how the modern day capnograph has evolved over a period of time. And I think the case presentations was also an interesting concept. So thanks for a presentation. First of all, I'll take any questions. Are there any questions?
Yes, ma'am, one question is there. In which situation pigtail appearance is seen?
Okay, Dr. Dheeraj, can you answer that? Can't hear it.
Dr. Dheeraj? Dr. Dheeraj, am I audible?
Dr. Dheeraj?
Hello.
Yeah, can you hear? Okay, before that, just let me quickly summarize the importance of capnography. I think, as he's rightly pointed out, it is the gold standard for airway management. It can be a standalone capnograph, or it could be a part of a multi-monitor standalone, as he rightly pointed out, very important outside the operation theater also, especially during resuscitation and trauma. Calibration of capnograph is very, very important, whichever kind of machine you may use, as per the recommendations. Hello.
Dr. Dheeraj, can you hear us? Yes, ma'am, you can continue, ma'am.
Okay. So, and most important is, although it is the gold standard, it is not the only parameter. You have to collaborate the other clinical findings. It has a very important role outside the operation theater, especially in emergency and resuscitation, where definitive airway placement is confirmed by a capnograph, and simple, especially when you go for peripheral calls to the wards and all. Handheld capnographs are very useful over there. In older days, of course, the calorimetric technique was used, but that's again a very, very important indicator for them. Also, I would like to say that it is an important guide, as you said, for resuscitation. And not only finding whether your CPR is effective, it is also important to know that there is a return of spontaneous respiration. So these are some of the important things. Of course, the waveforms, the examples have been given. You should also remember that capnography is not changed only by respiratory parameters, but it is affected by metabolic and circulatory parameters also, as has been mentioned by him. And generally in circulatory parameters, shock is pulmonary embolism. There's so many examples of those. You have metabolic causes like malignant hyperthermia. A simple diagnosis of a thyroid storm intraoperatively can also be diagnosed by a rise in capnograph. And generally, by the way of differentiating is when you have a respiratory problem, the wave is normally not normal. And also there is a difference between, as he said, difference between the end tidal and the alveolar and the arterial end tidal carbon dioxide. So these are important factors that you remember. It's a very, very important monitor. I think a must in all OTs, in all ERs, and also in the peripheral use. So Dr. Dheeraj, are you with us now?
Yes, sorry, I'm sorry. I have logged in through another device, ma'am.
Okay, it's okay. It's all right. It's all right. Okay, so there is one question for you. I think Dr. Chupri, I will tell you.
Yeah, one question is there. In which situation you can find pigtail appearance in capnography?
Pigtail we can see in poorly compliant lung. As I was showing in one of my slides, you can see that probably in fat patients, pregnant patients, you can see that phase 4 sort of thing, or maybe a poorly compliant lung when there are different types of inhomogeneous lung, and you can see sudden rush of end tidal carbon dioxide just before the inspiratory thing is starting. So you can see a sudden rush of EtCO2, and that peak can suddenly go up, and that is what we call as the piggy tail appearance in this thing. I'm sorry about the audio quality also. I think it was not very good.
No,
There was a lot of I'm sorry about that.
No, it was audible most of the time. I think it was fine. It was good.
Thank you.
No other questions.
Can we now? Okay, I think we can. Time is also the. Can we proceed to the next lecture?
Yes, ma'am. Yes, ma'am.
Okay, so Dr. Dheeraj, again, thanks a lot for a very elaborate and nice presentation. And the next speaker is has been a colleague of mine, Dr. Ridhima. Can I have a slide, please, ma'am? Dr. Shivpriya?
Shobhit, please put the CV slide.
Okay. So Ridhima, have had opportunity to work with her. At present, she's an assistant professor. I think, if I'm not mistaken, she's from postgraduate PGI Chandigarh. She's done an MD from there. And now she's working in the super specialty pediatric hospital and postgraduate teaching. It's a new institute which has come up in Noida, which is dedicated totally to pediatrics. So it's a great concept. Her area of interest obviously is pediatric and regional, and with pediatric, obviously obstetrical anesthesia go hand in hand. And she's going to talk about a very important topic that, most of us should know, but are not very familiar with, and that is disinfection. So Ridhima, over to you.
Good evening, everyone. And before I start, I would like to thank and congratulate Dr. M.D. Kaur ma'am and all the members of the organizing team Appec 2021 and giving me the opportunity to be the part of this academic endeavor. My topic is sterilization and disinfection of OTs and equipments. And before I start, I would like to acknowledge certain terminology that will be frequently used. What is disinfection? It is a process of inactivating pathogen organisms except for the bacterial spores. And sterilization is defined as a process that destroys or eliminates all forms of microbial life, including the bacterial spores, ensuring a acceptable level of sterilization. So a SAL of 1 is to 10 raised to power 6 represent that a 1 in a million chance of an organism surviving the sterilization process, and at this level, an item or equipment is considered to be sterile. Then bioburden is the population of viable infectious agent contaminating the device. In 1968, Spalding classified the medical instrument into 3 parts: critical items, semi-critical items, and the non-critical items. Accordingly, the items that enter the sterile body tissues, cavities, vascular systems are considered as critical items, and thus pose a high risk of infection involved with their use. They are usually used single, disposable, and it is not recommended to reuse them. And reprocessing is regulated by the FDA under strict requirements. Under critical items, all our 3-way cannula, our epidural catheters, our syringes comes under this. For the semi-critical items are the items that comes in close contact with the mucous membrane or non-intact skin but do not penetrate, and they require a high level of disinfection. All our airways, nasal, oral, our tube, our LMA, our laryngoscope blades come under the semi-critical items. Our mask, our breathing circuits, and fiber optic bronchoscope. For the non-critical items are the items that do not penetrate and comes in contact with only with the intact skin, and the cleaning process should follow low to intermediate level of disinfection. Laryngoscope blades, anesthesia machine, ECG leads, stethoscope, BP cuff, pulse oximeter come under the category of the non-critical items. Just to give you an overview, there is every hospital has or a big institute has this CSST department, that is Center Sterile Service Department, in which there is a cleaning, disinfection, inspection of testing and packaging, sterilization and storage and use takes place. And this is a cycle is repeated and again. Now comes the question, what sterilization or disinfection to be done? On which base it depends? So it depends on the type of organism we are dealing with. If we are dealing with the bacterial spores, then definitely requires a high level of disinfection. If we are dealing with the Mycobacterium intermediate, and if we are dealing with the low non-lipid small viruses, then it may require a lower level of the disinfection. And then there is a descending order of resistance of organisms like fungi, vegetative bacteria, lipid, or medium-sized viruses, and accordingly, the disinfection or sterilization method can be deployed. So cleaning is the most important part of the decontamination process, and we must have seen in our OT, our technician and sisters manually cleansing the instrument, and it is basically done to lower the bioburden before disinfection or sterilization, and it involves washing with cool water and a detergent, and the temperature of the water should not be more than 45 degrees because at higher temperature it may lead to coagulation of the proteinaceous material, forming a layer of the microorganism. So there are basically two types of cleaning is there. One is manual or automatic mechanical method, in which manual, one thing is that we can immerse our items or equipments in a detergent solution of 35 degrees Celsius and visible soiling can be removed. And in non-visible item that can be damaged by soaking, a cloth soaked in warm water solution is used to wipe and clean before drying. This is one picture depicting how the manual washing of the instrument has been done. A small clip showing that how the cleaning should be done very thoroughly, and all the visible soiling should be removed, especially in the crevices and all the linings where there is a chance of blood to remain. Then in the event of the COVID-19, when there is a high chance of disinfection and sterilization, automatic methods are very commonly used and they are gaining popularity because the staff, it is protecting our staff from direct exposure to chemicals and microorganisms, and various methods can be employed using washer disinfection, low temperature steam, and ultrasonic baths. Ultrasonic bath is very important and it's very popular these days. This is an ultrasonic cleanser, picture showing ultrasonic cleanser in which the chamber is basically filled with water and detergents, and transducers generate some ultrasonic waves which produce tiny bubbles that collapse and implode. Because of the negative pressure created in this pulls the debris away and away from the surface of the instrument or equipment, and the whole process is known as the cavitation. So disinfection can be done according to the microorganism or the level of contamination to the high level, intermediate level, and the low level. So how we are going to achieve the high level of disinfection? Basically, it's a process that destroys fungi, viruses, and vegetative bacteria, but not necessarily all the bacterial spores, and it requires a sufficient time, contact time is required for the high level of the disinfection. So it can be done by the pasteurization for 50 minutes or the liquid immersion with a 2% butyraldehyde for 20 to 45 minutes, 1.12% of butyraldehyde and 1.93% of phenols for 20 minutes, or hydrogen peroxide and peracetic acid for 25 minutes, or only 7.5% of hydrogen peroxide for 30 minutes. So this is a machine showing pasteurization. It provides thermal disinfection using the heated water, and we can use a temperature of 70 degrees Celsius for 30 minutes, and it is used for breathing tubes, for the sterilization of the breathing tubes, reservoir bags, tracheal tubes, face masks, airway, laryngoscope blades, stylet, bite blockers, and adapters, elbows, YPs, and ventilator bellows. The most common advantage of the pasteurization is that low temperature will not cause any damage to our equipments or as compared to the autoclaving. There are no toxic fumes or residues. It's relatively inexpensive and reliable method of sterilization. The only problem is that equipment treated with this technique are wet and must be dried and packaged, and during the process of drying, there is a chance of recontamination. And as far as the chemicals are there, for high level of disinfection, glutaraldehyde can provide in the concentration of 1 to 1.5% or the 2%, and it requires generally 20 to 30 minutes. And sometimes for the sporicidal action, it may need 3 to 10 hours. Next is the orthoaldehyde and Sidex OPA that provides a high level of disinfection at room temperature. After 12 minutes of exposure, it is sporicidal with prolonged exposure. Minimal odor is there. When hydrogen peroxide is there, it is all bactericidal, virucidal, sporicidal, and fungicidal, and 30 minutes time is required for using 7.5% solution, and 3% solution is a low, can also provide a low level of disinfection. Formaldehyde is formed in both the liquid and the gaseous state and can be used as a disinfectant as well as for sterilization. But nowadays, most of the hospitals are not using formaldehyde because of its carcinogenic potential and pungent fumes. The intermediate type of level of disinfection can be provided by the chlorine and phenol products for a minimum of 1 minute. That is, chlorine hypochlorite can be used and phenolic solutions can be used. Alcohol provides intermediate to low level of disinfection, and it is bactericidal in the concentration of 60 to 90%. So also it can give low in the phenols, quaternary ammonium compounds in 70 to 90% alcohol can give the low level of the disinfection. Quaternary ammonium compounds are low-level disinfectant, bactericidal, fungicidal, and virucidal at room temperature within 10 minutes. So just to see the bacterial properties of this chemical disinfectant, we can see that glutaraldehyde 2% is good for mycobacterium, bacteria, and viruses. Parasitic is almost good for all the microorganism, including the spores. Alcohol is very good for bacterial disinfectant, and hydrogen peroxide is good for bacteria. Chlorine releasing products are good for all, and phenolic 0.6 to 2% is good for mycobacterium and bacterial disinfection. Now we have to know how we can do the sterilization. So sterilization can be basically done by the thermal process, chemical process, sterilization, and the other method. For the thermal sterilization, we can use the steam sterilization or the dry hot air. Chemical sterilization is properly done by the ethylene oxide, that is ETO, or hydrogen peroxide gas plasma, and other agents like ionizing radiation can be used. So just to give you overview, there is a conditioning or heater phase in which air must be displaced from the chamber. This is known as heater. Exposure, that as the time enters the chamber, as the steam enters the chamber, it enters the load to be sterilized and give its latent heat, and this is a process is known as exposure phase. And post exposure requires the item to must be dried before removal from the sterilizer. So the only problem is that with the sterilization is that current standard calls for a steam quality greater than 97% and 3% of the water, and variation in steam pressure may affect the time needed to attain the proper pressure. So basically high pressure, if there is a high pressure in the sterilization autoclave, steam can turn into liquid and packs can become wet. And if it is low pressure, steams can be supersaturated and not able to achieve uniform temperature, and sterilization will not be very effective. So in this chart, you can there is a typical relation set temperature and time relationship and between every cycle. Like for 121 degrees Celsius, 15 minutes is required. For 126, 10 minutes. For 134, 3.5 minutes. And for 150, few seconds are required. So as the temperature is increasing, the time is decreasing. So basically, steam autoclaving kills all bacteria, viruses, and spores. It is rapid, good penetration, economical, easy to use, absence of toxin products, reliable, and material can be pre-packed and kept sterile until used, and they gives no harm to the environment and can be made available in OT. The only advantage is that many pieces of equipment are damaged or subjected to because of this high pressure, temperature, and steam. Blunting and cutting edges metal surface can get corrosive, and there can be a short life of the electronic components. So many studies show that a fiber optic laryngoscope blade shows a decrease in light transmission after a repeated sterilization. So now once the sterilization is done, how we are going to monitor whether the sterilization has been effective or not. So there are basically three types of monitoring we can do: mechanical, chemical, and biological. Mechanical can be done by recording the temperature. Chemical by changing cards and sealed glass tubes and pellets, and they break once the required steam and temperature is attained. And the most important and are the biological indicators, because it contains non-pathogen spore forming organisms that are highly height resistance are used, and if they grow, it means that the sterilization, if they still grow after sterilization, it means that sterilization was not effective. So in this picture, you can see chemical indicator tape before and after. It shows a change in the color, and similarly biological indicators in the form of tubes you can see. So one thing is, though, many of our equipments has this logo, and maybe you have seen in LMA or somewhere. So whenever you see it, it means that the device is only for the single use and should not be reused. And after autoclaving, the another method is dry hot air, although it's relatively ineffective, but it can be used for the items that can be damaged for the moist heat. And it provides better penetration and does not corrode metal and sharp instruments. The typical temperature 150 degrees Celsius for 150 minutes, 160 degrees Celsius for 120 minutes, and 170 degrees for 60 minutes, and 180 degrees Celsius for 30 minutes. So very commonly employed is the gas sterilization, that is ethylene oxide, that kills the microorganism by the alkylation of the proteins DNA and RNA. EO is basically colorless poisonous gas with a very sweet odor, and it comes in the hospital in cylinders, cartridges, or ampules. It is flammable in concentration of 3% or greater. To deal with this, the manufacturer just mix it with carbon dioxide or hydrochlorofluorocarbons, and it turns to be the mixture to be 12%. At 12%, it retains its disinfection property and becomes inflammable. It does not require high ETO. For ETO, you don't need not to apply high temperature and pressure, and ETO kills most of the bacteria, spores, fungi, and viruses, and it can also penetrate into crevices through permeable ducts. So the process of ETO depends on 4 things. One is gas concentration, temperature, humidity, and the elapsed time. For gas concentration, 450 to 750 mg per liter are commonly used. Temperature of 38 to 60 degrees Celsius. Humidity of 40 to 80 degrees Celsius of relative humidity is required. And elapsed time between 1.5 to 6 hours can be used, and it can be increased up to 12 hours depending on what type of microorganism we are dealing. This picture shows the ETO chambers. So it's reliable and can be used on a wide range of items, and damage to most equipment is minimal. Item can be packed before sterilization and can be stored for a very extended period of time until use. But definitely everything cannot be everything has to come with some sort of complication. So acute exposure of EO can lead to upper respiratory complaints, eye irritation, headache, blunting of taste, metallic taste, nausea, vomiting, diarrhea, increased fatigability, memory loss, dizziness, chest comfort, difficulty in breathing. With peripheral nerve damage, even the neurological signs and symptoms are observed if the exposure is more than 6 hours. Corneal burns, cataract can happen. An effect on central peripheral nervous system is this in irritant respiratory infection, anemia, impaired cognitive function. Also, mutagenic and carcinogenic activities have been found in EO, and it may affect the reproductive health. Another thing we are can use the hydrogen peroxide gas plasma. It is basically high reactive free radical. It destroys microorganisms at a very low temperature of 35 to 45 degrees Celsius over a relative short time of 75 minutes. It is useful for the heat labile materials, and its limited ability to sterile medical devices in humans. Ionization radiation can also be used using gamma rays. It is ideal for sterilization of pre-packed, and some materials may undergo degenerative changes, making this material unsuitable for re-sterilization of hospital equipment. The most upcoming and is the gas plasma sterilization, and in the coming years or time, it may displace the ETO. It is highly ionized gas containing ions and free radicals capable of inactivating the microorganism, and particles can definitely diffuse through packaged material in the chamber. It's non-toxic, dry, and low temperature sterilization with cycle time of only 75 minutes can be used. Just to compile, we can see that the face mask, airway, tracheal tube should be single patient use. We should use it. LMA should be also be used sterile and should be single use. But the manufacturer sometimes may recommend 40 times a maximum to be used. Breathing system should be disposable or it should be changed weekly, provided we are using new bacterial viral filter with every patient, and definitely change soon if visible contamination is there. Especially BUGs, they require, if we are reusing it, it requires high level of decontamination or disinfection, and we can use maximum to the 5 time. Laryngoscope blades and handles should be used handles should be disinfected regularly. BP cuffs and everything should be cleaned at the end of the day whenever there is a visible contamination. Now comes the operation theaters and sterilization and disinfection. Definitely cleaning is the most important in maintaining the operation theater cleanliness, sterilization and disinfection. And we should use, floor should be cleaned with the vacuum and cleaners and wet mops. We should not use the brooms because it can increase the bacterial flora or may dislodge the bacterial flora. It has been found that even a simple detergent can reduce the flora by 80%, and if we add the disinfectant, and it can definitely reduce to 95%. So if you see that the roof can be disinfected by 2% bacilloid solution once in 3 months, walls with the daily twice, floor daily twice, refrigerator can be defrosted and cleaned with soap and water weekly once. Sink, soap, water, and we can use sodium hypochlorite daily once, and OT furniture alcohol-based spray daily once, or AHU pre-filters can be disinfected with water once in 3 months. So initially we were disinfected this with the formaldehyde gas. It just inactivates microorganism by alkylating the amino acid and sulfurdyl groups of proteins and bring nitrogen atoms of purine bases. But because of its carcinogenic potential, OSHA has just limited an 8-hour time weight average exposure concentration of 0.75 mm. And fumigation of OT using formalin is also not recommended by nowadays CDC. The upcoming is the bacillocydricin, that is neutral benzyl alkyl dimethyl ammonium chloride and dimethyl ammonium chloride. It is new and effective. It's very excellent cleaning properties, and shutdown of 40 for 24 hours is not required, and it can give a complete asepsis in 30 to 60 minutes. Another method of fumigation newer are LD-con, permanganate method, paraform, Viricon, which is viricidal, bactericidal, and even fungicidal. So we can also do fogging, and that is nebulization of a disinfectant in a seated patient room, and followed by wiping of the residual fluid from the surfaces. But nowadays, new chemicals are used for fogging, like glucoprotamine, formaldehyde plus glutaraldehyde, hydrogen peroxide, and silver nitrate. Formaldehyde solution chemicals should be avoided. And if you see, glucoprotamine, hydrogen peroxide, and silver provides broad spectrum microbial action, and 30 minutes to 1 hour is required. Also, they are non-irritant to skin. And glucoprotamine can be used at 1%, and hydrogen peroxide with silver nitrate can be used as a 20% of the solution. So in this era of time of COVID pandemic, we should always think every equipment should be clean and disinfected very judiciously and very seriously. And one must try to use 70% of isopropyl ethyl alcohol within 1 minute of exposure, and followed by dipping of 1% of sodium hypochlorite for the 30 minutes. And after that, depending upon the type of viral load we are using, we can choose our disinfection or sterilization method. So at the end, I want to say that all anesthesiologists have an active role to take precaution against the transmission of infection, and all equipment should be considered contaminated, and appropriate disinfection based on degree of risk of infection should be used, and every hospital should have a guidelines on this. And last is that last but not the least, self protection is also very important. We should always take care of our own self. And At the end, thank you. Keep calm and stay sterile.
Oh, okay. Thank you, Ridhima, for a very, very elaborate lecture on how sterilization and disinfection should be done for most equipments in our setup. And it is all the more relevant, especially after the present pandemic. And you had made slides on it to show how you protect yourself and all the equipment, especially the standards quite changed during this pandemic. So many things were disposed of initially, and sanitization has become a word not just for the anesthetists, but also for the common people. So thank you so much.
Thank you, ma'am. Thank you for this warm welcome. And I really miss you all the time in our OT.
Yeah.
And I try to collaborate everything because it's a very vast topic. And as you know, we are not very aware and into this, but still I try to cover every genre that the PG student should know.
Right. All I would like to say for the postgraduate is that, there are so many methods of doing it. One should be familiar with whatever she's given a whole plethora of, methods of sterilization and disinfection. One should be familiar with whatever the practice is in your hospital. And somebody may be having ETO2, others may be having plasma sterilization. So you should be aware that what is the best way sterilization happens for your hospital. So there are some questions.
Yes, ma'am.
Okay, so one is saying that should ideally LMA be reused? If yes, how can it be disinfected? I think Ridhima, but
Actually, if you ask me, ideally there is LMDs should not be reused, but still the manufacturer says that you can use it, reuse this 40 times. Before you clean, you should wash it with the soda bicarb 8 to 10% just to remove the secretion. And cleaning is very important, as I've already shown in my video. And most important recommended method is autoclaving at the temperature of 134 degrees Celsius. Increased temperature should never be used, and cuff should be deflated, because if there is air in the remaining in the inflation line, then it will inflate the bulb during autoclaving and might cause damage to the instrument like our LMA. So, and another thing is chemical disinfection is not recommended because there are case reports of causing laryngitis and pharyngitis. And so autoclaving is a method if you really want to reuse this, and 40 times is the maximum.
Yeah, I think let's all be frank, even if the manufacturer says this, in the Indian circumstances, there's hardly a center which is actually throwing off their proceeds, excepting when you had to use it.
For years, ma'am.
You had to use it here.
For years.
Yeah,
Years, yeah, right, you're right.
Until unless we find a leak in the interop.
Those are the first different. Okay, then there is one, I think it says how gravity displacement and steam flush pressure pulse type of sterilizer work. Well, I don't know whether Ridhima
Actually, what happened, there are autoclave. It's a method of autoclaving in which air should be evacuated. So in gravity type, whenever the steam enters, it displaces the air from bottom of, drain or port, and it remains open until the temperature of the steam entering and the drain remains the same. It is just to make sure that the steam autoclaving has been done properly and the temperature is attained. So it's like gravity dependent. Air is displaced downward and steam is entering from upward. So in this like that. And another is that steam flush that depends on frequent pressure and vacuum. So in this another one, there is no creation of vacuum, and it is much faster than the gravity steam autoclaving.
But I really appreciate the postgraduate who's actually thought in such detail about how stuff like that. I put that at the end of the day also.
I know.
Good. I think it's a good thing.
There's a quick announcement.
One
for
more
the
question is there now.
Please.
There is a quick announcement for delegates that the quiz in Google form is already in their mails, and the link is open now, 6:15, and it will be open only for 15 minutes. And after that, the responses will not be taken. So kindly do the quiz. And the feedback form is also very important for us to appreciate all the faculty who's put in so much effort to make the PowerPoint, which are PG oriented, and distribute among, they have given their PPTs and write-ups also to be distributed in the delegates. So the feedback is also very important, and the quiz form will be the fastest and the correctest answers.
One more question is there. If we are suspecting prion infection, how can it be disinfected?
Actually, very nice question. Prions infections, or if you are suspecting that this is the most resistance one to deal with, but still we can do incineration or autoclaving. We can do at temperature of 132 degree or for 1 to 4 hours, or 250 degree Fahrenheit for 60 minutes in gravity sterilization. So this is the only way if you are suspecting prions infection. Otherwise, or other thing like glutaldehyde and ETO will not be successful. So we have to do the instrumentation. High steam autoclaving is required in this prion infection, especially prion, because they are most resistant to deal with.
Okay,
thank you so much, Dr.
Thank you. I again thank Dr. M.D. Kaur ma'am and all the team. You have a wonderful show, and I hope everyone will be gaining so much. Thank you, Suniti ma'am. Again, thank you, and we wish we'll meet as the corona settles. Keep on settling.
Yeah, I know, as the pandemic goes. Okay, thanks, Ridhima, and thanks to both the speakers. And again, I would also like to first thank the organizers to invite me as a chairperson. And I must say that is a very well organized, virtual PGSM. This is the first of its kind and very well done. So thank you so much.
Thank you so much.
Thank you.
Thank you. So see you tomorrow, all the delegates. Please be on time at 8 o'clock.
Dear delegates, we'll be sending the quiz now.